Thank you, one and all. As Dr. BNC is known to most of us, but he was legend of legends and teacher of teachers, and rightly called as the banyan tree in IVF, and he has imparted excellent knowledge with so many papers and publications. So we today pay respect to Sir, and we start our session for REPLETE 2022. May I request the managing committee members, Dr. Madhu Juneja, to take over as her MOC. Welcome, Madhu.
Very good morning to dear teachers and colleagues. I welcome you all after 2 years of lockdown period or the COVID era to the physical conference and making an installation ceremony of our president, Dr. Parag Biniwale. We have our first talk as preconceptional care, and I would want to welcome Dr. Uma Wankhede, Executive Vice President for the conference, as well Dr. Vaishali Chauhan, Chairperson for the Perinatology Committee. Ma'am, please come on the dais and take over the.
A very good morning. Myself and Dr. Vaishali welcome you for the first session, the first program, that is the Preconceptional Care Panel. For this, I would like to welcome all the panelists. It's not coming. Hello? Yeah. Thank you. I would like to welcome all the panelists on the dais, Dr. Madhu Juneja, Dr. Shilpa Joshi Chitnis, Dr. Aparna Sambus, Dr. Sneha Trivedi, Dr. Sagar Bam, and Dr. Leena Patankar. Please come on stage. Welcome everyone. Please could you each introduce yourself in 2-3 lines.
I am Dr. Madhu Juneja, and passed out student for Bharati Vidyapeeth, practicing as a consultant with Cloud9 Kalyani Nagar.
I'm Dr. Sneha Trivedi, currently practicing in Noble Hospital, Hadapsar, and my private clinic in Subhash Nagar.
I am Dr. Shilpa Chitnis Joshi, practicing in Kothurud. I write on social media to create awareness in women's health.
I'm Dr. Aparna Sambus. I'm at Mira Hospital and KM Hospital.
I'm Dr. Sagar Bam. I'm practicing on Nagar Road.
Dr. Leena Patankar, practicing in Pune opposite Sarasbag.
Thank you. Welcome all for the panel. So the panel is on preconceptional care. Initially it was thought that to decrease maternal mortality and fetal mortality and morbidity, we should have a good intranatal care. Then the concentration was on good antenatal care. Then the concentration went on the inverting the pyramid of antenatal care, and now it's preconceptional care. So the aim of preconceptional care is to promote the health of woman before she gets pregnant in order to reduce any preventable adverse pregnancy outcomes both to mother and baby. So actually it should be that every pregnancy should be planned. But I don't think this is happening. What are your views about this? Anyone can answer. Are you all doing preconceptional care or sometimes?
I think it's not happening the way it should be, but of course the awareness amongst the couples is increasing. So over the years we are getting more and more couples who want to plan their pregnancy, and we do get couples, not only the women but couples together who want to plan pregnancy, and they want to know whether everything is all right with them so that they can plan.
Anyone else? Or
around 10 to 15% only are coming for preconception
care.
Actually it should increase more. Only those who have probably history will come for counseling if they have thalassemia or some heart disease. But no, people should still be coming more often for preconception.
So I think, you want to say something?
Yeah, the senior family members generally don't allow, especially in lower middle class or lower class, the elders in the family don't allow women to go to a gynac even in early pregnancy, let alone before pregnancy.
So what you all are saying is that in fact it's still the concentration of preconception care in India is not so much as abroad, and I think we all should try and increase this. And mostly pregnancies are not planned, so that's why they cannot be pre-planned, you know. So that could be one of the most important reasons.
Yeah. Am I audible? Mic
No.
Yeah, am I audible? Yes, first of all, I would like to say thank you, Dr. Parag and the entire team, and it's so wonderful to be here Saturday morning after such a long hiatus post-COVID. We are free to meet esteemed panelists and to conduct a panel with none other than Professor Dr. Uma, who is the mastermind of the subject. So coming back to our subject. Routine preconception care, just like all of you said and Dr. Uma said, there are so many barriers. What is really required is not being done. Like we have antenatal protocols. You know, our protocols are set. Do we have preconception care protocols? No, we do not have. So maybe that is a thing which should be implemented. And long-term studies, RCTs have shown that women who undergo preconception care definitely have a better pregnancy outcome. So just for discussion, suppose a young girl, a young couple who wish to conceive, 28-year-old, nothing high risk about them, young couple married since 2 years and now they want to start a family. So what are the routine investigation tests, counseling that you would like? We'll start with Madhu.
Ma'am, they should be actually told the peak of the reproductive age is between 20 to 30s. We should not delay our pregnancy beyond 30-35, first and foremost. Despite being into our professional career, we are too occupied. There is importance of family planning as well. We do measure their BMIs, we do measure their weight and tell them how healthy they are. Of course, there is a bundle of tests which has to be performed on them, counseling them the importance of each single test, which includes the thyroid checkup, pre-diabetic counseling, and you know, people are there who are even confused if they are AB positive or A positive. So there are many things which they should be clear prior they actually plan a pregnancy. Their blood group plays a role, the thyroid status, of course managing with the proper nutrition and diet is to be given an equal importance. I always tell my patients, you are your own doctor, you barely need me. If you lose 10% of what you are, you will treat yourself. You may not need your doctor.
That's a good message, Madhu. Dr. Sneha, you want to add anything?
Yeah, in addition, we should also counsel her regarding the importance of starting with folic acid supplements pre-pregnancy, at least 3 months prior to pregnancy. And also during her routine checkup, other than her vitals, also screen her for any vaginal discharge or like sexually transmitted infections. Also explain her the importance of pre-pregnancy immunizations like routine, the varicella, MMR vaccinations, or even the influenza, we can give it pre-pregnancy as we are giving it during pregnancy.
I generally have started doing B12 levels nowadays because I realized many of the women, even if they are eating non-vegetarian food, they are having severe B12 deficiency. And after she becomes pregnant, it becomes difficult as it can lead to congenital anomalies. And thalassemia screening also is important. And HIV, HbSAg is something which is neglected by couples, though they are advised to do it before marriage. So that also should be done.
And important in the immunization would be to see that they are rubella immunized and also hepatitis B.
Yeah, and talking about the routine preconception care, there are various guidelines. The American Academy of Pediatrics and ACOG have given many recommendations of how to go about assessing the patient, right from the history, the patient medical history, obstetric history, family history, genetic history, immunization, infection, nutrition, correct BMI, and so on. So there's this entire checklist and we need to go through each one of it and rule out that there's probably this predisposes to some high risk factor.
Yeah.
Yes,
Also, the history of previous pregnancies, if it is important, that is also important because it will help in guiding us in managing this pregnancy and avoiding many other complications.
I think history of having a pet also, that's also important.
Aparna, you want to say something?
So I wanted to add about detailed family history, history of consanguinity, which generally they will not come out with. So that is something we need to ask them about.
So this is what we do in a normal pregnancy. But generally people, as Sagar said, generally if they are normal, they generally don't come so often for preconceptional care. But if they have any problems, they do come. So let's see the different problems.
This is 24-year-old Naligrada, which is a known diabetic patient, married since 1 year. And she has a blood sugar level, PP of 242 mg/% and HbA1c 11.5. And she is interested in pregnancy. So we'll start from there. Leena, what would you say to this patient?
She is just 24 years old and married 1 year. So I think we have enough time for her to, control her diabetes. The very fact that her blood sugar level is as high as 242 and HbA1c 11.5, that she is negligent about her health. Maybe she is a defaulter also. So main thing I would concentrate on is to counsel her is how important her health is, because diabetes is one thing. Whether we have multidisciplinary approach, which we will definitely have, but it is her own health which she should and she can take care of. So she has, if she is obese, along with it, she has to reduce her weight, she has to get her HbA1c in control, and she should postpone her pregnancy till her HbA1c is at least 6.5%. Till then she should defer from pregnancy, because she will have, not only if the sugar is very high, then during the first weeks of organogenesis, then there are more chances that she will have birth defects, congenital anomalies in the baby, and also high chances of abortion. Also, if she is not taking any, if she is already on antidiabetics, we may have to change it to insulin, because she is she should have better control. And likewise, the counseling is very, very important. So I will sit here with her and counsel her so that she digests an importance of her own health.
Yeah, well said, Leena. And especially when you counsel about how teratogenic high blood sugar is, and then the congenital anomalies that are going to come up with such high blood sugar levels. So effective counseling, like you said, is very essential. Anybody wants to add anything?
So we can look for complications for the other systems like fundoscopy, kidney function tests like creatinine, so that we know whether those organs are affected or not.
In these cases, I think it is important to take a history whether it is a type 1 or a type 2 diabetic, because type 1 diabetic would be those who would have maybe vascular complications, renal complications, and the prognosis of pregnancy would be a little worse than a type 2 diabetic. So I think it is important that we take that history from these patients.
So you want to rule out any major vascular damage. You want to reduce the weight of the patient.
A 2D echo before conception.
Yeah, so the heart, the lung, the kidney, the retina, all these should be checked preconceptionally so that she'll be in optimum health before she gets pregnant. And what Leena said is very correct, that the congenital abnormalities are high if the HbA1c is more than 6.5. So you'll ask her to lose weight and you'll shift her to insulin and get some time so that she learns how to start using the insulin by herself and her HbA1c comes down to 6.5. Our second case.
Second case is a Nali gravida with history of grand mal epilepsy on sodium valproate since 10 years, and now she wants to conceive. So what would be your advice? Let's start with Dr. Sagar.
So we have to take a detailed history. When was the last time she had the seizures? If it is more than 3-5 years, then maybe you can stop. Whether the EEG was done and whether the EEG was normal or not. And we have to explain to her that all anticonvulsants will have some congenital defects, and if there are no seizures for the last 3 years, maybe she can stop it and then start folic acid.
Anti-epileptic has congenital effects, but the problem is that if you stop anti-epileptics, the woman may get convulsion, which is even worse for the mother. She'll get trauma, and the baby also gets distress. So you have to balance between the two. So you will of course take a liaison with a neurologist. You will not manage alone. So what you will counsel?
So I think what we need to tell the patient is to listen to what a neurologist says. Only because she's trying for conception, she should not suddenly stop any of the anticonvulsants that she's taking. Because if she gets a seizure, then we need to increase the dose, or there can be polypharmacy, which can be even worse.
Worried they don't take medicine.
That is what we really need to counsel them, and if possible, maybe switch to a drug which is a better safety profile as far as teratogenicity is concerned.
Correct. And folic acid should
5 milligram is required because we know that they cause neural tube defects.
So what is the safe phase, like patient is epileptic on anti-epileptic drugs? So when do we say like, okay, now it's safe for you and you can go ahead and plan the pregnancy?
When she is on one monotherapy, one drug, either lamitrazine or tropicamide, they are better drugs. Yeah. And she is well controlled on those drugs. She is not getting epileptic. We have given vitamin supplements. And now she is stable mentally also, because many parents have this anxiety that will it be inherited in the next generation. So there is not much we can assure her about that, but then basic counseling and vitamin supplements, and then she can go ahead with the pregnancy plan.
So the close liaison with the neurophysician is very essential, and get a written fitness, yes, this patient can go ahead with pregnancy. That is essential, and the patient should follow up. Many a time we send them to the neurologist and patient comes back already on anti-epileptic and pregnant. So we are in a very difficult situation, difficult for the patient and baby also obviously. So a multidisciplinary management, active management is important.
And the newer anti-epileptic drugs have a better safety profile. We don't know much about them, so the neurophysician will guide us in managing the patient. We come to the third case.
30-year-old Nali Gravida, a known case of chronic hypertension, wants to conceive. She is presently on telmisartan and thiazide diuretic. Her BP is 130/90. So, Dr. Aparna, yes, what would be your management for her and advice?
Seems to be 130/90, which is quite controlled, but telmisartan is something she cannot take in the preconceptual period. So we need to switch to antihypertensives, which will have a better safety profile. Maybe switch to methyl-dopa, labetalol, or Nicardia. In her case, I would like to do a renal assessment, a cardiac assessment, preconception, because she's a known chronic hypertensive. So we need to know her cardiac status as well as her renal status, along with the other workup also.
So stopping these drugs is of utmost importance, ACE inhibitor or ACE blockers, which may be teratogenic, switching over to a good antihypertensive, and of course, like you said, ruling out any underlying cause for hypertension, whether it's renal or whether any other cause.
Even if she's on a statin, it should be stopped before pregnancy. And she should be well counseled that this pregnancy could have many complications, like preeclampsia occurring along with the hypertension, IUG or abruption preterm, and that she should be having close follow-up with us if she gets pregnant.
Unfortunately, clinically, I think all of us have gone through this, that patient comes to us and then we diagnose, oh, this was a pre-existing hypertension. So I hope our patients come to us with known case of hypertension and whom we can counsel. Yes.
I have one more query here, that I realized in some patients that labetalol or even alpha-dopa or amlodipine doesn't really control the BP that well. So for a patient, I had to put her again on telmisartan, and then decided when she becomes pregnant, we can switch over, because otherwise BP control is not good and labetalol is quite costly, so patients don't take it. Then BP is not controlled. So ultimately we might have to take that decision, that put her on something like that and then change over when she becomes pregnant.
Yeah, that's a tricky situation. Yeah. I think, I'm sure most of us have encountered it. Yes.
You have to, compare the efficacy of the drugs with the safety profiles. So, and cost, patients, if they can afford, they do go for the baby. If you say it's good for the baby, I think cost is not an issue.
And when the patient comes to us pre-conceptionally, then we have all the advice to give her about nutrition, weight loss, lifestyle change and all that, weight reduction, and but they should reach us pre-conception. That
there
again
is one
is
more
important.
thing. I feel that many times the patient don't accept that they have hypertension.
Yeah.
They will come to some quack somewhere where they don't know how to take BP. The BP will come normal. Then they'll come and argue with us that I took BP so many times, it is normal. Why are you saying it is high?
Or after
That
seeing
is-
you, my BP has gone up.
Yes. When I come here, my BP shoots up.
My daughter-in-law never had BP.
It's because of you.
Yeah, that. We come to the fourth case.
Fourth case is a 23-year-old Nali Gravida diagnosed as a case of severe mitral stenosis, severe PH, and she underwent prosthetic heart valve replacement 1 year ago. She is presently on warfarin tablet 5 mg daily. Shilpa, would you like to take this?
Yes, this seems quite severe, and I would actually like to counsel the family first that this woman is a very high risk for pregnancy, and if something goes wrong, there are going to be lots of complications, and if something like that happens, even she may lose her life. As a gynac, we are not supposed to be judging or advising something like that, but I think the family should be made aware that this woman can lose her life in pregnancy. And about warfarin, she has to be shifted on heparin. For first 3 months, she has to be on heparin, and then again maybe we can continue heparin or switch over to warfarin again. She has to be under continuous monitoring from the cardiologist, and she has to be advised lot of rest and all the vitamin supplements and rest of the antenatal care, and we have to look out for complications, and cardiologist will of course monitor, but we have to make sure that she doesn't land in many complications.
Here I would just like to point out that she had severe MS and PH, but she underwent the valve replacement. So cardiac status is much improved now. So the point here is she is on warfarin. Yes. Like you said, we need to change the drug, especially in the first trimester. We have to put her on heparin, and we have to change the drug. As we know, warfarin is highly teratogenic.
We should shift from warf to heparin preconceptionally, ideally, so that because action of warfarin is over a period of time, so you should give some time before she gets pregnant. Because as you all said, there is a very bad warfarin embryopathy. The warfarin interferes with the protein that modulates bone and cartilage formation. So the baby has a condition of chondrodysplasia punctata, where all the bones get broken in utero and baby may become deformed. And there are many other aspects of this syndrome. And the problem with heparin is that heparin is not a good anticoagulant as warfarin. And so there could be thrombosis of the valves and all that. So it needs a lot of liaison with the cardiologist. So patient should go with us and the cardiologist before she gets pregnant, so that she gets a good dose. And as you said rightly, we should switch to heparin, or better is you could give heparin in the first trimester, warfarin in the second and third trimester, and heparin at term, so that you get efficacy as well as safety.
This is such patients keep coming to us nowadays. It's very common. Software engineer, married since a year. She's 36 years old, wants to conceive. So what would be your advice to her? Sneha.
She's already 36 years old and she's married since 1 year. So first of all, I would like to discuss with her regarding her plans for pregnancy. And if she is planning to delay her pregnancy, I will be counseling her to plan it as early as possible, since there are some problems which can be encountered with advancing age. As in, when the age is more than 35, there is the ovarian reserve reduces, so chances of conception reduces. So she should start as early as possible. Again, if we should look out if she has any other underlying problems like diabetes, hypertension, and they should be corrected well in advance. if her BMI is on a higher side, it should encourage her to lose weight, because against advancing age and other associated illnesses can increase her chances of developing gestational diabetes or hypertension or the risk of cesarean in pregnancy. So she should be advised to again start with folic acid, which is utmost importance to reduce the risk of neural tube defects. And like once she tests positive, report early.
Yeah, very right. Leena, as ART consultant, we come to you. So what is your experience in your practice? 36-year-old, 38, 40-year-old, nowadays 42-year-olds also come. So what is your...
If she's 36-year-old and she wants to conceive, that is a good news. But then I would add AMH in her, because I will not wait for her to conceive naturally. Maybe it depends upon her AMH value and the AFC count. So many times it happens that we see a low AMH, especially if it is less than 1.5, it is very alarming. And in that case, if it is associated with low AFC, then I will not wait for her for natural conception. I will ask her to undergo treatment associated with the basic parameters of husband as well. So here we do have very less time, because the aim, if she wants to conceive, the aim should be, to conceive with her own gametes. So that takes the priority in this case. And sometimes it happens that the AMH AFCs are so low that I have to advise them to undergo ART. We freeze the embryos and then take care of her weight loss, her comorbid conditions and things like that. And we always can, fall back upon our freezing protocols. So the treatment, it has to be treatment and counseling associated, together. And of course, it has to be aggressive counseling and aggressive approach, I would say, in higher age.
Just an opinion of each of the panelists about elderly patients whom you have managed. What are the adverse pregnancy outcomes that you have seen in your practice?
Abortions is the main thing because of aneuploidies that they encounter, we come across. Then the complicated pregnancies is which we have to deal with the PIH and diabetes. These are the most two common things.
In your practice, something commonly...
So ma'am, they would come to us telling if I conceive, it's going to be a healthy pregnancy. They want a guarantee from us. Yes. We have to clearly tell them the importance of age, that it's going to impact the chromosomes and it's going to give them prematurity, abortions. We can only screen your pregnancy doing FTS screening and giving you, we can give you an 85% assurance. But of course, the chances of hypertension, diabetes, prematurity, landing up into C-section, etc. is bound to happen eventually. We never know that.
Right. And like Leena said, many a times patients say, I'll go and I'll lose weight and come. That never happens. So,
if she had to lose, she would have lost it by now. If she had to lose, she would have lost it
by now. So, not delaying pregnancy for weight loss or for any other reason is the best thing. Yeah. Yes, sir.
So, not to delay childbearing, as you said, and folic acid will be started. The next very common case.
This is a 24-year-old nulli gravida with BMI of 35, and she wants to conceive.
So here we have time to tell her to lose weight because her age is less. So we can actually work on Dr. Leena to counsel her and tell her to have weight reduction first and then come for...
Send her with Leena for cycling.
Yes, and actually start her on
and diving. Leena has just come back from diving.
But here, on serious note, if a 24-year-old woman is counseled enough and nicely for weight loss, then you don't have to counsel her any other time for weight loss. She will always maintain. She just has to be convinced about that her weight loss is going to be advantageous for her in so many ways. That is my experience, and she may not need even treatment for anything. So
absolutely.
That I agree, and I have experience, and I do practice.
Tell us your experience of the maximum weight you have encountered.
135 is what? 135 kgs.
110 averagely, yes. 130 of even.
Yeah, nowadays it is proved that intrauterine environment is the main factor which will decide about the health of her offspring when her child grows up. So I find that that is quite a strong motivation for a woman. When you tell her that if you don't lose weight and even if you become pregnant, because some women have argued with me on social media that I was 98 kgs and I conceived. When I delivered, I was 110 kgs, what you are saying. So her child is going to have lots of problems in future. So if we counsel them like that, that your child will have a health problem, maybe that becomes a strong motivation.
Yes, Shilpa, you do write very inspiring and educational articles and creating social awareness. So that is, I think, the need today of creating an awareness and educating these women about preconception care and what is to follow.
And there is this trend going on that my body, my pride, you are doing body shaming. I was actually accused of body shaming when I tried to tell them that obesity is such a big problem. So we have to put up counter arguments on so many fronts.
I agree with you.
They don't
Shilpa,
really like it.
Absolutely, especially the youngsters, the early 20s, even the PCOS patient. Lina's and our children are interns. So one PCOS patient had come, I was talking with her about weight loss. After she left, my daughter said, "You can't say that, that's body shaming." I said, "That's not body shaming."
So
this is
health
the gynecologist advice.
So they should understand the difference when the doctor is telling. There is difference between body shaming and strong medical advice. So that is not happening.
So maybe 10 years ago we would tell patient, please lose weight. But now you have to measure your words when you tell them this.
Yes. So the body shaming is a social aspect, but we have to deal with the medical and the physiological things.
So we ask them to lose weight and we give them folic acid because, as she said, the baby could have congenital abnormalities, and if the weight is too much, then of course use of a bariatric surgeon would be helpful.
This is a case, 7th case now, a 32-year-old patient with history of chronic glomerular nephritis being treated since 3 years, and she wants to conceive. Her creatinine level right now is 1.5 mg/%. So anyone can take it.
So she has moderate CKD, chronic kidney disease. Yeah. So we have to maybe, first thing is, we would have to consult her and associate with the nephrologist whether she is okay with her. Maybe her glomerular filtration rate we have to check additionally. Whether she has additional hypertension associated with it is what we have to check. And then she can go ahead with plan with pregnancy, but of course if she can, control her kidney status better in a better way. So
when because will you contraindicate pregnancy?
Moderate can conceive, but with very high risk of IUGR and IUDs, because the nephritic element will increase, and if it is severe, then it is contraindicated, because in severely impaired kidney disease, it is not advised to conceive, because that will cause worsening of the functioning.
Yes.
Right, rightly said. You wanted to add something, Shilpa?
No, again, I would like to, of course, counsel the family, and with the guidance of nephrologist, we can go ahead with this pregnancy. But it is going to cause lots of problems with hypertension, abruption, and all the other things. The kidney function, though it is normal in the beginning, it may worsen with the pregnancy, because pregnancy will load up the kidneys further. So it would be a very tricky and high risk situation for the woman.
So when you talk about renal disease in pregnancy, it could be due to many reasons. It could be autoimmune, genetic, could be acute infection, or could be even renal transplant. So this is a quick question for all the panelists. You can just say yes or no. This is a patient who has undergone renal transplant 1 year ago, and she is stable now. She wants to conceive. She's keen to conceive. Her age is 29 years old. So would you advise conception, yes or no? That's all I would, that's all I want. Yes, Lina?
Yes, with due risk.
No, maybe no.
Dr. Sagar says no. Aparna? Aparna says yes.
Yes, after lots and lots of counseling.
Shilpa says yes. Sneha?
Yes.
Yes, after counseling
Yes.
her regarding the
Madhu? Yes. Uma madam?
Of course, after asking the nephrologist. Because
Yeah, so the question why I asked you here is when a patient undergoes renal transplant and if she is stable and if the nephrologist says yes, go ahead, you can go ahead with due counseling that with the advance in the pregnancy, the patient's pre-existing condition is going to deteriorate and any point of time her renal condition status is going to deteriorate. Knowing this only and knowing only after this should you advise patient and go
More
ahead.
than that, their monetary condition deteriorates by the time they come to us.
And yeah, like
I
we
had
said,
a
patient may need to be put on dialysis. Now imagine a pregnant patient undergone renal transplant, undergoing dialysis. This is a nightmare. So that is why I asked you this question.
as Lina said, the pregnancy is contraindicated in severe renal disease when the creatinine is 3 and more. Most of these patients, they are hypertensive, so that worsens the prognosis. And enalapril is the drug of choice in renal disease because it's good for the kidney. So that's contraindicated in pregnancy. So we must ask the nephrologist and change them to better pregnancy-friendly antihypertensives. Statins have to be stopped. And very important is all these patients, they can get preeclampsia, means high risk. So they have to be counseled that to keep coming regularly. They go for their Dopplers and aspirin at 12 weeks. And it's a very guarded pregnancy. So she should have only a single kid maximum or a very small family and not have many kids. Anything else you want to say?
Maybe now it has gone into a lot of controversy, but maybe if the patient is affording, maybe surrogacy would be a better option.
No, I had a patient who came for IVF choice. She's donated a kidney to the husband, everything being okay. She came, she decided, but she left me because of many other, their family issues, their monetary and their mental issues come into the picture. Surrogacy.
Yeah, a lot of familial burden is there, like you mentioned, economic family, emotional burden is there. I had such a patient and she was keen to conceive, but after 6 months when she came to see me, she said, my husband has left because of the family and the burden and the monetary burden. So it's very, not a good situation. Yeah. This is case 8, a 22-year-old nulli gravida, known case of SLE, and she wants to conceive. She is on enalapril and taprednisolone. So when you advise a patient of SLE regarding conception, what are the things what you would like to advise her?
Yes, SLE is sort of a tricky situation because all of us have very less idea about SLE. So obviously the immunologist and the specialist involved will be guiding us in this case. Now, as we said, enalapril has to be stopped because it can lead to problems in this woman. And her SLE might worsen during the pregnancy. And as we know, all the autoimmune diseases, the patient has high risk of abortions. So, and when autoimmunity is at work, the patient might have all the other cardiovascular or thromboembolic disorders also. So overall, it becomes a high-risk pregnancy. So has to be monitored under the immunologist and physician guidance.
So can she go ahead with pregnancy or no?
I think we need to evaluate the patient. We need to know the kidney status, whether there is lupus nephritis or kidney status involved. And most of the patients will result in a live pregnancy. So explaining them the risks associated with SLE, they can go ahead with the pregnancy, provided the kidneys are normal and all the pre-workup is fine.
Right. So if it's
so
a
the
mild,
presence of antibodies is important, anti-RO, anti-LA, that is SSA and SSB. So if they are there, then there is more risk to the fetus. So that is also to be counseled. And SLE does flares. I have handled only one patient of SLE with pregnancy, but it does flare up. And it is the counseling, and it's very tricky because, as Shilpa says, we know very less about SLE. So
it's a tricky situation again, but it's supposed to be the commonest autoimmune disease, though we don't see it very commonly here. And if it's a mild SLE, then maybe patient can go through the pregnancy, entire pregnancy uneventfully. But like Lina said, there are SLE flares. and that can deteriorate the maternal.
And in severe cases, this is another case or situation where we may have to advise surrogacy in these patients.
And the presence of antibiotics, antibodies, SSA, SSB, when they go to the baby, when they transferred, it causes neonatal lupus. But the good thing about this is the baby recovers fast. Recovery of the baby neonate is fast, but the mother's condition does deteriorate.
Whose fetal heart used to be only 40 antenatally. Dr. Lakshmikant was the registrar at that time. And I remember that we had done her section for some obstetric reason and immediately shifted her for pacemaker to Dinanath Hospital. Immediately, I mean, as soon as the baby was born, it underwent a pacemaker. And the baby is fine now, you know. So there are lots of issues, and the problem is that patients, sometimes we don't know if they have SLE, because when they come to us, they may not have, may not be knowing also, you know, some patients. If they're already known, then of course they'll consult a rheumatologist and us, and pregnancy should be avoided if there is pulmonary hypertension, as Leena said, renal disease and interstitial lung disease. And the antibodies are very important because they cause fetal heart block and neonatal lupus. And if she has APLA antibodies, then the patient has all the problems of APLA. So all those should be looked into preconceptionally so that we diagnose her and allow her to have the most important thing is pregnancy should not occur at least for 6 months of remission. Patient should have no problem. But most of the patients do have hypertension. Patients should be given folic acid, and preconceptionally only they are on many medications, SLE patients, because it's autoimmune. So only hydroxyquinoline, azathioprine and prednisolone is allowed, and all the other medications which are given to transplant patients, to these patients should be stopped. And of course, the rheumatologist should be consulted all the while, because we have very less knowledge, as you all said, about this condition, and it's so rare in pregnancy. So we thought we will discuss this case. So now, what else?
When we were given this panel, Uma and I were discussing that preconception care, what to do. You give folic acid to the patient, you give them advice about diet, nutrition, lifestyle change, the investigation, vaccine. But then going in the depth of the subject, we realize that each patient may present differently, hypertension and diabetes and autoimmune diseases and so on, and anemia. A lot of things we have not really touched. But it was very good listening to your personal experiences about, so anything you would like to share, each of the panelists?
I would just like to add, in all these patients whom we have discussed the pre-existing conditions, while counseling, it is important not only to counsel the patient herself, because she will take care of herself more, but the family members also, because they also should know the importance of her frequent visits, not only with us, to monitor her pregnancy in a better manner so that we prevent complications, and also to the concerned specialist, because so many times it is the in-laws or family members who say, why are you going so many times? We never even had one visit during our pregnancy. So always involved, because many a times she is new to this family, and her in-laws or the family members, they do not understand the importance of the condition. So I would again say that counseling plays a very important role.
I want to ask, how will you do preconceptual counseling of the male partner?
If she is going to be a mother, he is also going to be a father.
So what he has to do before she gets pregnant?
Support. Unconditional support.
Yes, Dr. Sagar. Yes.
That's important. Stop smoking and alcohol.
Passive smoking can also be risky.
Yeah, passive smoking for the mother also, later also.
That we discussed, yeah. Nowadays patients only ask, how many cigarettes are allowed during pregnancy? I said, no, not allowed. So
how much alcohol?
Maybe we can include that also. Make a case more. Who are smokers and alcohols.
So anything else? Yes, Shilpa, you were saying something.
Yes, I had a patient who was diabetic with infertility, and there were lots of family problems. So what happens in our society is, if there is problem with the grown-up children, just marry them off. Still, if the husband and wife are having problem, plan a kid. So it just adds to the problem and the situation worsens. So this patient had lots of problems with her husband and in-laws, and she stopped diabetic treatment. In the end, we lost that baby because she just stopped all the medication. She had hypertension also. So the family harmonious environment in the family is very important. So after this, now I have counseled her that first you be at peace with your husband, settle all the situation and then plan pregnancy, because fighting in the family when she is already hypertensive, diabetic, all this leads to lots of problems. And maybe when you say preconceptional counseling, we should also judge whether the husband and wife are having harmonious relationship. Otherwise, if they keep on fighting, the pregnancy becomes miserable for the woman, and miserable women, unhappy women do have more complications in pregnancy.
So psychological
that is a social angle
and psychological counseling.
Yes, I feel it is very important.
And what Shilpa says here, it's not just preconception counseling for the patient, but preconception counseling for the entire family. Is that right?
Yes.
So, in the end, to wind up, we would like to say that preconception counseling, we should increase it among our patients. They should be aware of this condition. And if we counsel the husband and the honorary mother, then of course we'll have a good pregnancy both for the baby and the mom. Thank you so much for a patient listening. I thank all our panelists for guiding us.
Thank you so much. Thank you.
Thank you all the panelists.
It was a nice
you,
discussion. Thank you.
Thank you, Aishalya.
Thank you, madam. I request moderators to kindly felicitate the panelists. I request Mahendra madam. I request Mahendra madam to kindly felicitate our moderators.
Just I wanted to say something. No, not about the panel discussion. In a chronic renal disease, when she had a problem, hepcidin production by the liver is increased so much that right from the beginning, in pre-conceptional stage, she will be severely anemic, and this anemia could be refractory to the iron. So one must look for that also.
Yes, and use erythropoietin maybe.
So that is why
yes,
actually at that time I wanted to add.
Thanks, ma'am. Shifty experience always counts.
Thank you, ma'am. Thanks a lot. For the next session, I hand over the mic to Dr. Mangalavani, madam.
Thank you, Vaibhav. And it was extremely very important session, panel discussion that we had this morning. And now I'm extremely privileged and honored to conduct this important session, the oration. And I'm sure you are all waiting for it. And we have a very important person of the Foxy to give this oration, and that is Shanta Kumari, Madam. So first of all, I would like to invite the chairpersons for this session, and it is great pleasure to introduce the chairperson. So first of all, I like to invite Sunita Tandurwalkar, Madam, Sunita, and Dr. Dilip Walke, sir, and Dr. Nilesh Balkavde. तोपर्यंत मी तुमचे इंट्रोडक्शन करते ना मग. We have a time. आम्ही करतो ना, या ना तुम्ही. It is a pleasure. We haven't seen you for last 2.5 years. So we can have some interaction as well meantime. So meantime, I will introduce the chairpersons till they decide whether to come on the stage or not. So Dr. Sunita, she has just finished her presidential year POGS, and she has done fantastic work in last 1 year. In spite of having the COVID pandemic, all the challenges. And currently she is head of the Department of IVF and Endoscopy Center at Ruby Hall, and she is also advisor and consultant at D.Y. Patil IVF and Endoscopy Center, and she is a director of the Solo Clinic, and she is the first stem cell baby and world's first at age of 45, and this is extraordinary achievement. Sunita has actually so many extraordinary achievements, so this is one of that. And she is a chairperson of ISAR MSR. She is a president age 19 to 20, and she has authored many books and publications. So Sunita, then Dr. Dilip Walke, sir, he is also a past president POGS, and he was a chairperson Ethics and Medical Legal Committee Foxy 2007 to 2010, and he is a consultant at Jupiter Hospital and Vitalife Midpoint Hospital, and co-author of Foxy Uniform Consensus, and he is on advisory board Dr. Prax Telecommunication Solution, and he is a mentor and founder for Pune IVF. And Dr. Nilesh, where is he? He was sitting here. He is one of the youngest, and he was secretary POGS last year, and and he is the chairperson of now Foxy Quiz Committee, and he is a clinical head and fertility specialist Oasis Fertility Pune. He also has a lot of awards and lot of publications. So now I hand over the session to chairpersons.
Thank you, Mangala, for introducing all of us.
Pooja, can you check that?
And I think there is some time before Shanta can come here. And thanks, Mangala, for introducing Nilesh as the youngest. But let me tell the audience that he is the youngest father. He is not young enough to be called young now. Father of how many, Nilesh? Father of how many children now? 2. So he is the youngest father, you can say. Youngest father of
Let's
POGS.
take his viva. Was it natural conception? Was it assisted reproduction?
I'm finding it so difficult to sit here among these two followers.
No, let's tell me whether it was a natural conception or it was an assisted reproduction.
Madam, I have proven my youngness enough.
No, how to see? You can prove in the lab also. So we want to know detail. Was it a natural conception? Don't feel so shy, yaar. Now your girl is daughter is grown up.
शादी के पहले की कुछ भी नहीं पूछ रहे हम लोग. You have proved your manhood even before marriage. I know that.
Answer.
Anything can happen शादी के पहले और शादी के बाद.
No, we know कि they are legitimate kids. Okay, so really attempt for you, and it just happened. Consultant is going on.
Okay. About lifestyle shaming. I mean, where and how the conception action, I think it will be very embarrassing for you to.
No. He should take this sportively.
Madam, I have worked for you for 1 year. Now we should stop.
Very simple, but you are not so simple. And that's why I'm bringing everything out.
So Nilesh, as an
Josh,
ART consultant, yes, she's right in asking.
What I observed is, in Josh, he was not there in the hall. He was disappearing. And he came with the wife and 2 kids. So I was in conference.
Where wife
so
had
you
come,
want so now if he comes out with the 3rd kid, we will label it as Josh.
You know, when 2 ART consultants start talking, I mean, somebody like who is just very a simple obstetrician have to keep quiet. So you can carry on.
No.
Now,
legal person, do you think he will keep quiet?
And I think Dr. Dilip is also IVF consultant.
Dilip?
I am just a
What is
mentor.
the
I am far away from.
I will start asking him all the protocols then. He better say, I am Shanta. Shanta has traveled all the way from Hyderabad to Mumbai to Foxy office, and midnight she reached here to be with all of us, and then she is going to Mumbai to install another team. So I can imagine the hectic lifestyle.
Shanta, thanks for coming a little 5 minutes late, because we got a chance to actually group.
April and in September, and in last near 20 years, not a single Foxy meeting, managing committee meetings she missed. So she was so determined to lead this organization one day. And that determination, that passion, that perseverance speaks a volume about Shanta than reading her awards. She has achieved all the awards, and the project which is, I think, will take her to Padma Shri is her Dhira project. The way her Dhira project started way back when she was organizing some of the Foxy conference, I remember, in my vice presidency and Reshma's presidency. And it was a beautiful evening program of Dhira which she had organized, and then she has taken it to the another height during her presidency. So Shanta, many conferences you have organized and you will be organizing. One of the main where we saw Shanta shining was AICOG 2011, where she shown the world her organizational skills. I still remember that conference, and it was mind-blowing. I think she uses her city to her benefit. The facilities, what she has in her city, she uses them beautifully to organize these conferences. She has organized also ICI, Foxy Figo, ICPHRP, and so many others. And now also we have 2 major conferences in Hyderabad that will be a presidential conference and Foxy Figo conference again. So Shanta, stage is yours, and thank you so much. Each and every one of you are feeling humbled by your presence. We are so thankful to you that whether it is in Maldives or whether it is in Pune, your love to POGS is so much that you come to install all of us. Thank you, Shanta.
Shanta, before you start, I have to take some liberty, because very good friends, and we actually started Foxy together, and then when she became the Foxy president, I was really proud. I mean, somebody who started Foxy with me and then becomes the president, and she showed to the whole Foxy that she is such a dynamic leader. Shanta, I was very impressed when you became the Foxy president. Now, today, I have become a big fan of yours for one reason. I am going to share that with all of them, and I'll tell you why I have become a big fan of yours. That day, I heard a bite of yours when you were in Rajasthan to meet the family of Dr. Archana Sharma. And that's what I call is a true leader. I really thank you, Shanta, because this is what I was trying to see from a Foxy leader. And you have shown it to the whole Foxy that it is not just about sitting in Hyderabad in your AC consulting room and then giving a bite to a national TV. You are actually there on ground, giving support to the family of Dr. Archana Sharma. These are the kind of leaders that we want in Foxy. So Shanta, today I'm not just your friend, I'm a big fan of yours. Thank you very much for having done that.
Namaskaram to everyone. Thank you, Sunita, for the lovely introduction, and of course, Dilip, my dear friend. Congratulations to my another very, very close friend, Parag Biniwala, and Ashish, and the whole team of POGS who are getting installed today. Girija, everyone is there. Our sir is there. And each and every one of you. I never realized that till yesterday night that this is one society where I have been with you thrice in my presidency. Or 3 times or, yeah, third time. And as a president-elect, I came for the lips also. So it's the 4th time. So I think that shows the relationships I have with Pune OB-GYN Society. And it's really wonderful to be back here. The plan was not to be here. Today I had a lot of commitments in Mumbai. But then Parag said, no, you have to come. Niranjan said, how can you go? You have already committed here. Then finally he said, how can you not come? I had no choice. Then I told Niranjan, look here, I don't know what you will do. I have to go to Pune in the morning and come in the evening. Madam, Deshmukh Madam, good morning. And Mahendrale Madam, sorry, suddenly that KKD Madam's name came off in my this thing. It's really an honor to have the presence of so many of you. And Sunita, you told a statement that I have attended the managing committee meetings and all. Let me share with you, what is it that keeps us going? What is it that makes us do all these things? Yesterday, one of my cousins was saying, okay, are you there at Hyderabad at any time, given point of time? My husband didn't know where I was, so he was asking me, where are you? So I had to, then I said, what is this? You are not at all worried where your wife is. At least thoda to bhi drama to bhi karna hai na, ki that you know where I am and how I am. I think that is what Foxy is to all of us. Like we are a family and this organization is so close to our heart. We feel that every time we are with any of our own members, we feel we are at home. I think that is the power of Foxy and that is the power of being together. And when we are one, when we are together, I think there is no power in this world who can stop us. And that is the most important thing. We need to believe in ourselves, yes. Friends, I have traveled the length and breadth of the country in my journey to be the president of Foxy. And I went with a vision and mission for my election that it will be Foxy for every obstetrician, for every mother, for every baby, and for every woman. This was my election agenda. And when I got elected, friends, I was invited to this Global Maternal Newborn Health Leadership Workshop. It was in Africa. The complete who and who of the partners of women's healthcare were there globally, right from the World Bank to the FIGO, to the Foxy, to the ICM, to the UNFPA, to the UN, WHO, all the NGOs, DAPIGO, then UNICEF, USAID, White Ribbon Alliance, there were so many. If I just start talking of them, it will take an hour. Every possible partner of women's health was there in Dakar. And that day I realized that why is it that so many of us are there in Dakar in Africa? When I got an invitation, I was very happy that I got an invitation to Dakar. I told, okay, I'm going to Dakar, Pritam, very good, I'll go and see Praneeth. I really didn't realize that Dakar was in Africa. I thought it's in US. And I thought some states, there's so many places in US, I thought I was going to US. I told, don't worry, I'll call Praneeth there and see. Then Pritam asked, you know where Dakar is? I said, yeah, it's somewhere it must be, no, in the US. There. Senegal it is. He said, you know where Senegal is? Must be some district of America. He said, no, it's in Africa. So that, all of us being in that Africa, in that small place, is actually showed me the commitment of everyone towards women's health. I think that is what made an impact on me, that every one of us together can make a difference. Those 3 days, we had brainstorming and we had heard different perspectives. And that was the day when I realized that we at Foxy are very empowered also. You know, we are so focused. The amount of work we do as Foxy is unparalleled. So that shows the power of an organization. Friends, when I took over as the president in 2021, on the June 27th, I came with my commitment, Foxy for all, always, and Dhira, stop violence against women. Foxy at the service of women of our country, whom we serve, whom we take care of. I think every obstetrician gynecologist has this motto of trying to take care of the women we serve. So the logo which I came out was, we took all the 5 elements, the air, the water, the earth, the sky, and the fire. I think all the elements put together forms Shakti, that is a Stree. The woman is an embodiment of the 5 elements of earth, and we are so very lucky that we are actually taking care of the women in our profession. So Foxy for all, always, and Dhira, stop violence against women was the theme and vision and mission of Foxy this year when I took over, friends. Foxy for every mother to reduce the maternal mortality rate, to achieve the SDG goals, let no mother die in childbirth. Foxy for every woman with Dhira to say no to violence against women. And Foxy for every Foxyian to be able to practice with safety, dignity, and protocols. Many of us, maybe 20 years back, didn't know what it was all about when people were talking about the MDG goals. And that was the reason why MDG goals never succeeded, because they had kept the people who actually decided to start this MDG goals never took it across. They thought that they could achieve it themselves, right from the Beijing platform of action which was obtained to the target of MDG 2015. And when in 2012 they realized that we are reaching 15, then everybody woke up. Oh, what is it that we are doing? Why is it that we are not reaching the MDG goals? That was the time they realized that unless they partner with obstetrician gynecologists across the globe, they will not be able to actually achieve the MDG goals. It's not enough if all the World Bank or the governments or all the UN, WHO come together. It's the commitment of obstetrician gynecologists, the doctors who serve, take care of women, was so very vital. And that was the reason they realized that why we were not able to reach the MDG goal. And then they all sat together and came out with the SDG ambitious goals, big and so many goals and so many sub-goals. But remember, the goal 3 and goal 5 are so very important when based on the goal 4. And those targets can be reached only when all of us are committed to take care of women's health. So challenges at the global scale. We have got so many millions of girls who are under 15 giving birth per year, maternal deaths per year, and women, millions of women with no access to family planning. So many million induced abortions which are unsafe, and unsafe abortions are something which we shouldn't be hearing about. Millions of women are getting affected by diseases, and so many women are dying with cervical cancer. And 1 in 3 women experience physical and sexual violence. So when we talk about human rights, equality, health, life, privacy, information, and expression. That's so very important. And the link between human rights and reproductive rights is very important. The basic right of the couple and the individual, making the decision concerning reproduction, and to live in an atmosphere free of discrimination. We in India are so empowered. Way back in the 1970s, we had the MTP Act, when to date in 2022, the so-called global world leaders, the so-called big brothers of the world, are still trying to have criminalization of abortion, still trying to take away the rights of a sexual and reproductive rights of a woman. So very sad. We have amended this MTP Act in 2021, and that shows that we are way forward when it comes to women's health. We are a country who had a woman president, we are a country who had a woman prime minister, and they're still trying to actually deal with trying to have one vice president only for the sake of the election, friends. So the key international laws, which started in 45 with the UN Charter, to so many Declaration of Human Rights, to the International Conference on Population Development, and so many other meetings and programs which are held globally. The reproductive health outcomes are related to the adherence of human and reproductive rights. Unless you address this, you cannot achieve overall development. Still, we have to deal with rape, the gender-based violence, and even female genital mutilations, leading to unwanted pregnancies, miscarriages, HIVs, infertilities, and psychological trauma. So all these are actually affecting the health of the women. Care denied solely on the HIV status shows that we cannot achieve the maximum output unless we partner with each other. Reproductive health and other health risks of the client, partner, and other have to be reached only when you address all these issues. Friends, the issue of no privacy in counseling area of the reproductive health clinic, and probably non-use or incorrect use of methods and discontinuation contribution to the unwanted pregnancy, leading to maternal child morbidity and mortality. So, what are the tools for respecting, promoting, and protecting the human rights through reproductive health? Laws, policies, regulations, advocacy, documentation, reporting. So FOGSI at the service of women, I think we are a very important voice on the advocacy. Advocacy which is so very important. Documentation and reporting. These are the very vital arms in our hands. What can policy do to improve reproductive health using human rights tools? Well, when you look at the international, they have got so many countries which have ratified the human rights treaties, and national laws and regulations and operational service delivery policies guidelines. These are what are given and meted out by all of us. These are what will make a difference, friends. So when you look at our own FOGSI, we look at the section on reproductive human rights. We've got so many subcommittees of FOGSI. We've got so many chairpersons in Pune also. We all started the journey. We all were chairpersons together. So many committees, be it the adolescent or the food and drugs, family welfare, ethics, medical legal, HIV, all the committees we have in FOGSI to work towards sexual reproductive health, friends. The MTP committee, Safe Motherhood committee, and so many others. So we have been on the right track trying to see that we help our women in a better way. Quality of care, including respect for rights, is so very important, and it is very critical that people do access service. You please give them the quality of care. It is their right, and it's our duty to give it to them, friends. And any woman of any age or background who cannot access, afford, or receive the SRH services with respect, dignity, denied adequate information, sensitive counseling, or free choice of contraceptive methods. Now, who is the unreached constituting the unmet need? This is what we need to look at, friends, which is so very vital for us to achieve an all-round, I think, improvement in women's health. There's a spectrum of unmet needs. We find that still we are dealing with the adolescent and youth problems to the reproductive problems, and we find that the less educated, immigrants, victims of social conflicts and natural disasters. Even today, when you look at the Ukraine war, what is happening? I'm not talking at whether who is right, whether they have attacked and all, but who are affected? There are thousands and lakhs of pregnant women. 1 month back, there were 80,000 pregnancies which were supposed to deliver in the next 3 months, which were given, the data given to us at FIGO by the Ukraine Society of OB-GYN. So many women, and there were women who were actually delivering in the tunnels, in the subways, and the doctors, the OB-GYNs trying to see how best they can save lives. So it is important, whether it's a conflict, whether it's an improvement, it is these services which we mete out to our women are what will make a difference in that country's, I think, outcome to being good holistically. So do we grossly undervalue, undermine, underestimate, and underperform in our scope of services in reproductive health is something which each one of us have to talk about. The government, the partners, everyone. So when you look at our vision and mission, we've got so many types, right from the Asha mentoring to this Jagriti to Foxy Eye Care, training and workshops, publications, the Foxy SRH standards for adolescent youths and youth-friendly health services are there. And these talk about our advocacy. And friends, when we look at the target 5, the gender equality, now respect for women's sexual and autonomy within the marriage is so very important, and universal access to contraception and SRH information is the key for achievement of overall, I think, improvement in women's health. Dhira, which means courage, the power of being Dhira together. It was way back in 2015 when I became a member of this working group on no to violence against women. We realized that there is something which is beyond our knowledge of obstetrics gynecology. It's not only your skill to perform a cesarean, your skill to do an operative delivery, your endoscopic skills or an IVF skills. We have to understand what it is which affects the women's health also. Think beyond our obstetrics and gynecology. And that's where we realize that we are the first point of contact for any woman with any violence. And when I launched this Dhira in 2016, we carried it forward to 17, 18, 19, 20. We partnered with police, the SHE teams. We partnered with National Commission of Women. We partnered with FIGO, partnered with society, celebrities. We called for an advocacy. We did public forums, cyclothons, bikeathons, and so many other programs. FIGO was very impressed and said, you have to take it internationally. It was 2017, we took it to FLASOC, when again we had to fight. I didn't have to face any problem when I launched this in India, but in the Latin American countries, there was a lot of resistance. They said, you can't do this. Politically, right, not correct. We can't do this. Then I had to fight. I said, this is something which is the core of us as an obstetrician gynecologist. And in Cancun, I could convince them to do it. And we carried it forward to the Rio Congress, and that was where the global partnership happened. Every country, every obstetrician across the globe actually confided in us that this violence against women is there in every part of the globe. It is not only in our country. And we were actually somewhat better than in the other countries. At least the women's sexual and reproductive rights are respected by the government and by the healthcare providers. Nobody hesitates to offer her any service which she needs, actually, friends. So when I took over, we started this initiative. I said, now we need to do something. Foxy has to be an advocacy, Dhira, no to violence against women. So I started this project. It's based on 5 pillars, partnered with UNICEF India. The first pillar was the Foxy online school certification course, Dhira. I thought that we need to catch them young, right from the 9th to 12th class children. Talk to them about why we need to address this, because these are the children who will grow up to be the future of our country. I thought we need to catch them young so that no girl should say, okay, it's all right, I've seen my mother, I've seen my aunt suffer violence, it's okay to accept. And no boy should actually think it's okay to do violence when they see somebody doing it. So that should be the way we should handle it. And friends, I started this online certification course because how do we engage these children? You have to give them something to attract them. So I thought only certificate you give them, they're very happy. You know, at that age, you're very happy to get a certificate, and only Foxy doesn't make them very attractive. You need to give them something which they will like. So that's why I partnered with UNICEF India and for another project with the WHO. And engaging government, Ministry of the Health, Family Welfare is the core. I hope that by the end of this, I will be able to reach where I want it, that the government makes this a mandatory course for all school-going children. And friends, let me tell you, we have achieved UNICEF partners. This is an old thing. We have done 12 master trainings, about 1,200 plus Foxians trained. We have covered 125 schools till yesterday. This is an old one. And about 1,000 plus teachers also covered. 15,000 was last week students who were touched. I think this week, yesterday only I saw we have reached almost 20,000 students. Every obstetrician gynecologist, every Foxian is in connect with some school teacher, some school principal. I wish where all my 262 societies with 38,000 members, all of you do one school at least. Per society you do about, even the big societies do about 20, 30 schools. I think we'll be able to reach the 5 lakh students, and automatically the government will be forced to accept it. They said, I can't directly partner with you. They said, you come through Foxy, once you achieve this, then as the government we can absorb it and put it. So I need your cooperation now. The exams are there, hopefully by June, by the time the schools reopen, and now every child is in access with an online platform, with a smartphone. We can take this across, and we find that there is so much of motivation in some of our members, the students, and very surprising, the first school was a school from Assam, such a far east place, and that shows that if we really work, our members can take this across the length and breadth of the country. I hope the Pune OB-GYN Society, Parag, Ashish, and all of you will be able to take this program to as many schools as possible in Pune and in Maharashtra. So friends, the second pillar, workshop CMEs for gynecologists is ready. It's getting launched, already few societies, and we are going to talk about that. Now when you're talking of Foxy for all always, Youth Day we celebrated, yes, there was a lot of involvement, and we need to involve the youth. We need to make them responsible to be a part of this movement of trying to reach to all the women of our country, friends. The Foxy Adolescent Health Day was celebrated with so much of enthusiasm when we were in the last year still in the virtual mode. And then the respectful maternal care is so very important. The past 2-3 years, everyone is talking about the respectful maternity care, which needs to be addressed by all of us. And I think most of us are taking care of women's rights because we are the ones who are taking care of them. And friends, when we launched it, the WHO actually declared 17 September the World Patient Safety Day revolving around respectful maternity care. And that was when we also launched the Foxy, the RMC, Respectful Maternity Care. And that day, it was an hybrid launch by Professor S.P. Singh Baghel in Agra with Dr. Jaydeep Malhotra. And let's hope that all of us do what is required. And I'm very sure that all my members are giving that respectful care to the women of our country. We have a collaboration with the WHO India, a joint Foxy partnership on respectful abortion care. When I was talking about this respectful abortion care, it is to bring a strong positive global standard as a basic human right. We have launched it as the Foxy WHO initiative. When I was speaking about this respectful abortion care project to my FIGO colleagues, they were all very impressed. They said, we have never heard this concept of respectful abortion care, especially the Latin American, European countries and North American countries. They said, I think this is a very good idea. We should take this from you and spread it across the globe. Because we want to reach out and we are not able to know how we can reach out without breaking the barriers of the government, the laws and the regulations and the cultural and the religious beliefs of these countries. So friends, our Foxy's projects are an inspiration to the leaders of OB-GYN across the globe, and let's hope that this initiative will make safe abortion available to all the women across the country. And that is the power of Foxy for all, always. We have started this initiative of Naipunya Skill for All. It's a simple program. Dr. Agarwal with our vice presidents have Bipin and Fesi. They worked on this. This is a simple online program which is ready with all the PowerPoints and all. We have sent it to all the president secretaries. It's there on the website. Simple things. Lot of programs happen in the government sector for big hospitals. There are small clinics, small nursing homes. You may have 5 people. You may have 6-7 people who are your staff. You can do it. Just take the presentations. Do it in your hospital. 3-4 hospitals together sometimes you have. If your staff can pick up few points from this presentation, I think that will go in a long way where we'll have more skill. We have got so many programs, but this is a small, simple Naipunya Skill for All, which if properly utilized, will be like a refresher for all these small places where we can train our paramedical staff. Now, prematurity is a global burden, and our action, we have seen that so many million die every year, friends. So we thought, why do newborns in India die? So many reasons. And we realized that the birthday is very important. The neonatal resuscitation, breastfeeding, community-based pneumonia management, this kangaroo mother care and all. So we have launched some of the programs with the IAP, and the government IAP have signed an MOU for training FOXI as an important partner, and this is going on. I'm sure many of the IAP people would have got in touch with you all, and this is something which we need to look at. And the other important program is this Lactocon, the breastfeeding awareness week, which is so very important. Sneha and the team, we are with the breast committee. With Archana Verma, they worked very hard to see that this program is successful throughout the country. And I was so very happy to see that more than, actually there were 200 plus societies which participated. They did programs in the hospitals, TV, radio, everything. And it was a massive participation to show the commitment of OB-GYNs to encourage breastfeeding, because we know that it affects the maternal and neonatal health and well-being. So this was a participation showed that every one of us actually care for our women and our babies. Then we have the stillbirth day, reducing preventable stillbirth, which was a scientific program. And we have a project, actually that's the only project which has got delayed. Hopefully in the next 2 months we'll be able to launch it. We are trying to gather the data for the stillbirth registry in our country and trying to see how we can approach this. We have a partnership with the GE, where they have offered us some of the ultrasound machines. The team is working on it. It's a very massive, ambitious program because PCP, NDT and so many other issues which are involved, friends. In spite of so many programs, still we have not been able to break free from anemia. And FOXI is committed to anemia reduction. We have seen, we are partnered with this Guinness Book of World Record certificate. Friends, the other most important FOXI's commitment is vision and mission in cervical cancer elimination. We know at the statistics that cervical cancer is such a leading cause of death in our women, and I think we should do everything possible to help our women. Now this 90-70-90 is so very important. See that the HPV vaccination is actually, I think, taken to all the adolescent girls. Vaccination of the adolescents is so very important. Don't lose an opportunity when any mother comes with her young adolescent girl to your clinic to actually give her a small advice on this. And COVID vaccination has also improved the knowledge of vaccination among people, and we should take the chance, friends. And what we have seen is we have come out with GCPRs, and we know that there's so many deaths which can be averted because of that. Again, when you look at it, I read there was an article where for every dollar we invest for the vaccination coverage, there is about $3 which is returned back to economy in few years. That's how the World Bank and the US were looking at it. So even taking care of women's health is linked to economy. And they say now if you invest in the HPV vaccination, by 2050 for every dollar which is invested, you get back $50. So the reason behind, I think, the World Bank and all the global leaders trying to invest in women's health is again looking at the economy. That women, taking care of women will improve the economy. But whatever is the reason, if they're doing it, let's hope that they do it so that we can save our women. The Cervical Cancer Mukt Bharat was our commitment. We took it, Priya was the oncology committee chairperson in the Salkapuram village in Kurnool. We involved the politicians, we made them sure that they partner with us. Colposcopy was done, and then we did the hybrid conference. We had the FIGO president, Jean Connery, with us, who was a chief guest, and that showed the commitment of FOXI and FIGO for eradication of cervical cancer. Because we need to have a goal, be positive, work hard and make it happen. It's not just talking or trying to give bhashans, but every one of us giving one vaccination, doing the screening. What I want each one of you seniors, please instill the fact that among the juniors and other colleagues, any woman who walks into our OB-GYN clinic should not leave the clinic without a speculum examination. You may be an expert IVF specialist, you may be expert radiologist, whatever you are. Don't lose the opportunity of putting a speculum in the patient who comes into our chamber and do a cervical cancer screening. This is so very important. So people at some of the youngsters feel ultrasound is there, why do we need to do a speculum examination? I think we keep on talking, keep on telling so that this gets instilled and we lose no woman to cervical cancer, friends. Friends, Foxy has been working on SRH for last 2 decades and will continue to engage in working with all the stakeholders to achieve the best of health. What we need is a national international collaboration for knowledge setting and skills. Foxy with FIGO, with UNICEF, the USAID, the WHO, with the IAP, the NNF, the ICMR, the Royal College of Physicians of Ireland, the RCOG, so many partners. All together, I think will make a difference. There is nobody who is very great. There's no one college which is greater than any other organization. There's no organization. I can't say Foxy is the best and I am the ultimate. Neither can the FIGO say I'm the best, neither can the RCOG or anyone. I think together everyone can partner with each other, and that strength will give us more strength to take care of problems, to see that we reach a commitment to our women. That is so very important. Foxy works for women's health, yes, but friends, what is very important, my dear friend Dilip has also told, I think no to violence against doctors is also the core of our heart. As an Foxian, my commitment is for my Foxians, for my doctors. If I don't take care of my people, if you don't take care of your colleague, who is going to take care of us? That's why we were in Rajasthan, Lalsot, and I have not gone there to celebrate that somebody has done Balidan. I do not want any Foxian to commit such a step. Don't even dare to think that the world is going to break and something will happen and I have to do this drastic step. I think I have to insist that every one of us have to have the strength and power to instill that in our colleagues, that we are there for each other. If there is a problem, don't think that you are alone. Problems will happen. If you are not having problems, that means you are not doing enough work. If you have not had a medical legal case, if you have not had a critical case, that means you didn't practice enough. You're not doing enough work. So remember, but when somebody has a problem, just don't try to shrug off. If a colleague has a problem, be there for that colleague, because it could be you next time. I'm not giving bhashans and I'm not giving anything, but any problem, I think when all of us are together, you go and beat one lawyer, what happens? All the lawyers are there on the street. You go and tell something to one politician, then they forget that they're this party and that party. They all become one clan. It is only we doctors, Foxians and other doctors, don't care for each other. And when you see somebody commenting something very brash and unwarranted in the social media, I want each one of you to actually tell that person, do not dare to belittle your organization. Do you know what the organization is doing? Tell me what is it that you have done for your colleague. Tell me what is it that you have contributed to the organization. And unless we show to the world that we are together, we are one, we will not be able to achieve anything. And that is very important. This message I want to send across to all the 38,000 members, so that if you find anyone trying to belittle you, trying to make us weak, or trying to make us look like we are some jokers in front of the society, I think that is unacceptable. And that is something which we will not tolerate. And if we find such things, probably the Foxy leadership will be taking steps to see how we can address those people who demean the organization on the social media or otherwise. Because I know my organization is strong when all of us are strong. We are committed, and together we can really tackle any problem. What happened in Ahmednagar? I'm so very proud of my Foxy people who have joined hands with our IMA in Ahmednagar. You know, we were still in Indore when this happened. When I got a call, I was still in Indore. I said, when the Ahmednagar incident came, I spoke to Dr. Shinde, Ahmednagar president. He said, madam, don't worry, we are all there to take care. I spoke to Rajendra Singh Pardesi and Ajay Mane. They said, madam, we are on the way, we will reach, don't worry. So that commitment, that we have 262 societies. So we have our people in every nook and corner of the country who can reach out in times of crisis. It is not possible for the FOXI President or Secretary General to reach at every place. When problem happens, what you need is you need your local colleagues and team who will be the first response, because don't think you are heroic or some big dada or something you can handle. Mob violence and all we cannot handle. I'm sure all these medical legal people will be telling. So gather your own people and try to see how you can actually avert that problem, so that after the initial issue is over, as an organization, FOXI is always there. We are there to support and help. I think that is very important. Every society needs to be together, and that is what actually will make a difference to reach this vision and mission of FOXI, FOXI for all always, Dhira stop violence against women, with the important message that FOXI says no to violence against doctors. Thank you very much, friends.
Thank you, Shanta ma'am, for such a wonderful oration. We are indeed, it's our pleasure at Pune Society to have you here. And one thing I can say, that when she speaks from her heart, and it's always right from local to the global. We have seen her travel and her connect with each society, and same is the connect with FIGO. I think what message she gave and what we should understand is that it's very easy to sit there and see what POGS is doing or what FOXI is doing, but we should come together, join hands, bring some issues in front of the organization so that together we can and together we will. So thank you, ma'am, for such a wonderful oration. I would request the POGS President, Clinical Secretary and General Secretary, Dr. Ashish Kale, to come up, please.
Parag, you would like to read?
Shanta, thank you very much. And when you will hear my presidential address, you will realize that we speak the same language, which we've been speaking for last 15, 20 years. Thank you very much for coming. I know the adversities that you've gone through, but it's the bond that we share. I would read out the oration plaque, which is presented to Dr. S. Shantakumari, President FOXI. Your role for women's healthcare and role for the upliftment, FOXI will always be remembered and cherished. Your efforts in spreading academic excellence are commendable. In appreciation for your perseverance, passion, and dedication to society, from Team POGS 22-23.
Ashish, come. Thank you for the wonderful words, who made me feel good.
Thank you so much, Shanta Kumari Madam. That's been very wonderful. And now I request Parag to felicitate the chairpersons. Thank you so much.
रास्ते के रोड़े हैं सब पीछे छोड़े हैं, जो रास्ते के रोड़े हैं सब पीछे छोड़े हैं। बस आगे चलना है, बहुत दूर निकलना है, मंजिलों को पाना है, साहिलों पे जाना है। बस एक ही जज्बा है, कुछ कर दिखाना है। At your service, POGS. At your service, POGS. We turn and we will do it. We turn and we will do it. वो जो घर को घर बनाती है, सबको जीना सिखाती है, हर हाल में जो मुस्कुराती है। We care for her, we care for her, we care for her, we care for her. अरमानों के पंखों को फैलाकर उड़ती है हवाओं को सहलाकर। उसके सपने हैं आसमानी, आँखों में है एक कहानी। वो जो रखती है सबका ख्याल, वो जो रखती है सबका ख्याल, हम रखते हैं उसका ख्याल। At your service, POGS. At your service, POGS. We turn and we will do it. We turn and we will do it. At your service, POGS. At your service, POGS. We turn and we will do it. We turn and we will do it.
Chauhan and with Dr. Manish Matswe. It's a pleasure to take you through the grand installation ceremony of the new team under the leadership of Dr. Parag Biniwale, followed by the inauguration of the 37th CME of our very own Pune OBGYN Society. Pune OBGYN Society was founded way back in 1953 with just about 5 members, and today we are more than 850 members strong, and we are doing more and more activities, and it's indeed a great pleasure to meet everyone in this post-COVID era for the very first gathering of this year. For Manish and I, it's a memorable event because it involves two of our favorite mentors, that is Dr. Sunita Tandulwadkar and Dr. Parag Biniwale. And it is but natural that we stand here today to take you through the grand installation ceremony of Dr. Parag Biniwale, as he is the sole reason that we are here on this dais today. we were privileged to have been given the opportunity, the encouragement and the introduction into Foxy by none other than Dr. Parag Biniwale. Manish, do you remember long ago, Dr. Parag had taken us to Kolhapur for Yuva Foxy when we were really Yuva at that time?
Good morning, everyone. May I request everybody to settle down, please? We'll give you a 10-second period. May I again request everybody to please settle down? It's an earnest request for everybody to please settle down. Thank you so very much. Of course, Vaishali, I remember, Parag taking us to 2008 Kolhapur Yuva Foxy, and we still are enough Yuva, and Parag sir has pushed so many of us into the mainframe of Foxy and POGS. And I don't feel any shame to confess that at that point of time, and time to comes, we were copy pasting his PPTs and getting all the accolades.
We still do, I think.
Yeah. And the only thing probably which we cannot copy paste is his personality. So I think that is impossible, at least in this era, to do. Okay. All right. So that is why we are here. A promise made to the one and only Dr. Parag Biniwale long time ago that we will do the installation and inauguration whenever he takes over as a president. If I have to say, इतनी शिद्दत से हमने आज इस पल की गुजारिश की है, इतनी शिद्दत से हमने आज इस पल की गुजारिश की है कि जर्रे जर्रे ने इस पल को हमसे मिलाने की साजिश की है. So to begin with, as is customary, nothing happens without the blessings of God, and to invoke the Almighty on this splendid occasion and bless us all for the grand installation and inauguration of our conference. May I present to you Miss Savni Shirish Gokte. She is studying MA in music and from SNDT Women's University under Pandita Shubhata Tai Paradkar of Gwalior Gharana. Miss Savni Gokte, please. Thank you, Savni. Totally mesmerizing song from Umberta. I request Dr. Vaishali to felicitate Savni, who also happens to be Mahendra Madam's niece. So, learning music in itself is something which is extremely difficult. You have a superb voice. Thank you so much. Time to call our esteemed dignitaries to occupy their respective positions on the dais. I request our young managing committee members, Dr. Mansi and Dr. Archana, to welcome the dignitaries as they ascend on the dais.
It's a great privilege for us to invite Dr. Sunita Tandulwadkar, President POGS, on the dais. And words aren't really enough to describe this power pack of elegance and intelligence. Madam has taken POGS to national and international fame. Only one life it shall someday be passed. Only what is done for the society is what shall forever last. With this as her mantra, this lady is draped in confidence and wears a crown of passion, setting benchmarks as she travels a road of success. She is simply unstoppable. Welcome, ma'am. I would now like to welcome the office bearers of the team 21-22, Vice President Dr. Pankaj Sarode, who was instrumental in the successful organization of AMOG's Zonal Conference and also the POGS AMOG's installation inauguration at the exotic location of Maldives. Welcome, Dr. Pankaj. I would like to invite Executive VP Dr. Kundan Ingre, Chairperson Infertility Committee FOXI, and we have witnessed a fantastic conference, IOI2 International Conference on Ovulation Induction. He also was instrumental in organizing Star Josh Exchange Conference with MOGS at Lonavala. I would now like to welcome General Secretary Dr. Vaishali Kordenai, who gave us very successful programs the entire year. She was involved in every program. Some important ones like the statewide Star Connect program, Masterclass, Annual CME, Annual Conference, and so on. I would also like to call Dr. Lakshmikant Behre, the treasurer who has streamlined the work by his meticulous ways. He has managed major transactions of conferences with great finesse. I would now like to welcome Clinical Secretary Dr. Nilesh Palkavade, Chairperson FOXI Quiz Committee. He has designed excellent scientific programs throughout the year, and the highlight being the monthly Star newsletter which was compiled by him, and it was greatly appreciated by all. I now take upon this opportunity, and it's indeed a great honor for us to welcome on stage Dr. Parag Biniwale, whose fame and popularity extends all over the country from north to south, east to west, with his vast work in FOXI and ICOG. And yet he is the epitome of simplicity and sincerity. As the incoming president, Dr. Parag will certainly take our society to greater heights.
It's my privilege to welcome on the dais the incoming Executive Vice President, Dr. Uma Wankhede, Madam. She is teacher to all of us, and I call her the GPS, Guru Positioning System. So whenever we are in unfamiliar terrain or areas or issues where we cannot find a solution to, she is the one person to go to. So Uma Madam, may I request you to kindly escort Dr. Shanta Kumari, President FOXI, and our revered guest to the dais. I have the privilege to invite a person on the dais who has an extremely busy practice, a very senior person from POGS who has done so much for POGS and even outside. Incoming Vice President, Dr. Milind Dugad, and I have to say this about him every year, one message which comes to all of us from him which says Michhami Dukhadam. That means forgive for whatever I have done. So sir, forgive us if we have done something wrong. I am put this on stage just now. I would request you to escort our revered guest, Dr. Kelkar, to the dais, please. Dr. Vijay Kelkar is with us today. Sir, we are honored to have you today here. He is an esteemed Indian economist and is currently the chairman of Forum of Federations, Ottawa and Indian Development Foundation. He was earlier advisor to the Minister of Finance 2002 to 2004 and is known for his role in economic reforms in India. So probably during his speech, he'll put some light on why so much of escalation in prices of common things that we face. So the common thing every day. So I would also request the incoming secretary, dynamic Dr. Ashish Kale, executive body member of IIG, ISAR, recipient of Kaminira Oration. I think there are very few awards left for him to take. I would request the backbone of POGS every year, who forms all the programs, is the clinical secretary. Dr. Marjorie Vansankar, please come on the dais. And I told Manjiri when we were talking yesterday what my president, when I was the clinical secretary, Dr. Charuchandra Joshi sir, told me. He had told me that if a faculty disappears, does not come, or for whatever reason cannot make it, the clinical secretary has to give that talk. So in that year, impromptu, I have given quite a few, so Manjiri, you take the baton now. I would also request the Kuber, the one who will make all the programs happen, get all the money, and I'm very happy that he's also ART consultant, because nowadays probably sponsorships only go to ART guys. Dr. Chaitanya Ganpule, welcome. Thank you all. May I now request Dr. Vaishali Kordenayak to present her outgoing honorary secretary's report. A revered teacher, a professor at Myanmar Medical College, an academician, somebody who is not only loved by her students but also by all the managing committee members, and proudly, if I may say so, and I remember very vividly my Kashi Bhai on stage. Dr. Vaishali, please.
Thank you so much, Manish, for that kind introduction. Can I have my PowerPoint presentation, please? Respected Chief Guest, President Foxy, Dr. Shanta Kumari Madam, President POGS, Dr. Parag Biniwale Sir, Past President, Dr. Sunita Tanduvadkar Madam, all respected past presidents who have joined us today, and all my friends. Today I'm here to present a report, and I'm just waiting for my PPT to start. But till then, I would just like to tell you all that I was a very naive and a simple girl when I joined, and today when I stand here, the experience of this is the team which knows you so well, and they start giving you the words for your help. It was really an enriching experience. Yes, little complicated, definitely, but it makes you, it grooms you, and it really prepares you for all the difficulties and the achievements of life, and I'm going to share it with you very quickly. Team POGS 21-22, we started binding this team with the motto, the strength of the team is each individual member, and the strength of each member is the team. And this is my team. I start with them, that they are the ones with whose efforts we could achieve what we could. This was the plan, this was the vision of then President Dr. Sunita Tanduvadkar, that we wanted to do so many things, and this was told to us in very first meeting. So I learned from Madam that how early you need to plan your year, and the vision was very clear and magnanimous. When we took over, it was that tension was there and that burden I could feel. But as I told you, gradually, we developed our logo, the She the Star, the short form of star, designing the envelopes, designing letterhead, sending those monthly communications, and gradually, as per the plan, we had 6 major conferences, and Josh was the one, which was the 7th one which we had. And Madam will tell her all, Madam will share this journey in her presentation in detail. These major conferences, रामायणात एक छोटीशी गोष्ट आहे की जेव्हा तो राम सेतू बांधला जात होता तेव्हा मोठे मोठे दिग्गज होते ज्यांनी मोठे मोठे ते दगड उचलले आणि त्या राम सेतूत टाकले. माझ्याकडे अशी खूप जण होते माझ्या टीममध्ये की ज्यांनी या मोठ्या मोठ्या कॉन्फरन्सेस खूप लिलया पेलल्या आणि माझा रोल या कॉन्फरन्सेसमध्ये त्या छोट्याशा खारुताईचा होता जी फक्त वाळू आणि सिमेंट टाकत होती आणि आमची टीम बिल्ड होत होती. And that was really a great experience. We all started in this COVID time thinking that what we could do for our patients, for our society, for our postgraduates. It was the COVID time. We all were wearing masks. We all were so afraid of having physical conferences. But I think the blessing in disguise was a small masterclass which we had started when I was a clinical secretary under the presidentship of Dr. Dilip Walke sir. We could take it to national level, making it on Zoom. And almost 150 PG students all over the country started joining it, and we could really do something for our postgraduate in these COVID times. We could also have mock viva. We knew that the PG students are posted in COVID wards. Their academics is getting affected. And we had our teachers and teachers of teachers from all over the Maharashtra coming and teaching them how to describe specimens, instruments, spots in practical examination. And it was a great session. And Dr. Uma Madam and Dr. Ameya were of great help, and the teaching program was very well accepted. POGS Rotating Trophy, a very favorite program of mine since I have joined POGS. It was again COVID times, and we were in dilemma that how we should call the students and make them present, and how the competition, it should be online or physical, we decided. And following all the norms in COVID times, we conducted this conference. This time not just 6, but 7 medical colleges participated, and BJ Medical College won the trophy. And it was very nicely conducted by Dr. Lakshmikant Bele under guidance of Dr. Uma Wankhede. Again, it was a very big moment for the students and the faculty who have joined as judges as well as delegates. I also enjoyed the program which we had for felicitation of our past presidents, that is the Pride of POGS Award. And really it was the time when we paid our gratitude towards the past presidents. And Shanta ma'am was there as a chief guest for that also. And ma'am, we thank you for always encouraging us in such ventures. And we could design a beautiful memento which our past presidents really appreciated. This was a time when I could get chance to understand the bond between presidents and secretaries, and also could know history of POGS. We could know that how the POGS has come to the present stature from the beginning. These are few clips which we could gather during this presentation, where you will see our beloved past presidents and the present ones in those era enjoying and working for POGS. These were some special treasures which I could gather during my secretary's post. And then knowing and taking the tips from the team who has won the Best Society Prize, we continued our journey. Kamath sir's party, as he received the POGS Ratna Award, was one time which I think was my privilege to be here. And sir shared few things in this evening, on this evening, and which will stay with us, that how POGS has come to it and how beautifully the society is developing. I will cherish the visit to Dr. Nargolkar sir, which was a dream to me to meet sir, to spend time, and Lali ma'am, and the affection and the love which I received that day. It will stay with me forever. We could do certain social programs and get connected with the society at large by radio programs where 4 to 5 lakh listeners could attend this program, and we could discuss about COVID times, vaccination, safety in COVID, few programs on Facebook, and they could get us a chance to get connected with the society. Even our managing committee monthly meetings was sometimes very interesting, and we had our Diwali MCM where all came nicely dressed and we enjoyed. It's a family which enjoys every festival together. Our President Madam's birthday, she does everything larger than life, and we decided to celebrate her birthday with this large bouquet which Madam called a Christmas tree, and we really had great time enjoying this. Madam has taught us so many things, from designing, choosing the colors, the pastel shades, planning in advance, doing the best are the things which we learned. I used to send those WhatsApp cards on every occasion. The card has to be with the message is hammered in my mind so much, and this is how I've got that grooming which is probably necessary for a person to work in an institution or organization like POGS. These are few best moments which I could get during this time, and I would always cherish them. Maldives, we went back like this with face shields and masks and everything, and Prasanna team made our journey and the experience over there enjoyable, and we could have some best moments of our lives. We could be at AFMC, and we are glad and thankful to Dr. Aruna Menon, head of the department AFMC, for always participating and encouraging us. At Kaleidoscope, I could get a free hand to design a completely non-academic conference, and really it was enjoyed by all the delegates, where yoga and how to develop the how to invest, how to develop wealth, to मन करारे प्रसन्न. So हे सगळे विषय आम्ही हँडल करू शकलो, आणि ते सगळ्यांना तेवढंच ॲप्रिशिएट झाले. आणि यात मला ही गोष्ट शेअर करावीशी वाटेल की प्रतापगडाची मोहीम असं आम्ही एक जे छोटं नाटक बसवलं होतं, त्याचे प्रॅक्टिस सेशन्स, आणि आमचा डायरेक्टर डॉक्टर वैभव दांगट याचं स्पेशल मेन्शन मी इथे करेन की इतक्या कमी वेळात ते नाटक लिहून ते सादर करून, आणि त्याला POGSच्या बाजूने त्यांनी ज्या पद्धतीने ओवलं होतं, इट इज रिअली ॲप्रिशिएटेड बाय एव्हरीवन. अँड फ्रेंड्स, दिस इज वॉट I really want to share it as a POGS family, that when we were practicing at IMA Terrace, our past presidents they come with कल्याणची भेळ, सुजाता मस्तानी, आणि आमच्याबरोबर बसून हा शेअर आणि हा विणाचा जो खोई तिथे आम्ही जी सेलिब्रेट केली. These are few moments which will always remain with us, and this actually builds POGS so strong as a family. And then the Pathanatya, which we could really enjoy in Josh as well. I really want to thank all of you for giving me this opportunity. I'm humbled by the trust which is placed in me by you all, and I will always would like to work hard for POGS. And as President Madam had said, that Dhira, Foxy President Madam had said that the projects like Dhira and the abortion, the respective abortion care, I want to offer Parag Biniwale sir, President POGS, that I would like to work on these things in your tenure, and we can do the dream of Shanta Madam, we can take it to other level. I would like to express my gratitude. General Secretary ची पोस्ट ही अशी असते की त्याला खूप वेळा गीता ऐकावी लागते, कधी धनुष्य खाली टाकावं लागतं, कधी चाक जमिनीत धसतं, आणि अशा वेळेस तुम्हाला या सगळ्यांची मदत लागते. त्याला सखा म्हणता येईल, त्याला सारथी म्हणता येईल, त्याला द्रोणाचार्य म्हणता येईल. आणि असे इथे सगळे इथे जे बसलेले आहेत त्यांना माहीत आहे मी कोणाबद्दल बोलतीये, आणि मी त्यांची खूप आभारी आहे. त्यांनी माझं धसलेलं चाक तेव्हा ढकलून माझा रथ इथपर्यंत आणला. आय एम ऑल्सो ग्रेटफुल टू माय पेरेंट्स फॉर गिविंग मी द करेज विच आय हॅव. I'm grateful to my husband for the support which he gave when I completely neglected my family and my house last 1.5 years. And I'm also grateful to my family who were with me in these times. These are few people who we have a thick bond with, and they were there all the time. Lakshmi, the treasurer, आमचे कुबेर म्हणजे आमच्या प्रेसिडेंट मॅडमनी जे काही फंड्स आणले होते ते सगळे सांभाळून वापरण्याचं काम आमच्या लक्ष्मीनी केलं. आणि पाठीराखा ज्याला म्हणतात, म्हणजे प्रत्येक मीटिंगला 8 वाजता माझ्याबरोबर लक्ष्मी हजर, ते शेवटच्या POGSच्या रिपोर्टपर्यंत. आणि ऑफिस सांभाळणं, ऑफिस हँडओव्हर करणं, या सगळ्या गोष्टीत जी लक्ष्मीनी मदत केली आहे, आय एम सो ग्रेटफुल. निलेश, पूजा, we are partners in crime and we will remain partners in crime, and we only know what are those crimes. Certain best moments which I had the privilege of being there. Aarti ma'am, all those MMC points, thank you so much. This is my executive vice president who is so tired working so hard, but his better half is always there to support him. These are few blessings office and staff for last 1 year, the way they have worked, the way they have supported. I'm really obliged to them. And this is POGS, which builds us all together. Our academic sponsors to mention. And now, when we hand it over to a very able team under the guidance of President POGS, Dr. Parag Binewale, we are really happy that they are taking over. And he has a very able team, and all our best wishes for their journey. And I would like to have Milind's quote here, that if there was any lacunae, if there was anything which we couldn't cover properly, I would like to beg your forgiveness and blessings for my further journey. Thank you so much. And 1 minute, please. And I want to say that I want to actually congratulate President POGS, Dr. Parag Binewale, for having newcomers in his team. And I assure them that POGS is a right place to come together, work together, and it will give you an experience of life, and that will help you everywhere, at your family, in your practice, and this is the place. And I would request all the seniors to take them under their wings and guide them appropriately. I again repeat that the strength of the team is each individual, and the strength of each member is the team. And I thank every one of my team, Sabrina, Veena, Archana, Uma madam, Aarti madam, everyone who has helped a lot during this tenure. And now, at the end, I would like to say, oh, I'm sorry. Sorry, Veena has already started laughing. She knows what it is. POGS is the best. Can someone help me to please? I'm so sorry. Yes. Now I can. Yeah. It is the thing that Milind has this dialogue that jante hona, and which we perform in the skit, and it is that dialogue which we all have to say. And POGS, and I'm really grateful for this opportunity, and I thank you all. Thank you all.
Thank you, Dr. Vaishali. You've had a fantastic year and fabulous work done by you, and I'm sure the younger POGS, MCM and members will reach out to you, because you have set a benchmark in the role of General Secretary POGS. Now I would like to call upon outgoing President Dr. Sunita Tandulwadkar, who is a source of inspiration towards greatness for every one of us. I request Madam to deliver the presidential address, and a few words about Madam. Madam's able leadership brings out the best in all her workplaces and organizations. Madam is an experienced veteran, skilled endoscopic surgeon, a teacher par experience, and she has played a role model for many young achievers in the making. Madam's organizational skills and perseverance to serve the society has brought her to the helm of various prestigious organizations, right from ISG, IAG, Vice President, FOXY in 2007. She has been active member at ESHRE, SRM, AAGL, and the list goes on. She has received numerous awards. Madam is not allowing me to complete, but I would just like to say one thing. Even during the COVID times, Madam has taken FOXY and AMOX President to Maldives for the installation. And this is something which only Madam could do. Welcome, ma'am.
Thank you.
By the time he puts this, let me take this opportunity. Let me take this opportunity to thank each and every one of you. You are the reason why I'm standing here today. When you take over as a president of any organization, may it be big, may it be small city, what is important is when now standing here, I realize that this organization has been founded 37 years ago by the leaders par excellence. They have created this organization. Over the years, so many presidents have really taken it to the height, and they are handing over to you. It's a great responsibility. And today, I feel immensely satisfied and feel fulfilled that we have done, as a team POGS, a beautiful job. And I'm doubly happy that I'm handing over to Dr. Parag Biniwale, the leader par excellence. So that is also a satisfaction to give. Parag, thank you so much for taking it. It is a Parag who I still remember called me whether you wish to go before me or after me. I said definitely not during my FOXY election. So understanding both of us together. Friends, and the organization, when you become a president, it reaches to its peak and the climax. So Vaishali has done my job so simple, beautifully presenting the work the team has done. So I'm just giving you few glimpses of me and POGS, what journey we have done. I already thanked each and every one of you for making me stand here. They are friends. They are like stars. You don't always see them, but you know they are always there. And these are my national friends, and these are my Pune clan, because of whom I climbed every step in my various organizational positions. My fellows, they make you grow in life. They teach you so many things, and you need to be lucky to have such an outstanding team POGS. I remember in the Delta wave, taking out the photograph on Manish's birthday, coming together, taking out mask on a 1 to 10 scale, just take out everyone, click the photo and mask on. What a fear we had. With the new team comes new strength and new thoughts. This was our theme of the year, She the Star. I remember our meeting, designing this, creating the long forms of sassy, talented, ageless, and resilient. Each and every team member has contributed in making this logo, and they worked for this cause for the entire year. I'm thankful to each one of them. And then we had the installation at Maldives. Again, thanking Dr. Shanta Kumari, our Foxy president, who traveled with the entire team and our friends from across the country. It was absolutely a noble idea. We were not able to do any physical meet here, and then we floated this idea, and I'm so thankful to my dear friends who took this idea ahead. The entire team POGS worked tirelessly, and then since the AMOGS president was there, we decided to have AMOGS inauguration of our zonal conference, because even Kiran was involved in this entire, who is a vice president, and that's where we had 4 days of a gala event at Maldives. And I'm thankful to each and every team member who enjoyed this and who were with us making the dances on the Maldives beaches. And Charu and Vaishali, your Lavani is so famous that it was demanded again. It always seems impossible unless it's done. When we were floating this idea, we were not sure, but huge efforts. I must say, Kiran, thank you so much. You were strong strength with me throughout. And when we were planning the activities, 7 major conferences with the COVID pandemic, our dream was to make those physical conferences, and we were not sure how it will go. We just believe that God is there with us on every step. Set a goal so big that if you achieved it, it would blow your mind, and that's happening. Today, when I look back, I definitely feel 7 conferences was a tough job which we did. The best way to predict your year is to create that year, and that's what we created with the team POGS. The Star Global CME, every conference had 1 or 2 office bearers with it, and then they were absolutely well accompanied and well helped by the managing committee, 3 members who were the joint secretary. So I see every month, every managing committee member was working for some or the other reason, and I'm thankful to it. Nilesh, along with Parag and Pooja, you have done a wonderful job. 4 pre-congress workshops, Pooja, who you handed as a joint clinical secretary, and Nilesh, along with Parag, took this conference in the peak of our Delta wave. Thank you so much, Parag and Nilesh, for that wonderful 3 days program. Then came our international conference on ovulation induction part 2, because in 2008 we did part 1, and Dr. Kundan Ingle, who was my vice president, excellent infertility consultant, who took this complete responsibility, and we did this fabulous event in JW Marriott. Again, thank you, Shanta, for coming for this IOI conference inauguration as a chief guest with Dr. Nandita, who was president-elect of ISAR, to come and grace the occasion with all of us. That was the first physical conference in the country after the COVID pandemic, and I'm so thankful that the leaders, they joined to all of us. Then again, Dr. Nandita Palshetkar, the AMOGS president, had handed over this zonal conference to us, and we were just shifting the dates because we wanted to do it in a different way, and it had 3 parts. Vaishali, along with Uma, has taken the mock Viva. It was a fantastic program for the postgraduate student, and I'm sure on a website it is there, and many will be benefited with it. And then we did a second part, was the inauguration of the conference at Maldives, and then this was a 2 days on a critical obstetrics. It was a fantastic program which we have done with AMOGS. And this was the program which we did students to attend the revision. Then came the Phytopanishad. This was conceptualized way back in 2017 when Pooja was in my cabin, and we were thinking in one of the my presidency, we will do this Phytopanishad conference. It has to be out of the blue, and we absolutely thankful to Pooja, who designed it, who created it, and she had a competition by other fetal medicine consultant at Delhi on the same dates doing, but look at the woman power that she gathered all these people, the stalwarts in fetal medicine, to be in Pune, coming from all over the country, from north to south and east to west. I am absolutely delighted to have our even ICOG chairperson, Dr. Uday Thanawala, coming for this. And we announced the workshop, and within 10 minutes, all the workshops were full. I was telling Pooja, let's hike the fee and then announce so that POGS earn more money. But Pooja was, madam, let the conference, the workshop gets full. That was this. And within 10 minutes, the workshop was full, and we both repented for not taking the higher fees for it. Then came the POGS Star Global Conference. This Star Global Conference was, I later felt regretted, we did not do the Limca world record. 70 surgeries under one platform, relying in 1,200 seated auditorium. 70 surgeons from all across the country flew down, and we had every operation theater well equipped with the 3D technologies, with the 2D technologies, with the best of energy sources and what you want. And I cannot say this conference, I cannot complete about this conference unless I thank Minal and Shitole. They worked tirelessly every Tuesday for 6 months with me to design the program, to collect the cases. It was very difficult to keep the patient postponed for the penorrhagia, multiple fibroid, put them on a list, saying some excuses with this. It's a very difficult job. And I need to thank D.Y. Patil Medical College completely, Mr. P.D. Patil, Honorable Dr. P.D. Patil, and Honorable Dr. Bhagyashri Patil, who wholeheartedly supported it, did it completely free of cost. They gave us 6 operation theater complexes from 18 operation theaters of there, the auditorium completely free to utilize by POGS, and I think they were also equally excited because such a huge, larger than life conference, 70 surgeons coming from across the country, because this was the first physical conference after the COVID pandemic. I don't know what that Omicron wave and all, I did not bother because we have decided we have to move on. And I'm so thankful to all of them. You will see them without mask, whether they had it or they did not had it. They just traveled all the way and to perform this surgery. And the most important thing is team conference. This gave me a call. Can we do it on a Zoom platform for a global also? We are ready to do it. And that was a mind-blowing. We had a global viewers and the people paying in dollars for POGS. That was a fun conference, and I'm thankful to each. A river cuts through rock, not because of its power, but because of its persistence. And that's what we realized. Then came the kaleidoscope. Dr. Vaishali worked beautifully for this design. She had a very short period because after Star Endogyne, I think every member of mine, they had a short period of a time, but they can conceptualize because it was told to them a year ago, this is what I'm expecting you to do. And involving every team member, because I felt vice presidents otherwise don't have much activity to do. Managing committee members show enthusiasm in first 3 months, 6 months, and then slowly they wave off. So it's very important as a president to engage everyone into the activity and give them a freedom to think, freedom to execute, and then the results are going to be mind-blowing. The kaleidoscope, we started with yoga. That was the first where I could just really felicitate each and every managing committee member, and thankful to Veena, Sabrina, Pooja, Vaishali, everyone who created these adjectives. I think they were doing this brainstorming, which adjective to which member, and it was a fantabulous conference. The highlight of this conference was a past president's oration. Harshad, our past president, could not have anything physically. So we decided, let's give him the best platform, and that's why we chose Ritz-Carlton. And then I need to thank MQR for completely sponsoring, because if we charge heavy, then the people will not come. And that's why we could have 500 rupees as a registration fee. And Harshad, it was a fantastic past president's oration you delivered, and we were all amazed. All the past presidents who came to attend that, they were also for the inauguration. And this is Vaibhav. I'm so thankful to you for creating, designing this Patanatya, which Vaishali has already spoken about. And it was a fun. I know I could not attend each and every fun evenings, but at least 2 we could. And Charu, thank you for that. Kalyan Bhel and Mehendle madam be there all the time to ensure that the practice goes very well. Then came the Josh conference, the Pune and Mumbai Exchange Conference. I'm so thankful to MOGS President Dr. Sarita Bhalerao. With her, we discussed nearly 1 year ago that we will be doing this conference. From January, because of the Omicron plane, we have to shift it to March, and it was a fantastic. I need to thank Bipin Pandit, who was the convener of this program. He took effort along with Kundan to go to Delhi, work out. Kundan, with the 2 managing committee members, Milind and Charu, did a fantabulous job. And Bipin Pandit negotiated the cost. And again, I need to thank Zydus. Instead of taking a sponsorship for 4 or 5 members, it was so expensive. I asked for 50% sponsorship for each and every member, and that's why we could have more than 200 members. It would not have been possible without the support of Zydus and Sudeep. And that was where we had our past Foxy president, Dr. Hema Divakar, traveling all the way for the first time. After the COVID pandemic, she came out and she said, I even forgot how to check in the baggage and the luggage. So that was a fun activity. We had it, and we enjoyed all of us together there. So thank you all the friends. And there, performing the repeat Patanatya with the MOGS Society was the brainstorming, and it was well appreciated by everyone. A dream does not become reality through magic. It takes a sweat, determination, and hard work. To organize these 7 conferences and to just present it in 15 minutes, it's not so easy. It's a lot of hard work and determination by each and every team member. We were not behind with the social initiatives. Though there were pandemic restrictions, we decided we took out 5 Foxy celebration day or days to perform, and we started with every managing committee member giving the responsibilities. Shubha Lakshmi started it. It was a peak of a delta wave. I need to appreciate Shubha walking into those roads with Vaishali and Dr. Patwardhan, who in 3 of them, 2 hours sitting without mask and addressing to each and every radio question was a marvelous job they did. And I think I need to appreciate the courage. I need to appreciate this courage. Then Leena, absolutely mind-blowing activity of tree plantation on a World Environment Day. We took 12 mango trees. I know the amount of efforts and amount of phone calls she used to make from where to collect the mango trees and how, and we decided why not to make this program every year. And mango trees were implanted at Panshet, my farmhouse, and I ensured that it is watered, and so that the next presidents can come and say, yes, it is flowering, and maybe 5 years down the line, entire managing committee can enjoy those mangoes and the fruits, and we can share it with the entire POGS. Leena, thank you so much. It was a most wonderful Environment Day celebration in my life. Then came the Meenakshi with the Foxy Girl Child celebration. When she came to know about Panshet, she first thought of, this is what the advantage of telling them all in advance. She came with this beautiful banner over there. She said, entire POGS will be there, the managing committee. Why not to take the advantage of it? And she did this release of beautiful banner, Save the Girl Child, Beti Bachao. And of course, the time doesn't allow me, but it is on a YouTube, the beautiful song. This is Vaishali's idea of getting all the mother and the daughters, or the father and the daughters coming together, and we could have all the POGS members contributing. Then we were all worried about the 3rd wave, and we decided, let's work. People say, let government work. I say, we should work. Don't bother what government will do. We as a doctor should take a responsibility and enforce on wearing the mask and prevent the 3rd wave. Again, Kundan, fantabulous song. Again, with the time, I cannot play that 4 minutes video, but every one of us took efforts and took a video shoot, and we did this Mask India beautiful project with us. Then the Foxy presidency, the year violence against women. Every one of us are breathing, eating, drinking, sleeping with this because Shanta Kumari allows us to completely bombard with that. And we all feel why we did not thought of this for years together, and we need to do something. Again, with the peak of a COVID pandemic, we decided why not to go with the Pula, who has 250,000 women from the city of Pune. Let us reach out. Schools are closed, working offices are closed. This is the way we can reach out to this. And then again, Veena taking over a complete interview along with Sonia Karnaji, the Pula, who is the brain behind this Pula platform. And it was absolutely well viewed. More than 1 lakh people, women, have seen this violence against women program. Then the Star Connect. Major conferences were one part, but we thought this has given us a global opportunity to connect with the presidents and secretaries and the managing team of entire country, all the societies, and we made the two groups, Nilesh with Amit and joint secretary with Chaitanya, and they did this. We felt a candle loses nothing by lighting another candle, and we finished all Karnataka societies. We felicitated in each Star Connect program the stalwart in the field from that state, and it was such a joyous experience to felicitate whether it is Jaideep Malhotra, Narendra Malhotra, Usha Krishnan or Meera Agnihotri. Each and every one received the felicitation, and now our Connect program is starting with Gujarat and Kerala, and I'm thankful to Parag, who has given us go ahead with these continuous series with the state conferences. POGS Awards. This is one of the most awaited program, and Shanta Kumari, when took over as a Foxy president, we first felt like, let's celebrate her. Since it is a Zoom meeting, she has already been here 2 times, let's took it. And I think POGS felicitated Shanta Kumari even before Hyderabad Society could do it. Shanta, thank you for taking out your time and accepting our felicitation. And then the pride of POGS Awards. It was felicitation of all our past presidents who have built up this. And we wanted to have a twist where their secretary talking about the president, their tenure, and though the program was 2 hours, it went on till the midnight. No one was ready to stop because it was wonderful to hear Charu Joshi talking about his president, while at the same time I and Pankaj talking about Charu Joshi. So it was a well mixture, and we were able to hear so much of a past history of a POGS. So this was the past presidents of POGS, and you will find them again, a rare collection of their photographs in our annual reports. We could get a chance even to felicitate our POGS president-elect, Dr. Rishikesh Pai, because if you are doing everything on Zoom, why not, after declaring his results, we felicitated complete team POGS. And the most important felicitation was achievers of our own society. Dr. Parag Biniwale was the secretary of ICOG, while Nilesh got elected on a committee chairperson, and Minu and Vaishali has done a wonderful job in their respective committees, and they are known nationally now because of their work. And it was so beautiful to go to the places and visit and give them these plaques. Orations of POGS, 3 important orations. Anjunalu oration, we got a chance in our Fetopnishat conference to have Professor Greg Ran, who is the authority in a fetal medicine, to give this prestigious oration. We had our past presidents, Dr. Harshad Parasni's oration, and we had also the MSR oration. Rendezvous with Jindagi Ek Safar with these stalwarts in the field of Foxy was another beautiful experience where 2 hours you are discussing how they lead to the organization, how they reach to where they are, because there is every small person can pick up something from these giants. And it was beautiful interview of their life stories, which is there on our YouTube channel also. There are many friends who are achievers. Lena, Your passion for cycling is so obvious and so palpable. I just could not stop myself putting this. It was absolutely commendable, reaching to some faraway places on bicycle. That was a beautiful journey. Uma, you are known to take the adolescent age group health awareness program, and I'm so thankful that after every program or before the program, you asked, we just discussed, do it on a POGS platform. It will give a different picture of POGS all across the country. And Dr. Amol Lunkad, we know his amount of health awareness program or fertility awareness program, he keeps on doing it. And Dr. Radha Sangamnerkar, thank you so much for sharing your all activities in the villages, what you are going to do, and you are doing already. It was wonderful to have it. We had academic achievers, Dr. Ashwini Kale, who was shortlisted in Final 5 for a Manish Banker Award in embryology. We know how much she is, and she got also elected on a ISAR embryology with the highest votes. Ashish Kale getting elected as a IAG member. Manish, you also got elected, but you did not send your contribution. So please get up and start writing. Unless you write, people cannot know, and that's why I did not include it. Ashish, thank you for becoming a clinical secretary of ISAR, because then he will be my general secretary. I myself, I felt whether I was just working for the organization, I was busy only in conducting the conferences, and I realized, I just asked my reproductive medicine fellow, what publications did we do? I'm just working. I don't know how many publications we are doing, how many got released, how many we are reviewed. And to surprise, I found in this 1 year, we did 5 publications very successfully in various national and international journals. And then the victory of our own Girija Wagh as a vice president of FOXI. West Zone, she won with the highest votes, and that gave us absolute happiness and a pride moment for each and every POGS. Girija, we wish you all the best and congratulations, dear. You deserve that. We also did beautiful publications, Star 100, the co-editors Pooja and Uma Wankhede. This is a beautiful book which has come out, and Pearl of High-Risk Pregnancy, along with Vaishali, Savita Mehende, and Brigadier Atul Seth. And I'm so happy and proud to say the JP brothers will be releasing it soon. Then the Star Connect program, news bulletin. The credit goes completely to Dr. Nilesh. When he was talking to me about news bulletin, when we met 6 months before we took over, he says, I would like to do. I said, even in IAG or MSR, my experience is first 6 months is an enthusiasm. And then this news bulletin just wave off. So we spend a lot of time, money in it. He says, no ma'am, I'll do it. And then we decided, along with him, 3 managing committee members will be given. The themes were decided 6 months prior, and every member was receiving this Star News Bulletin, either in a physical or on an EVE platform. I think entire FOXI has received. Thank you, Nilesh, for pushing me to do the news bulletin, which I felt sometimes I don't believe. And these are all managing committee members who helped Nilesh in each and every news bulletin. And I'm thankful to each one of them. I don't know inner stories, whether only their photographs came or they really worked with Nilesh. I am not here to micro-manipulate as long as the product is in front of me. I think without the academic partners, we cannot survive. And Sun Pharma, Zydus, Abbott, and Emcure, our platinum sponsor. When I told them the platinum sponsorship is 25 lakhs rupees, they were amazed. They said, this is not the history. I said, we are here to create the history. And I'm so thankful that Parag is following the platinum sponsorship of 25 lakhs rupees. Then only I think you can afford to keep the fees less, waive off the fees. I'm not here to make the bank balance. I'm here to share this all money with our POGS friends so that we can afford to tell them the conference fee as minimum as possible and can have a lot of academic program. Friends, I cannot end. I might have left few. Apologize. Pardon, it was unintentional because it's so difficult to compile the entire year in short, but I'm sure we will be releasing our annual report and you will get the glimpses of remaining things. What I'm today is because of this family. They are my roots, they are my wings, and they are my circle of strength. Without Rajesh, Rishi, and Naik family, I don't think what I have achieved in life would have been possible. And then one needs to be very, very lucky to have a great Guru, Gagangiri Maharaj, in my life. The solutions come first, and then the problem comes. He always told me, I'm not telling you it is going to be easy, but I'm telling you it is going to be worth it. Travel this path. Friends, when you are focused on being blessed, God makes it sure that you are always blessed in abundance. Allow the nature, allow the universe to shower the love by taking out your negativity around you. Stay focused, and it will not happen overnight. It is years after years, hard work where POGS has reached. Don't stop when you are tired. Stop when you are done. And today, I'm done as a president of POGS. I just declare this Dr. Sunita Tandulwadkar's Personality of the Year Award. Thank you, Parag, for graciously accepting this award. And we've decided I will be sending them how this award will go, but I felt the many youngsters who are doing amazing work in the field, which we are unaware. And it's a time that POGS invites them on their academic front, social front, extracurricular activities, and then we will be giving Personality of the Year Award everywhere. Thank you, dear friends. Thank you for your patient hearing. Thank you. Shall we release first?
Thank you, ma'am. I know the amazing programs that have happened throughout the year definitely warranted an exhaustive presentation, but if I have to sum up your personality and what you are to POGS and all of us in just 2 lines, खुदी को कर बुलंद इतना कि तकदीर से पहले खुदा बंदे से खुद पूछे बता तेरी रजा क्या है. So thank you. May I request Dr. Shanta Kumari madam to release the annual report for 2021-22. Thank you, dignitaries. The moment has now arrived for which all of us are gathered here today. Like fireworks, this universe is a celebration and we are all spectators. So I hand over to Dr. Vaishali to carry us through this very momentous occasion today.
So this is a moment of great celebration, the moment that we've been waiting for, the tradition of handing over the medallion. This signifies the passing on the continuous work of women's health to a new team, and the new team carries it forward. I request Dr. Sunita Tandulwadkar to transfer the presidential medallion to Dr. Parag Biniwale, followed by exchange of the seals.
The newly installed president is now formally endowed with the powers and responsibility of the office. Congratulations, Dr. Parag Biniwale, our newly installed president, POGS.
I think I got when this medal has come to Harshad, I realize how important it is, and it's a treasure of a POGS. One has to take care every year. We travel, we move around, we may miss here and there. So I got 2 medals because Parag is a national faculty, which has written President 2020-2023 POGS, and he can keep this in his locker with Vaishali's jewelry.
अपना प्रेजेंट आपका नहीं अपना प्रेजेंटेशन लगा तुम्हारा एक ही प्रेजेंटेशन है सबका मिला के जो अभी तक चल रहा था इनॉग्रेशन का प्रेजेंटेशन है उधर से होगा सर लगाओ ना फिर क्यों कंफ्यूजन कर रहे हो दर्शन इनॉग्रेशन का प्रेजेंटेशन
Congratulations, Dr. Parag Biniwale, newly installed President, Pune OBGY Society. This is a great moment for us, a great moment of celebration.
Can I have the next slide, please? Next slide. Next one, please. Play the videos. Yeah, play the videos. Voice.
I'd like to wish a hearty congratulations to Dr. Parag Biniwale for taking over as president of the Pune OBGYN Society. Parag is not just a dynamic, debonair and a handsome guy, but he's also very amicable, approachable, always lends a helping hand, and therefore in Foxy he is one of the most liked persons, and I'm sure most of you will agree with me on that. I know Parag and Vaishali ever since they got married, and we had met at the ICOG at Pune. Parag was a part of most of my activities in Foxy, but particularly the Young Talent Promotion Committee, where he helped me in cesarean skills, communication skills, safety first, writing, editing, whatever. So he was therefore a very natural choice for the next chairperson after me. And I remember Dr. Shanta Kumari had applied for this post, and I said, Shanta, please don't apply because Parag has already been groomed for that. And she very kindly agreed. And when Parag took over from me, and at one particular communication skills workshop, Shanta also attended, and she said, Suchitra, now I see why you said that Parag was groomed for this post. So Parag, I know you will be a wonderful president, and I know Vaishali will have to spare you for this entire year. But what I'd like to tell you is, apart from your academic activities, your social activities, and the fun and frolic which goes on with society work, I'd like to say that please do focus on some workshops for training doctors to protect themselves from injury, because we've seen that the Savior is getting injured many a times in the past few months. And also some workshops for sensitizing the public for saying no violence against doctors. So Parag, I hope to be a part of some of your activities during your tenure, and here's wishing you all the very best. Thank you.
Hi Parag, and a hearty congratulations to you and your team at POGS for your installation as president. I'm really proud of you and my best wishes, and I'm sure you will take POGS to even greater heights. Best of luck, and we are there with you in spirit. Thank you.
A very good morning to the august audience. Leadership is not about titles, positions or flowcharts. It is about one life influencing the other. So is the charisma of Dr. Parag Beniwale. His Midas touch has not only touched my lives, but of so many young gynecologists, not only in Pune, but all over India. He has paddled, promoted and patronized my small little ship through this journey in POGS and FOXY. Not only that, he has helped me and promoted on various personal fronts as a friend, philosopher and guide. I wish him all the best. I'm sure POGS is going to reach greater heights with Dr. Parag sir at the helm. Thank you.
Hi Parag, congratulations to you and Team POGS 2022. I've been told to speak a few good words about you. You are hardworking, disciplined, dedicated, sincere.
Hello friends, I am Dr. Suchitra Pandit from Mumbai, and I'd like to wish a hearty congratulations to Dr. Parag.
I guess let it play here, let it play. Okay, can we have the presentation again? We'll play the videos afterwards, not a problem. Just put the presentation.
There's a slight technical hitch. We request everyone to have some patience.
If you can give me another laptop, I have a presentation on the pen drive. Just give me one laptop, attach it here. All right. Next one, please.
Parag, I remember the day when you were installed as the General Secretary of POGS. It was the auspicious occasion of Gudi Padwa. And we all know that Gudi Padwa marks the coronation of Lord Rama when he returned to Ayodhya from his exile. Similarly, today you will be installed as the President of POGS on another auspicious occasion of Hanuman Jayanti. You know, these two occasions are very auspicious as far as we are concerned, and it indirectly says that the universe is plotting something good for you. Parag, you are one of the most deserving persons with poise, perfection, precision, perseverance, patience, popularity, praiseworthy, pristine, proficient, prolific, purposeful, the one and only Dr. Parag Beniwale. You are also pure at heart. So Parag, this shayari is for you. नीयत जिनकी साफ होती है, उनके कदमों में जमीन होती है. नीयत जिनकी साफ होती है, उनके कदमों में जमीन होती है. आसमां में उड़ने वालों को कहां सितारों की कमी होती है. Similarly, Parag, you have no dearth of stars. You have everyone in the managing committee who himself is a star, and you have Sheila Star also with you. So you are the common thread for all of us. So please soar high, not only in POGS, but in whatever organizations that you are into, whether it is IMS, whether it is ICOG, and of course in FOXY also. And I am sure that with the blessings of all the past presidents, with the well wishes of all the POGS members and your goodwill, not only with the current president of FOGSI, Dr. Shanta Kumari, who is our
Can we skip the videos and put the presentation, please? We can skip it. We can play it some other time. Okay, the next 2.5 minutes is something which I have not taken permission from the president. So if anything goes wrong or if somebody takes it adversely, please defend me during lunchtime and please be my lawyers. Next slide, please. Next slide. All right, so Parag Anand Biniwale, as we all know him, he was born on 25/4, so his birthday is coming up at Jalgaon. As a child, he is always described as a fair blue-eyed boy loved by all the girls, and this information is given by his mother. Next slide, please. Nothing has really changed. Still, he is a fair blue-eyed boy. Age could never catch up and still loved by all the girls. So hardly anything has changed. Next one, please. Loved by females across kingdoms. So what more can I say? Next one, please. He studied at Modern High School, Pune. Those of you who are from Pune would understand the boys from Modern High School and what they are capable of and what their caliber is. On the contrary, he was very sincere and well-behaved boy in school. He went to Ferguson College, and not like you all know what Ferguson College Road is all famous about and why people go to Ferguson College, but again, very differently, he was considered as a very intelligent and hard-working lad, actually sitting inside the classrooms and not on the Ferguson College Road. Next one, please. He was a true sportsman, and he was a badminton state champion, represented Maharashtra state in 1984 and All India University champion. So that sportsman spirit, the spirit a sports person has, and the calmness, the conduct is all there in his behavior. Next one, please. And then he obviously entered MBBS 1984 batch, and he was considered as the boy next door, and very approachable, very friendly, very calm, composed person, not like the Atireki people, BJ Medical College generally. 99% brings out, so I mean, yours truly is one of them, so you all realize what I'm talking about. He did his post-graduation from 90 to 92 under Dr. Medha Patankar madam, and again, he was considered even as a resident to be very calm and composed, you know, unlikely a resident who is there in BJ Medical College. Next one, please. And obviously, there was a surgical strike during that time. And ye to hona hi tha, and that is what has to happen, and it eventually happened. Next one, please. Now it is for Dr. Vaisali madam and Parag and you all to decide which one is the better half of who. Otherwise also, I am so sure that so many of the girls in and around BJ Medical College and Pune at that time would have been eyeing at Dr. Parag, but probably Dr. Vaisali could take the entire cake and enjoy it too. But we need to, you know, have a debate on that. Next one, please. Yeah, and Rab ne bana di jodi, obviously, and this is one jodi which we all vouch for. And I hope that, you know, I hope that like the movie shows the dance thing, and I always hope that both of them could dance together, and they actually did in POGs. Next one, please. This is how he started his practice way back in 1995, and now we all know that even though the Biniwale clinic is now shifted to another location, prior to that also, the Biniwale clinic was considered to be a landmark in Pune, and now people know Santosh Bakery because of the Biniwale clinic. Because when I was discussing day before yesterday, somebody said, "Acha, oh, Santosh Bakery, that is just ahead of Biniwale clinic." So that is how famous it has become, and obviously he is very respected teacher and revered faculty. Next one, please. A complete family man. They say boys are attached to mothers and girls are attached to fathers, but the reverse holds true here probably. Saurav and Akshay, they are daddy's boys, and some secrets, all of them I cannot, you know, tell here, but whenever they need a plane ticket or whenever they need something costly to be bought to, Baba is the one they run to. Next one. And he likes to explore outside and within. I have been fortunate to roam with him all around the country, east, west, north and south during our AOD workshops. When Gupte sir was at the helm of affairs at FOGSI, around 42 societies, he is one of the best person to roam around because he'll take you to every visitable place in that city. And he will not allow you to sleep at all. So, you know, my goal used to be sleep, but that is what he will do to you. Next one. He even, once we finished Ganga Aarti at Kashi, he even asked me to take a dip. But at that point in time, the water there was more black than this carpet. So I said, if I take a dip now, I will be a permanent patient to any skin specialist, which I do not want to become. He has been trained by experts in various fields. You can see Kurt Sem there and all of them. Something has happened to the names. But anyway, he has been trained and his unquenching thirst for knowledge grows on and on. Even today, he would attend PPIUCD workshops and, abortion workshops. And his zest to learn just keeps on increasing. Next one, please. And the roles have probably now reversed also because through POGS, through FOXI, through ICOG, he now trains the trainer, trains the expert. So in a way, he's come from getting trained to training all the experts. Next one, please. And there are so many contributions. I don't want to just read all the contributions. Important ones are he was the chairperson of Young Talent Promotion Committee of FOXI. As I already told you, so many of us have been really airlifted by Dr. Parag Biniwale into POGS and FOXI. He was the organizing chairperson for so many. I think YTP conference was the first conference JW Marriott ever had. And they were into construction. And I know I was responsible for the stalls there. And we used to have the night meetings there with nice coffee and all the food that he used to provide. Another good thing is he is a very good food provider. So, whenever you go to his place, you get to eat a lot of things. And best is if you meet him outside, you have to just show a face like this. And he'll take you to Pride. Pride probably happens to be the, alma mater for him to eat and take people for eating. Obviously, medical legal conference. Next one, please. Yeah, he was the ICOG secretary, as has been told, and now the vice chairman of ICOG. Next one, please. Yeah, of course. So he is also the president of Indian Menopause Society Pune chapter. So very vividly, you will see that he's worked with adolescents, he's worked with young talent, and now with the menopause guys, menopause females. So doctor, friend, philosopher, and guide to women from womb to tomb. So he's probably, taken away all our jobs, and from A to Z, he's always there. So we say there is aspirin replacement treatment when you have a heart issue. We say there is hormone replacement treatment if you have menopause. And I say there is Parag replacement treatment for everyone. Next one. All right, so he's edited various books, given keynote addresses. He's peer reviewer of Jogi and JMH. He's teacher for CPS since 2002. He was teacher for DNB 2006 to 2014. And so many orations, keynote addresses. Next one, please. And obviously, this is the Chanda Chowkadi you all know about in Pune. We all know all four of them. They are fantastic four with their remote controls. And I'm so glad I found this photo because I wanted the remote controls also to come, at least in one of the pictures. Otherwise, I know what would have happened after I came down from the dash. Next one, please. Yeah, and as I said, I always wanted this couple to dance because Rabne Banadi Jodi is all about these two guys. And they had danced, and fantastic dance they performed, and we all had, on numerable occasions, we have seen this. And this is the fun-loving Dr. Parag Biniwale, your president, who always leads by example. So if there is a dance to be done, there is a performance to be done, he'll come there, he'll be there with you and dance too. Next one, please. Okay, so what I have to just say here is Shurveer Sardar Srimant Parag Anand Biniwale Apnas Amchakadna Manasa Mujra. Play the music.
Just a disclaimer, like Manish said, for compiling this, we really did not have Dr. Parag's permission and we just went ahead. So our apologies, President Sir, if we have crossed the boundary. But this is a way of paying our respect for being our friend, philosopher, and guide. I now request President Dr. Parag Biniwale to come ahead and introduce his team and give the presidential address.
Thank you. Thank you, Manish and Vaishali. It was really embarrassing, I should say. I personally do not like to be in the center of attention, and it rather gets uncomfortable. Namaskar. Chief guest of today's function, Padma Vibhushan, Dr. Vijay Kelkar. Guest of honor, President FOXI and a very dear friend, Dr. Shanta Kumari. Immediate past president of POGS, Dr. Sunita Nandurwadkar. my office bearers and managing committee members, office bearers and managing committee members of 21-22, all the past presidents in these, of these esteemed organizations who are here today, my teachers sitting here in the audience, ladies and gentlemen. Thank you for choosing me to be the 32nd president of our beloved organization, the Pune OBGY Society, which now enters the 70th year of its inception, and I accept it with great humility and responsibility. First of all, let me congratulate team 21-22 led by Dr. Sunita for performing so well in spite of the COVID pandemic. Today is an emotional moment because I am reminded of this gentleman, late Dr. A.V. Umranikar. When I joined the Department of OBGYN as a houseman way back in 1990, the first instruction I received from Dr. Umranikar was to become a member of Pune OBGY Society, and I became one without asking any questions. I miss you, sir, today, and he has been an idol ever since. I had never imagined that time that I will be occupying the same chair that he did so many years ago. I must salute all the past presidents who have put in so much effort in taking the Pune OBGY Society at this stage. My journey in POGS as a managing committee member started in 1996. I'm happy that Dr. Kamath, who has also seen me growing for last so many years, is here. Of course, I continued to be an office bearer, co-opted member, then as an ICOG office bearer. Thank you, Dr. Sanjay Gupte, who has mentored me into Foxy ICOG, and now as your president. The turning point, I always say, in my career in POGS was my appointment as General Secretary for the year 2002. And it was a great learning experience for me working under Dr. Subhash Nargolkar. Unfortunately, he is unwell and he cannot make it. Thank you, Dr. Ranjana Nargolkar, for being here and for all the pampering that you've been doing for last 20 years. I learned discipline, I learned team spirit, and a favorite term of Dr. Nargolkar was our POGS, which says a lot. My journey in POGS continued as Vice President with Dr. Mohan Paranspe and Dr. Arun Fadnis. I must make a mention that Pune OBGY Society won the Best Society Award with Dr. Arun Fadnis as President. It was a fun moment for me to be with my teachers, Dr. Anand Bhalerao, Dr. Savita Mehndare, and Dr. Aparna Shrotri. When they became president, I always remained young because I was their student all the time. And my journey in POGS was enjoyable because of these friends, Dr. Charu Chandra Joshi, Dr. Bharati Dore Patil, Dr. Dilip Walke, and of course, Dr. Harshad Parasnis. Being a healthy woman isn't about getting on a scale or measuring your waistline. We need to start focusing on what matters. This is what Michelle Obama has said. We know the different role a mother plays, a wife plays, a daughter, she's a sister, a working lady, and this list continues. A woman has so many roles to play each day with a bunch of responsibility, be it at home or work, she does it with a smile. But are we taking adequate care of our women? We know the challenges that we face right from intrauterine period. We still have a lot of sex-selective abortion taking place, endangering life of female feti. There are so many challenges the adolescent girls even face today, right from nutritional disorders to unsafe sex practices, substance abuse, alcohol, tobacco, not to forget mental health concerns, injuries, violence, and unintended pregnancies. Our mothers are still dying, though Maharashtra is doing a little better off as compared to the country statistics, but still, as Dr. Shanta Kumari said in her address, that no mother should die during childbirth. WHO has recognized so many key health issues as far as women are concerned. Violence is one of the important ones. Let's not forget the non-communicable diseases which are killing our population. The elderly women face a lot of challenges. We know that with increased longevity, women are going to live longer, and there are silent killers like osteoporosis and gynecological cancers, which we must deal with. So time has come for all of us to have only one focus: to improve women's health. And for this, the theme this year that we have is Her Life Counts. Small steps are still steps forward. Your speed doesn't matter, and that is what we believe. Maternal health, what we in POGS 22-23 are planning to do, this installation conference, which talks about Paripurna Matrutva, and it focuses on common aspects of maternal health. We've planned some outreach programs on the outskirts of Pune and even at Taluka places every month, where we will be discussing key issues related to pregnancy and childbirth. Infertility is another challenge, though it's not my cup of tea, but we do come across a lot more infertile patients coming to us with a lot of impact on their mental health. So for that, we have conceptualized the UIRT conference, which will be held in the same venue on May 21-22. It is a brainchild of my clinical secretary, Dr. Manjari, and joint clinical secretary, Dr. Amol. We will have orations, symposia, dialogues, quizology, and a special session or a workshop on ART bill, which really needs a lot of brainstorming. Gynecological endocrinology is something which all of us must be aware about, because PCOS is something which is so common in day-to-day practice, and so are thyroid disorders. We do intend to have a conference on endocrine problem in obstetrics and gynecology, which will be held on the 2nd and 3rd of July at the Hyatt Regency. The conveners are my treasurer, Dr. Chaitanya, and Vice President, Dr. Milind. Endometriosis once was thought to be a condition of the West, but it's pretty common even in our setups, and it is causing a lot of challenges to women of various age groups. To understand more about the challenges of endometriosis, we bring you Endomet 2.0, which will be held in the month of October. It is the baby of my General Secretary, Dr. Ashish, and Dr. Prakash, who is the Joint Secretary. Lactacon, I must say, is one of the signature events of POGS. It has been there for many, many years, and that is thanks to Dr. Mangala and Dr. Charu, who will be in the helm of affairs this year for this particular event. And of course, our prestigious annual conference, which will be on safe surgery and techniques, to be held in the month of December with Dr. Milind Dugad and Dr. Pankaj as the lead. We continue the postgraduate teaching, and the masterclass will be held on the second Thursday of every month on a virtual platform, because we thought during the COVID times we've accepted virtual platform as one of the good platforms to reach out to people remotely. So the idea is to have an interaction between our students and teachers from various parts of the country. And I'm happy to say that my first masterclass was held on the 14th of April, where we had two examiners, one from Delhi and one from Kolkata, grueling our students, and our students lived up to their expectations. I must thank the conveners, Dr. Uma Wankhede, Dr. Vaishali Korde Nayak, and Dr. Nilesh for flawless conduct of this program. I'm happy to announce that because we are talking about Paripurna Matrutva, we have made this conference free for postgraduate students of teaching institutions. Of course, the forthcoming PG activities will have the Foxy Dr. Usha Krishna quiz, which will be conducted by Dr. Nilesh Balkode, who's the quiz committee chairman of Foxy, and of course our prestigious rotating trophy, which will be conducted by Dr. Uma under the guidance of Dr. Charu Chandra Joshi. There are quite a few social programs planned. We intend to have adolescent education programs. There's a discussion about checkup and awareness camps for police, wives of police and police women. Breastfeeding awareness program, again, which Dr. Mangala has been doing for years, will definitely continue. My personal favorite area, the menopause and midlife management. And of course, we intend to reach out to rural areas where Dr. Vaibhav has assured me his help throughout the year. We will have liaison with the government as far as advocacy and training is concerned, and I'm happy to say that one of the governing council, one of the managing committee members of POGS, Dr. Madhav Kankavle, is currently the civil surgeon of Pune. So with his help, we will certainly train medical officers of Pune district and of Pune Municipal Corporation as well. POGS turns 70, and I did appeal to all the past presidents to introduce new awards, and these will be named after the POGS and the past president. The sole idea being the past presidents who have done so much for the organization should be permanently bonded with the POGS. And I must say that so many past presidents have generously accepted to donate prizes, and these will be introduced this year at the annual conference. And of course, office space is something which is very much in our mind. We cannot forget the burning issues and violence against women in India. It is so rampant, and it has become more and more evident during the COVID times. There is certain gender inequality and increased incidence in domestic violence, especially noted during the lockdown. And Shanta, here I would like to tell you that we are committed to Dhira, and we in POGS fully support to all activities of FOXI, not only Dhira, but otherwise also. Violence against doctors is something which is really grueling and very, very disturbing. We did have an opportunity to join hands with IMA. Thank you, Dr. Meenakshi Deshpande, President of IMA, for tagging POGS along. And to avoid this, we are creating quick response team, and I must thank the Vice President, Dr. Milind Dugad, who acted so promptly, contacted all these members, and all the members have gracefully accepted our invitation to be part of the quick response team, and these people will certainly go to the place where there is a mishap. Of course, there would be a training program for the people who are going to be part of it, and I'm happy to say that Dr. Dilip Walke and Dr. Manish Matswe have agreed to help us in this matter. So thank you, my team 22-23, for agreeing to be me. When Ashish contacted me about 3 years ago that he wanted to be a secretary when I become president, my first advice to him was, I'm going to be a tough president, so it's not easy to deal with me. But thank you, all of you, for joining hands with me. All the past presidents who have put in so many efforts to take this organization where it is, and I'm happy that so many of you are here today on personal invitation. All my teachers, I must mention Madam Mendale, Madam Shrotri, Madam Barucha, who are here today on my invitation. Thank you very much, madams. These are the people who have taught us principles and correct practices of OBGYN. Thank you, my family. My son, Saurav, is here. My extended family, who are also here. And my other son, who's watching me virtually, sitting about 12 and a half hours behind us. I cannot talk anything about Chaukadi. All has been said, but they are my pillars of strength. Women are extremely important shapers of my own life. This is what Tony Hillerman has said. But I cannot leave this without mentioning 3 women. First is my mother, who gave birth to me 55 years ago today, on the day of Hanuman Jayanti, a homemaker who played a significant role in encouraging her 3 sons in becoming doctors. My teacher and postgraduate guide, Dr. Medha Patankar, who's here, who taught me the surgical skills and values of ethical practice, and to whose daughter I remain happily married for last 29 years. And what can I say about Vaishali? Shanta, I will just use the term that you used. She's my Shakti. She's always there with me in whatever I do, and she's my best critic. That's what I always say. I would end my talk by this quote: miracle starts to happen when you give as much energy to your dreams as you do to your fears. So ladies and gentlemen, let's dream of a healthy nation with healthy women, and I'm sure with energy that you all give, the miracles are definitely going to happen. Thank you very much. I take just 2 minutes to introduce my team. The President-elect, Dr. Meenu Agarwal, who chaired the Imaging Science Committee recently. She's not here today because of a family wedding. My Vice President is Dr. Milind Dugad. When you have a Vice President who's your close friend for last 40 years, it adds a certain different flavor. Thank you, Milind, for always being with me for last 40 years. Dr. Uma Wankhede, who will be the Executive Vice President, and I always say that Uma is my first teacher in OBGYN. Way back in 1986, when I did my first OBGYN posting, Uma was the one who taught me how to conduct a delivery and how to suture episiotomy, and that is how I got into this field. What can I say about my General Secretary, Dr. Ashish Kale? You've seen him all for all these years. My Clinical Secretary, Dr. Manjari Valsankar, though an ART specialist, is taking interest in obstetrics and other things also. And my treasurer, Dr. Chaitanya Ganpule, another excellent endoscopic surgeon and ART specialist. The three joints, Dr. Prakash Kothawade, may I request all of you to stand so that everybody sees you. Dr. Amol Lunkad, who's the joint clinical secretary, and Dr. Rahul Argade is the joint treasurer. Coming to my managing committee is a perfect blend of seniors and newcomers. Seniors who can become president anytime, and the new ones, there are 6 of them, who have joined the Pune OBGYN Society for the first time. Dr. Charu Bape, Dr. Vaishali Chavan, Dr. Archana Pungalia, Dr. Shubhalakshmi Kurtakoti, Dr. Pankaj Sarode, Madhav Kankavle, Vaibhav Dangat, Chinmay Umarji, Leena Patankar, Vaijayanti Patwardhan, Amey Chug, Mangalavani, Veena Todkar, Pooja Loda, Arti Nimkar, Arti is not here today, and the 5 Panchakanya, that's what I say, Manasi Naralkar, Samida Dalvi, Kanchan Durukkar, Madhu Juneja, and Mansi Sharma. The team is not complete without the ex officio, Dr. Sunita Tandurwadkar as immediate past president, Dr. Vaishali Korde Nayak, who has to continue working hard the way she has done, and of course, Dr. Lakshmikant Behle, who was the treasurer last year. 3 of the FOXY committee chairpersons are very, very important. Dr. Manish Matswe, Dr. Kundan Ingre, and Dr. Nilesh Balkavade, who are doing excellent work even in FOXY. What can I say about AMOG's VP? Sunita has said it all. Kiran, thank you for always being there. I'm happy to co-opt, and this is for the first time we have co-opted President of IMA Pune, Dr. Meenakshi Deshpande, who's here with us. And I also thank co-opted members who've agreed to be part of our team, Dr. Hemant Deshpande, Dr. Samir Darode, Colonel Bidhan Roy, Dr. Nitin Sangamnerkar, Dr. Girija Wagh, Dr. Ruchi Thakur, and Dr. Vaishali Biniwale. Thank you.
Thank you very much, sir. It is said, वफा की कभी गुजारिश नहीं होती, प्यार की कभी आजमाइश नहीं होती, कुछ तो हमारी भी किस्मत खुल गई है आज, वरना ऐसे सितारों की हम पे बारिश नहीं होती. Thank you for your talk. May I request Dr. Shanta Kumari ma'am to put the oath and give us the oath.
I think now we have the most important aspect of the installation, the oath of POGS Managing Committee installation. I solemnly pledge my allegiance to the Constitution and the bylaws of Pune Obstetric and Gynecological Societies, POGS. I promise to carry out all work and duties assigned to me and work in unison with the President and members of the Managing Committee. I shall strive to maintain the dignity and honor of POGS.
I shall strive to maintain the dignity and honor of POGS.
I shall abide by the rules and regulation of the PNDT Act.
I shall abide by the rules and regulations of the PNDT Act.
I shall not indulge into sex selection, sex determination and sex-related abortion.
I shall not indulge into sex selection, sex determination and sex-related abortion.
To this I swear with the utmost sincerity and nobility.
To this I swear with utmost sincerity and nobility.
Thank you for taking the oath, and I wish you all the best, team.
Thank you, Madam. I now invite all the dignitaries on the dais to come forward for the lighting of the ceremonial and traditional lamp. Like inaugural ceremonies, commence with the lighting of the ceremonial lamp. Lighting a lamp amounts to awakening the Atma Jyoti, that is a glow of the soul within oneself. The serene aura around the lamp represents the Atma Prakash, that is the light of the soul, while the predominant light of the lamp represents the Atma Tej, that is radiance of the soul. By lighting the lamp at the commencement of the function, the Gayatri principle is invoked. Like the light spreads to every nook and corner, so will the knowledge. I request all the dignitaries to take their seats on the dais.
Thank you, dignitaries. I would now request, as you have seen, witnessed, and also it came in our president's talk, that he and the vice president, so Dr. Parag and Dr. Milind are, friends together. We call them Jay and Viru, and we are just waiting for the Gabbar to arrive. Anyway, so I now request the newly installed Vice President of Pune Obstetric Gynec Society, Dr. Milind Dugad sir, to please come on the dais here and introduce formally to us the Iron Lady of Foxy President, Dr. Shanta Kumari Madam.
Good afternoon, ladies and gentlemen. It is indeed a proud privilege to introduce this tall personality, Dr. Shanta Kumari, who has been leading us as President of Foxy in the year 2021-22. She is treasurer of our international organization, FIGO. She has served in many positions as FIGO member for Committee for Human Rights, Refugees and Violence Against Women in the year 2018 to 2021. She has served as our organization, national organization, before becoming president as the vice president of Foxy into the year 2013. She has been chairperson of Foxy ICOG wing in the year 2018. She has been national corresponding editor for our journal in the year 2011 to 2013. Madam has many awards and achievements to her credit. She has been awarded FRCOG by UK in 2018, FRCPI by Royal College of Physicians of Ireland. But we know her, and we will always know her for her work, which is initiated by her, Dhira, in the year 2016, a socio-medical campaign to eliminate violence against women. And this was the theme of Foxy in a year to work against violence against women. She has been awarded Lifetime Achievement Award by the Hyderabad Society, Foxy Star Award in the year 2017, Pride of Foxy Award in the year 2019, and the list will go on. We have seen her organization skills. We need to present all this, Madam. We have seen her organization skills in the ICOG 2011, ESAR 2020. The things will go on. It's indeed a proud privilege to have you, Madam, most efficient leader with ever smiling face who works with perseverance and passion. Thank you so much.
Namaskaram to everyone. Thank you, Milind, for your kind introduction. And sorry, I was getting very restless. I think it's indeed a pleasure to be here with our chief guest, Dr. Kedkar sir, and all the seniors who are here. Dr. Sanjay Gupte sir was there, and he just left. Dr. Joshi and all my seniors here. Dr. Parag Biniwala, President of Pune OB-GYN Society, Secretary Dr. Ashish Kale. I thank the whole team for having me here at your installation. My dear friend, Dr. Sunita Tandalwarkar, who is now the immediate past President of POGS, and Vaishali, and the whole team of theirs too. It's been really, I think, a pleasant trip from Hyderabad to Mumbai to Pune, and I didn't realize that till I came that I think literally for all the programs I've been here with the Pune OB-GYN Society. I think this is third or fourth program of Pune OB-GYN Society. After taking over as winning the president election, I'm here, right from Dilip Valke's year to now Parag taking over as the president of Pune OB-GYN Society. My relationship with Pune OB-GYN Society dates back to the time when I entered Foxy, and we all five of us actually used to be very close. Harshad, Dilip, Kiran, Parag and myself. And we used to call them the boys of Pune, my team in Hyderabad. And we really used to have a lot of fun. And let me actually share with you now. I entered Foxy in 2004, in Hyderabad Society, and 2005 I did the first UO Foxy conference of it at Hyderabad. And that day I decided, okay, I'm going to enter Foxy. I'll become a chairperson. So I saw all the committee names. Then I found the Young Talent Committee chairperson sounding very interesting. I thought, I'm also young, I was in 30s. So I should become, this is sounding very good. Others are all looking very, very big and difficult. I was already in one or two committees. Then I decided, I declared I'm going to be the chairperson for this. Then so many people started coming. Suchitra mentioned. Suchitra came and told me, no, we all, Parag worked a lot in this committee, and I have decided I am the chairperson. That is, I said, so what you decided? No, I have decided. I have decided to go. What you decide is your choice. What I decide is my choice. Doesn't matter, okay? It doesn't matter. If I win, it's okay. Otherwise, it's okay. I'll try again. Don't worry. That's what I told. Then so many people started coming and telling me, right from Sanjay Gupte sir to Nozer to PK Shaw and so many other people I don't know. Also all the topics. So wondering why they're all after my life. I decided one nice committee, it's sounding nice, young talent promotion, and all this dadas of Foxy are coming and tell me not to contest for this. Then it was in the Calcutta conference. You remember Parag? Vandana Valvekar. I love Madam. She came and said she wanted to talk. And that day in the conference, actually, I felt very sad that Vandana Valvekar Madam had not become the president of Foxy. And we were very close to her because I know her from Manipal time. And then she said, no, Shanta, you come, sit with me. She called Parag and she said, you two are good for the organization. So I don't want one of you to get, I think, to be seated in the back row and only one go. Two of you should be in Foxy. Then when she told that, somehow I felt, what, when Madam is telling, there must be something in this. I said, TK Madam, you are telling, I'm going to listen. Then I said, okay, all these people, I'm going to contest. Now, whichever committee, now nobody dare contest against me. I have to go unanimous. Agar koi aayega, then I will. I didn't know Foxy people, I was like my own boss. And in fact, I think 5-6 applications were there for that. I mean, I knew that, but finally all of them withdrew. And I became a committee chairperson of that medical nomenclature, norms, records, research committee of Foxy. Uska meaning, idea, vision, mission, I never understood that day or today. And after I finished, we decided, on my last committee, I said, now this committee has to be closed because there is no meaning for this committee. So that's the history of our chairperson post. And we were all actually together and we used to have a lot of fun together. Parag and all of us, 5 of us, we really enjoyed our chairmanship post and we used to go to many conferences. We have come to Pune also so many times and so many. I think that bond was there with us, which remained, and that is the reason I think whatever we are, and when Parag said, you have to come, and of course Sunita is a very close friend. I've been with her throughout in her programs. And Ashish is a very, I like Ashish from the beginning. I don't know why. Sometimes, it's very, I'm a very different person. If I like, for me it's all or none. If I like, I like. If I don't like, they don't exist. For me, that's it. It doesn't matter, You can't like everyone. That is a normal human being. It's very, I cannot be a Mother Teresa. I'm sure she also wouldn't have liked some people. So that's a human nature, I suppose. So that's how it is. And the whole team of POGS, all my chairpersons are here. Many are here. Kundan is there. Then Nilesh and Manish and anybody else. I hope I have not missed. Are there. So it's a very nice being with POGS, and only thing was so many things happening because we lost about 1.5 months for the COVID, and suddenly everything became very tight. Niranjan had invited me and blocked today date for MOGS for installation almost a year back. And then when Parag called and said, you have to come for the installation, I said, can we do it on Sunday? He said, no, you don't know, Padma Bhushan sir is coming. How can we ask him to change the date? So Dr. Kedkar sir was the chief guest, so we didn't have the audacity to ask him to change the date. Now what to do? I have to come here. And Niranjan says, no, how can you go? You have to come and stay with me from Friday evening to Sunday morning. Sunday you go to Pune. Parag can't change the date. Then I told him finally, I said, Niranjan, Tusun, I am going to Pune, that's it. Your oration I'll keep on Sunday. I said, no way. I'm going to Pune in the morning, I'll come in the evening to MOGS, my oration will be there. If it's not there also, doesn't matter, I'll be there in your installation and I'll go. So that's how I'm here. It was nice to be here, and congratulations to the whole team. And POGS is doing good work, do more good work. And there was one small statement which if everyone noticed in Parag's installation speech, there is still sex selective processes are happening, and sex selective abortions. I think that is something which we condemn, and the fact that your president has brought out this point means something is wrong somewhere in the surroundings. So if you find that anybody is resorting to such unethical, unlawful, illegal activities, kindly bring it to our notice so that we will take the proper action, We will regulate them. We don't need somebody to regulate. We don't need government also to regulate us. We can regulate them. We will see how they will continue to do such illegal things. We will not let anyone do such illegal activities as a FOXY member or as a FOXY, as an obstetrician gynecologist. And please bring it to my notice. Adequate action will be taken. I don't want government or some other person to come and catch these people. We should be the people who will be regulating ourselves. So I'm sure by the time you give your outgoing address next year, this statement and this slide should not be there in the presentation. I think I request all the POGS members kindly see that we weed out all these antisocial elements. They may not be doctors also, they may not be our colleagues or whoever it is. Don't get worried, don't get scared. Please bring it to the notice and adequate action can be taken. So thank you for having me here, and all of you. I can understand the role of women in your life. So we also are very happy that we are also some more women in your life by default. Okay, Sunita, me, Vaishali, and all of us who are here. So we wish you all the best, and the whole team. Please do good things, and Pune OB-GYN Society always is a very strong partner of FOXY. And when I did the AICOG conference, Sanjay Gupta sir was the president, FOXY. Girija was the joint secretary of FOXY, 2010. So we had worked very closely for the AICOG with full cooperation and coordination, and I think that was also very instrumental in the success of my AICOG at Hyderabad. So we look forward for your cooperation when we do the AICOG again, when I'm going to do in 2024, and invite all of you all to join us in big numbers at Hyderabad soon. And thank you all for your support. It's your love and affection and everything which gave me the strength to become the treasurer of FIGO. I have to again thank Sanjay Gupta sir. C.N. Purandare sir has been the role model. And thank you all for being there with me so that FOXY is represented globally in FIGO. Thank you very much.
Thank you so much, ma'am. I would request President POGS Dr. Parag Biniwale to felicitate Dr. Shanta Kumari, ma'am. I request the office bearers, please join.
Thank you, Shan. We are here presenting another small plaque, and this is for your influential organizational leadership, inspiring commitment, and passionate perseverance towards healthcare in recognition of your ongoing services. Presented to Dr. S. Shantakumari, President FOXY, guest of honor for today's program. This is from POGS 22-23.
Thank you, dignitaries. I request all of you to take your seats on the dais. I request Executive Vice President, Pune Obstetric Gynec Society, and my teacher, Dr. Uma Wankhede Madam, to formally introduce Dr. Vijay Kelkar, sir.
Good afternoon. It's my proud privilege to introduce Padma Vibhushan, Dr. Vijay Kelkar. When I searched the Wikipedia for his biodata, I was amazed of his contributions to economics of India. And I have been given only 1 minute for his introduction, so I didn't know what to introduce. So many things are there. So Sir is currently the chairman of Forum of Federation of Ottawa and Indian Development Foundation, New Delhi. He is also chairman of Janvani, a social initiative of the Maratha Chamber of Commerce, Industries and Agriculture of Pune. Sir's main field of interest is macroeconomics and public economics. Sir is also trustee of the Sri Satya Sai Baba Trust of Puttaparthi, Andhra Pradesh. Sir was also chairman of Finance Commission till January 2010. Sir was earlier advisor to Ministry of Finance in 2002 to 2004, and he's also done a lot of economic reforms in Indian economics. Before this, Sir was Finance Secretary, Government of India, 1998 to 1999, and in 1999, Sir was nominated as Executive Director of India, Bangladesh, Bhutan, Sri Lanka on the board of the International Monetary Fund. Sir has also been awarded the prestigious Padma Vibhushan from the Government of India in 2011. Sir has done his engineering from RCOEP. Sir has done his MS from the University of Minnesota, and later Sir did his PhD from the University of California, Berkeley. Sir has taught in Hyderabad, Kathmandu, Germany, and also the University of California, Berkeley. He has held various senior positions like Chairman of the National Stock Exchange of India, Chairman of Indian Development Foundation, Chairman of the 13th Finance Commission, Secretary to Ministry of Petroleum and Natural Gas, Secretary Economic Advisory Council of PM, Government of India. So Sir has done a lot for the economics field of India. Sir has headed various committees like the Kelkar Task Force, which recommended the GST, Kelkar Committee for the Public Partnership of India. So, ladies and gentlemen, I present to you Dr. Vijay Kelkar, Padma Vibhushan, Dr. Vijay Kelkar.
Dr. Shantakumari, the distinguished guest of honor today for our function, Dr. Parag Binewale, the new president of POGS, Dr. Vaishali, Dr. Smita, and Dr. Kai, and of course, all the distinguished members of the society and the distinguished audience who's here. Let me first thank POGS and Dr. Parag Binewale for inviting me. And I particularly want to thank for very generous introduction. And I'm very grateful you did it because my wife is also here. And at least it improved for next 24 hours domestic politics in the house. I didn't realize about this organization. I didn't know much about it, but when I heard this whole morning, I was truly, truly impressed by the great commitment you have about your profession and your professional sort of excellence. I have a particular interest in the organization. I was born in a, what you now call, a non-institutional setup. And I had a problem of what you now call neonatal complications. And the only reason, that's what my mother told me, that I had neonatal problems. And the only reason why I sort of survived because I had a very good doctor attending me, which was my grandfather. So I have great interest in neonatal, and that got particularly kindled because I had the great fortune to be for 10 years chancellor of a medical university in Pravaranagar. And there, and I think I would really like to acquaint you, we have an incredible program of working in tribal area, which is, many of you know Bhandardara Dharan and their backwaters. And this university helps these areas, and there are about 150,000 households. And one of the major work we do is really run a neonatal center in our university. And I really hope that POGS can sort of help us out, because one of the best unit I've seen, because then I got interested, like one which is in the Mangeshkar Hospital, which is run by Dr. Joshi. I don't know whether it's still there or not. I visited a few years ago. And there the recovery rate is almost 95%. Ours is still only 2/3 of that, and really one of the endeavor of the university is to make it as good as Pune. So it will be great if POGS can help this university, because there is a remarkable work going on. It's a private university, but the dedication which was there, which was started by the founder, it still continues. And there's one area which I would hope in one of your future work program you may wish to do that. I was also listening very carefully the number of interest things you do. In addition to neonatal challenges you may wish to consider, other important issue which I didn't hear in this morning, but is the postpartum psychosis and related problems. And that's not as small as you think, because the data which you saw, which I've seen, almost 1 to 2% of women are prone for this challenge. And this is quite serious. So you may wish to consider at some point of time, look at this important challenge. Today, what I thought I share with you my own sort of current preoccupation and my recent preoccupation. It is incidentally, I'm the only one who really should not be called doctor here, because here everybody is the most useful doctor, and I'm just a mere economist, which I did. But most of my work has been in the area of policy making for several years. So I've been working on the health areas. Health area for a policy economist is an extremely interesting problem. Very difficult issue. In fact, even the developed countries has not been able to solve the issue of health. And India is even more difficult because of poverty. My first encounter came when I was dealing with regulation of pharma industry. Now, many of you, for you probably even history, but in the 80s, there was so much control on our pharma industry that we had problems of non-availability of pharma, quality, what was not there. For instance, we didn't have adequate vaccines because price controls, and enormous amount of what I found out, what is irrational combination was another major problem in that. So we looked at it, and at that time I had the misfortune of regulating all the pharma industry. And one lesson one learns in working in a policy making, there are some simple insights one gets and which one applied for pharma industry. There are 3-4 insights I want to share with you which I learned, and then I'll come to how it worked in the pharma industry, how it helped me. One simple insight is in economic life, incentives matter. People respond to incentives. So you have to think about incentives a little carefully. Second is competition is usually very good, not only for consumers, but also producers and the industry. And policy should be so designed that it should nudge the economic agents towards better outcome. So what did we do for pharma? As I said, pharma problem that time was ubiquitous price control, scarcity of drugs, substandard drugs, irrational combination, and no incentives for new technology. For instance, my wife who is here, she had to go around almost all night just looking for anti-rabies vaccine. And it was not just hers, but it was a problem all over. So, non-availability of vaccines. So, we had introduced a new reforms program for pharma. And really, if somebody asks me, what did you do in your life in working in the government? The only thing I'm really proud of is in many ways those reforms which were introduced led to the India's pharma industry. Today, India has the largest producer of vaccines in India because we just abolished all the price controls. And you saw that what happens by taking towards the pharma industry in a very, very sort of bright star of Indian economy. So that was my sort of encounter with the industry, and it really has very, very useful contribution one could make by very simple tweaking the price controls for on vaccines. Now I want to talk about my current preoccupation. You know, when I told my daughter I'm going to come and speak here. You know what she told me, Parag? She told me, Baba, you wear safari because then people know what is vintage is. So, which I did dutifully did, but nobody these days wears safari suits. So that was a useful trip. But even now, we are still involved with, because of this vintage, one gets invited by the government to look at the policy problems. And recently, the government of Maharashtra, after COVID issues which came up, has approached currently I'm involved in an organization called Pune International Center, which is a policy think tank, to look at the public health of Maharashtra, how to improve the public health of Maharashtra. Because a major problem is, all of us know, is affordability and accessibility. So I thought I'd share with you what currently we're thinking about and leave this thought with you because some point of time we'll come back to you as an organization to help us out, to think how do we improve our public health delivery system and our levels of quality, affordability and accessibility. And the one strategy we're thinking about, they revolve around what is now sort of well-known sort of concept in other sectors, but not yet done in a public health, is public-private partnership, or what's called PPP. And that's what we're really now thinking about. And I want to share with you some of the thoughts which currently one is working on using this concept. And all of us are aware of it, and you are probably more than I am, but I thought I'll give you some numbers. That COVID really brought out complete inadequacy of our country in the area of public health. In India, we spend only 1% of entire gross national product on public health. And even health expenditure, more than 2/3 is spent by citizens themselves. Out of this, 75% is spent in urban areas and only 25% rural areas. So there's complete inequality in our public health availability, and also it's completely inadequate. In fact, even up to WHO's minimum standards, we don't even meet the 2/3 of WHO standards. Now, the concept which we are using is called public-private partnership, is practiced in a number of areas in infrastructure like roads, has been successfully done by our very, very dynamic minister, Nitin Gadkari, and very, very effectively. Is being used in the area of education, in the area of airports, and we believe that it can be used very effectively in the field of public health. Now, public-private partnership is really simply defined as a variety of cooperative arrangements between the government and the private sector to deliver goods and services to meet the needs of citizens and society, of the community. Now, we believe, and this is what we are proposing to Maharashtra government, that healthcare offers excellent opportunities to utilize public-private partnership to create better health outcomes in Maharashtra. Because private sector will bring expertise, finance, efficiency, innovation, and technology, and government can bring initial capital, land, and regulatory standards. And also now, through the policy for what they call CSR, or corporate social responsibility. Now, in public-private partnership, there are a number of models. One is simple model of operation maintenance contract, which government sort of gives for running hospitals. Or second is a build and operate and transfer. Third, leasing, and second, joint venture. But achieve this public-private partnership objectives, you've got to require a good regulatory system, but even more important is require cultural change in the government and the bureaucracy. Because it's a partnership. So public-private partnership requires different thinking. Government has to think more of a, instead of transaction, is a relationship between the government and the producer. So it requires more trust, more what you call approach towards treating as a partner rather than a transaction with the private sector. So with this new approach, what we believe that at Maharashtra can be a trendsetter to become a much larger sort of supplier of public health services. Now, the importance in the organization like yours in this public-private partnership would be, I think, very critical in persuading the government that we can improve the services for area of where you work in, which is essentially the women's health, as pointed out by earlier speakers, and the other areas. So my request to you would be to help some of us who are trying to use this new technique of a new institution called public-private partnership for improving public health outcomes in related to women's health, and also there's two areas which I mentioned, which is the neonatal. I think somewhere I saw a data that who presented just now data on the mortality rate, MMR rates. They're still too high, and we had to find ways of reducing it, particularly in the poor sections of society. So my last point relates to which area which I mentioned, which probably your institution can work on is this postpartum depression and postpartum psychosis. Because I've seen a number of tragedies which I think are totally avoidable if given proper counseling and proper help by you doctors. So once again, I want to give my thanks to the POGS for inviting me, and to Parag. And the reason Parag invited me, I must share with you the secret, because our relationship with the family goes over last 3 generations. And his grandfather and my father were colleagues, and his mother and I've been contemporary in school, and she was a star student of our school. And my daughter and Parag and Atul are also work together. And finally, I should recognize that the other bond is Atul, who is my physician, is my most favorite physician, because he somehow agreed totally with me on the advantages of red wine. And that sort of had led to a very, very happy married life for me with his advice. So once again, Parag, thank you very much for calling me and allowing me to share some of my thoughts. But I really seek your help, both for my university at Pravanagar and also our institution, for helping us out in the areas where the challenges faced in tribal areas and here in the areas of neonatal challenges. Thank you very much.
Thank you, sir. We would now like invite sir to release our POGS publication called, aptly named as Speculum. Talking about the historical background of Speculum, it was very popular many, many years ago, and Speculum now has been revived by Dr. Parag Biniwale during his tenure.
Way back in 2001, Dr. Sanjay Gupta is here. Speculum was his baby, started in 2001, which we continued for some time, and somehow it got discontinued. Sir, it's a revival for you from our side. Thank you.
I now request Dr. Parag to felicitate our chief guest, Dr. Vijay Kelkar.
Thank you very much, sir, for being here. And this is a memento in appreciation which is being awarded to Padma Vibhushan Dr. Vijay Kelkar, chief guest for the installation conference REPLETE 2022. For your laudable and exemplary contribution to the field of economics and academics, we salute your distinguished and exceptional service to society and nation. This is from Team POGS 22-23.
We would also like to celebrate the accomplishments of our POGS members, and we are extremely proud of them. I request Dr. Parag to felicitate Dr. Girija Wagh, who has had a very triumphant, resounding victory. Girija was here some time ago. All right. So she is the Vice President, Foxy West Zone, and we are really proud of her. I would like to invite Dr. Meenakshi Deshpande. She is President IMA, which is a huge body doing enormous amount of work, and it will be great to have the liaison of IMA with POGS. I also request Dr. Alka Shirsagar to come forward. She is the Honorary Secretary of IMA. I also request Dr. Nilesh Palkaude to come ahead for felicitation. He is Foxy Chairperson Quiz Committee. Congratulations to all our members who have achieved great honor.
It is a tradition that whosoever gets elected in important post in Foxy, we always felicitate. But Nilesh became chairperson during the COVID times, so we did not have an opportunity to felicitate him in public. So we thought we will take this opportunity and congratulate him for becoming Foxy chairperson for Quiz Committee.
Thank you, dignitaries. Requesting all of you to please take your seats on the dais. So friends, as we come to the end of this installation and inauguration ceremony, I have to tell you a story about two obstetricians and two patients. The first obstetrician is Dr. Sunita Tandulwadkar, and her patient is Dr. Vaishali Kordenaik, who just delivered, and a postnatal patient very happily going home now. The second obstetrician is Dr. Parag Biniwale, who now has a labor patient with him for next 12 months, that Dr. Ashish Kale. So Ashish, welcome to the labor ward, and I request you to propose vote of thanks.
Thank you, Manish. Good afternoon, everybody. Respected dignitaries on the dais, Chief Guest, Padma Vibhushan, Dr. Vijay Kelkar, Guest of Honor, Dr. Shanta Kumari Madam, President Foxy and Treasurer FIGO, Office Bearer of Pune OBGY Society, past President of POGS, my Managing Committee members of POGS, all faculties and delegates present for our installation conference REPLETE. I sincerely extend my thanks to our Chief Guest for taking out the time from his busy schedule and gracing the occasion and installing Team 2022 and 23. Thank you so much, Dr. Shanta Kumari Madam, for traveling here, especially for this installation and being with us. Pune OBGY Society is always more than happy to have you. It's indeed a pleasure for all of us to host this conference in a physical way after a long break of 2 years, and I'm happy that this has been a huge success, and this could not have been possible without amazing academic program, the theme Paripurna Matritva. The faculties and all delegates, I am really thankful to all of them. I am also sure you will also enjoy the rest of the academic extravaganza today and tomorrow. I take this opportunity to invite all for this conference and the society dinner today and the same venue, Grand Sheraton. It's rightly said that the team work divide the work and multiplies the success. So without my team, this would not be possible. And thank you once again, my team, and thank you all for being there. Thank you. Thank you very much.
Thank you, Ashish. I now request everyone to stand for National Anthem.
जन गण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
भारत माता की.
With this, we are at the end of the inauguration ceremony. The 37th CME is officially inaugurated. We request all of you to proceed for lunch.
Welcome. Second panel is Dr. Archana Shah. Thank you, Archana, for traveling all the way from Solapur. It's really privileged to have you. Archana is an obstetrician and gynecologist at Deep Super Speciality Hospital, Solapur. I know her personally, very good academician. Welcome, Archana. Dr. Chandrakant Sankleja. Do we have Chandrakant here? No. Okay. Dr. Shilpa Kare. So, Dr. Shilpa is Associate Professor in Department of Obstetrics and Gynecology, Government Medical College, Miraj. Thank you for traveling and joining us, Shilpa. Thank you very much. Then we have Dr. Kalyani Ingre. I dare to introduce her. She's my wife, and she's a director of Nirmiti Clinic and a chief embryologist and a clinical consultant at Nirmiti Clinic, Pune. Basically, she owns the clinic. I am a consultant. Next is Dr. Mugdha Parasnis, a very dear friend. She's head Tata Center for Reproductive Health, KM Hospital, Pune. Please join Mugdha. Thank you very much. Dr. Vaibhav Dangat. Vaibhav. So our drama director is here. Vaibhav is a very dear friend. Director, Shivneri Nursing Home, consultant at Noble and Prayagdham Hospital, Pune. Thank you for joining, Vaibhav. And Dr. Veena Todkar. So we have a very lovely personality, all the time smiling, director at Neo Bliss Clinic, Pune. So thank you, friends, for joining us. And let me tell you that today we are moderating. Rules number 1, you are not going to ask questions back to us. We are going to ask to you.
The most important question.
You are not supposed to sleep during panel. Okay, we are going to keep you awake. So this particular video is for you. So that was me who was asking for 3 condoms, but that's not going to happen. Okay, you are not going to just blindly follow. You have to give answers. We are just going to ask the questions. So case number 1.
Thank you so much, sir. In fact, a UPT positive thing is something, a very happy moment for a family. But at times, this happy moment is threatened by the events of vaginal bleeding. So it's a lot of, not only the medical aspect that we need to see the emotional aspect as well. So coming to the case number 1, I read out the case. It's a 28 years old woman married for last 2 years, and she had a amenorrhea of 52 days, but suddenly for the last 2 hours she started having bleeding per vaginum. So although her UPT was positive, that pregnancy was threatened, and she had a regular cycle. This bleeding was painless, and she landed to us in the month of Jan, and she had an LMP of 15 December 2021. To sum up, she is a primary, 28 years old lady, 7 weeks, 3 days period of gestation, early period of gestation with bleeding per vaginum. So my question to the esteemed panelist, I would like to ask this question to Dr. Veena ma'am, that which investigations would you like to do the first?
Sir,
how do you approach this question?
In this scenario, I would like to reassure the patient on the phone once she calls me that yes, she is bleeding and it's going to be very disturbing for her. So reassurance is the first thing on the phone, which I'll tell her not to worry and come to the hospital. First thing
she's already in the hospital with you.
Okay.
Yeah.
And then I will do her sonography just to see, how the gestational sac is, how the fetal pole is, and whether the cardiac movements are there. And if the sonography is
we'll come back to that but we'll go ahead with the findings.
In this scenario, the lady underwent TVS, vaginal sonography, and it showed a gestational sac with a yolk sac. The sac diameter, gestational sac diameter of 12 mm and the yolk sac diameter of 2.4 mm. Now my question to Dr. Vaibhav, that what is your take on this TVS picture?
Since her periods are very irregular,
This can be a normal growing pregnancy.
Okay.
We should counsel her, and we have to repeat the sonography after a gap of 10 days. Should tell her to
You'll
take
repeat
a
the sonography after 10 days. Right?
Yeah. To see
So
the cardiac activity.
do you want to comment on why the GSAC is only 12 mm and we don't see a fetal pole? What are the possibilities?
Yeah.
What can be the differential diagnosis?
It can be a normal pregnancy also, since her periods are irregular.
Okay.
It can be a blighted ovum.
Okay. So Mugdha, do you want to comment on this picture? What it can be? One is that he said already delayed conception. Anything else you want to say?
So we need to, since the sac is mean sac diameter is around 12 millimeter, we'll need to wait and see for a week at least to see the size of the diameter of the sac, and then whether we are getting a fetal pole, because we can wait till 25 millimeter if the mean sac diameter is.
I think you mentioned about 25 millimeter.
Yes.
What is that 25 millimeter?
So
Why
if the
that cutoff 25?
mean sac diameter is 25 millimeter and you can't still see a fetal pole, then it's a missed abortion.
Okay, so you mean to say that we have to see the fetal
sorry.
pole by the sac size of 25 millimeter.
Yes, I do agree that the next question which comes to our mind is the viability of this pregnancy. Yes. So the viability of this pregnancy, I would like to ask ma'am that how at this juncture, how would you counsel the patient, because you are also not sure that what is going to happen. So it is very difficult moment to counsel also. So what clear-cut evidence?
What points you will counsel
to
the patient?
So in this situation, as we are discussing, it is either a non-viable or a viable pregnancy. So to confirm that, there is another investigation, like the serum beta HCG levels should be checked, and which are to be repeated after 48 hours time gap, because what we expect is at least 70% rise in the beta HCG levels should be noticed within 48 hours of duration. So with that, it can be assuring, and if the levels do not rise, or they remain at the same level or fall, then it gives us an idea about the
So Shilpa, Dr. Kalyani mentioned about that beta HCG follow-up test. So is this beta HCG it indicates chorionic function, or does it actually give you a clear-cut idea about viability, non-viability?
See, if it is more than 3,500, that is assuring, and it should be more than that, just to label them that it can be a viable pregnancy. And then we'll have a serial rise of beta HCG. We'll keep an eye on that. So depending on the next value, we can just tell them whether it is going to have a positive outcome, or maybe it is going towards like a blighted ovum.
So Archana, if we have one particular value, and then we repeat it after 48 hours, and then we realize that it is only 55% raised. It's not 70% raised. That is what we expect in viable. What will be your approach in this scenario?
Still, I will assure the patient and will wait, because she is having only spotting, no pain, and I think I will wait for 10 days and repeat the scan again to see the developing fetal pole. Since it's an intrauterine pregnancy, I don't think the rising beta HCG level should be done, but I'll prefer to go for ultrasonography after 10 days.
Yeah, I hope you will all agree that beta HCG is a sign of good implantation. If the rise is there, the implantation is good. Yeah,
so that's very important, that beta HCG is produced from a chorionic tissue.
Yeah.
And that's what it is, a functional probably representation of what is happening at the chorion levels. Okay, so probably it just gives you idea how much is the chorion is functioning and how much is the probably oxygen supply to this gestational sac. So that is not a very diagnostic test, but it will give you some idea about what is happening, why it is slow, whether it is only a healthy delayed conception or there is something wrong with the proper implantation. Right.
Now, with these two armamentum in hand, that is the beta HCG on one hand and the ultra TVS on one hand, I would like to request Dr. Ashwini ma'am to delve further into this aspect of anembryonic pregnancy by only just looking into the TVS.
So we will label this case as a case of anembryonic pregnancy if we repeat the sonography after 1 week. Okay. After 1 week, if there is a growth in the gestational sac seen, but if there is no fetal cardiac activity, so if there is a sac size of 25 millimeter, but no fetal pole without cardiac activity, or if there is a fetal pole of around 6 to 7 millimeter, but no cardiac activity, then we can label it as an aneurysm.
I think she mentioned about it, and it is also documented that roughly the CRL will increase by around 0.6 to 1 millimeter per day. So whatever size of the CRL, gestational sac, I'm sorry, I said CRL, I'm talking about gestational sac diameter. So whatever diameter you say, according to that you can call up the patient, like say 12 millimeter sac you are seeing, and if you want to repeat the scan, I think another 2 weeks time is very important, because by that time the sac will be 25 millimeter and you will be able to detect whether it is particularly cardiac activity seen or not seen.
So very truly said. I'd like to remind the panelists and the esteemed audience also that it's the time of so many litigations are there if you go through the medical legal series, and with the advancement of the ultrasound, with the sophisticated ultrasound, we are very sure nowadays that some 1 point criteria and time based criteria are there. This CRL of 7, more than 7 without any cardiac activity, or MSD of more than 25 without an embryo are point based criteria. Again, we have got something known as the time based criteria, where we give time of 11 days or 2 weeks to come to a conclusion. So as the panelists have agreed that the TVS plus the beta ICG level should be advised for the patient.
So now I think this we have already discussed. So we can go for the management.
Sir.
Next question. So as we have understood about even the question, now suppose Veena, you have done this scan, now we have agreed upon that we must call this patient after some time, but will you leave that just like that, or you are going to give some medication? Are you going to manage this pregnancy? How you are going to decide that? Does she needs any additional medications?
See, first of all, I would like to tell her that she has to be on the strict bed rest, and then I would like to give her micronized natural progesterones, which can be in the form of vaginal formations. Then the SCG injections can also be administered. Along with that,
so bed rest, micronized progesterone, and you said SCG
injections.
Vaibhav, do you agree that bed rest really helps in this scenario? What evidence
not
says?
required. Only pelvic rest is recommended. That is
the new term pelvic rest has come.
Yeah. And there is no role of
can you elaborate pelvic rest for the audience?
Pelvic rest means she should not indulge in any strenuous activities, exercise, intercourse, vaginal douching. Rest, routine activities she can do. Secondly, the research up till now has proved that progesterone has very less role in such things. So I won't advise a single medicine for her except folic acid.
Okay, Mugdha, she's bleeding, she has a spotting. Will you just leave her like that, or will you like to give something?
I would like to reassure her first, and I would like to give her progesterone. There are some trials which say that oral progesterone, dydrogesterone can give a better result. So I would like to give her progesterone. I would also like to do her investigation, check her blood group. If she's Rh negative, might consider giving her NTD.
Yeah, I do agree with you partially that mere words do not help. You are going to counsel a patient, she is in an anxious state. भगवान को मानने के लिए मूर्ति की ज़रूरत है. So I think that progesterone might be idle in our case. Yeah, evidence, I know evidence are not that much supportive of the role, but he's an infertility expert, he knows better than my field of expertise. So I do believe that that progesterone in some form is helpful. But I would like to ask you, ma'am, again, why the vaginal route? Why not the other route?
Can you take the mic?
Yeah, it will benefit the students here.
The absorption of the progesterone is directly available to the uterus when it is it is put in
fast effect.
Yeah, the liver.
The bioavailability of drug is.
I read this literature. To sum up, the bioavailability is around 25 to 30%. But if given by the vaginal route, it bypasses the liver metabolism. So more of progesterone is available to the.
You want to say something, Ashwini?
Same as Madam said, vaginal micronized progesterone is always a preferred route. That is what I do. But if the patient is bleeding, bleeding to
Yes.
the extent that she is scared to place tablet in the vagina,
Yeah, true.
then I would explain her, I will give her dydrogesterone 10 milligram twice in a day.
Yeah.
Okay.
Because she is in an early gestation, and then I'll gradually shift her to micronized.
So Archana, why we always discuss that progesterone, only 15-20% is available if you administer orally. Why dydrogesterone doesn't have this kind of thing? I mean, if we give micronized progesterone orally, we always think that availability is the problem at the uterine level. But why dydrogesterone? As she said, again, oral advantage. But why dydrogesterone? No,
Any other
anybody?
panelist? Yeah.
Ashwini?
Pharmacologically, the structure of dydrogesterone is very, very close to natural progesterone. The bioavailability of dydrogesterone is better. The tolerability of dydrogesterone is better. So that is why it is tolerated better. One meta-analysis says that the prevention of recurrent miscarriage, I know we are not dealing with that, but recurrent miscarriage, it is effective as high as 47%. So
Yeah.
that's why probably for us, every threatened abortion is like we want to prevent the further recurrent abortion. So we should be concentrating on this and then using progesterone.
To sum up, ma'am, and the fact that we are talking about, the progesterone helps in endometrial maturations, the stabilization, implantations, and regulations. But we have many studies, the Lotus 1, 2, the Promise trial, for the benefit of students, there is one trial known as the PRISM trial also. I think PRISM, Promise and Lotus, these are the 4 trials you should read about, and it says that the dihydrogesterone, that is commonly known as duphaston, is not inferior to progesterone. That is the conclusion. So still I'd like to request you about the final opinion on this aspect.
No, I think I will agree with my panelist. I think if you talk about oral form, then dydrogesterone is one which is only preferred. Now we have this oral natural micronized progesterone. Anybody who uses that, anybody who is really favorite of that than oral dydrogesterone, I think they do agree. The only problem is that we don't have a data. We don't have a data of what is real availability with oral natural micronized progesterone. So we really don't know. It's only what we are, probably the thought has been inducted into our mind. Yes?
So the progesterone pharma market is now 1,000 crore. I am attached to Ayurvedic Medical College, Sane Guruji.
Okay.
Lot of workload.
Okay.
For first trimester bleeding, they give no progesterone.
Okay.
And still, first I used to think that how come they not give progesterone and there will be lot of abortions. No such thing happens.
Great. Vaibhav, I think you have pointed out very right point. We'll come to that evidence, okay? But I respect your opinion and really a good new area you have come up with, because our anxiety is she's bleeding, okay? Our anxiety is that how can I stop that bleeding? Because once that bleeding is stopped, she has a full faith in you. I think that's our usual problem. Now, before we go ahead, I want to ask you, along with progesterone, suppose we decided that we need to give her progesterone, okay? So do you give any other medication along with progesterone for this patient who present to with a bleeding per vaginal?
As correctly mentioned, I would also like to add folic acid to the pregnancy.
Right, that's fine.
And
that's routine, kind of supplement. I agree. But any other
from
thing?
that, I think reassurance will be more important.
Very
because
important.
20% normal pregnancies, they have this implantation bleeding. So I think reassurance is more important because they are very anxious right now.
Right.
Because early pregnancy and bleeding, so sometimes they expect that it maybe have a negative outcome. So I think that I would like to add. Definitely.
Anybody who is of opinion, Mugdha, any tranexamic, salicylic acid, so many other drugs, do you give? Kalyani?
I prefer to give tranexamic acid.
You prefer to give?
Basically
Kalyani?
stabilizing the clot and preventing the further seepage of blood is very, very important, along with the counseling of the patient for her psychological impact and prevention of appearance of blood, because blood is a contaminant.
So Vaibhav, you said
tranexamic
that...
acid,
Yeah, go ahead.
yes, so
Please allow, ma'am.
addition of the tranexamic acid is very routine practice along with
Right.
the other.
So Vaibhav, you said you have seen and that no progesterone is being given. But then in that scenario, do they give these kind of drugs, salicylic acid or tranexamic acid?
No, they give only some churna, which is or a tablet, Ayurvedic tablet in Sani Guruji. And research has proved that tranexamic acid, ethamsulate has no role proved in such first trimester bleeding.
One point I'd like to draw across is that as a doctor, if we are not assured, how can we assure our patient? So whatever you believe, you have to believe in that firmly. Unless and until you don't believe yourself, you can't counsel a patient. So I know 15% patient will go into abortions and all, but counseling is very, very important. I hope you all agree to that.
Now, this patient came back to us again after 2 weeks as instructed by us. So single intrauterine gestational sac of diameter 24 millimeter this time, with yolk sac with tiny fetal pole without fetal cardiac activity. Now what? Veena? Do you agree with, this kind of pictures we do come often?
Absolutely, we do come up with pictures like this, and probably how many weeks is the pregnancy? Can you just mention?
7 weeks.
7 weeks that time. Now she's
so
9 weeks.
She's 9
and now
weeks.
it is 20.
So
it was 12 millimeter gestational sac. Now it is 2 weeks. It is 24 millimeter.
Yes. So this looks like a belated ovum kind of picture, non-viable pregnancy. So now what? I mean, in this scenario, you mean to how will I manage the patient?
What will now? Is it viable? Not viable?
It is a non-viable pregnancy.
It is non-viable.
Yes.
Why? Because we see the fetal pole, which is more
and
than
it is
6,
already
7
9
millimeter.
weeks, and there is no fetal pole in this.
Yes. So I think that's very clear that once we see a fetal pole and the CRL is beyond 6-7 millimeter and we don't see fetal cardiac activity, now it is confirmed. Now you don't need any evidence to say that it is viable pregnancy. This is non-viable pregnancy.
Absolutely.
So probably we'll go for termination,
Yes.
right? So, Mugdha, cytogenetic studies of the conceptum, should we always do them? Now this is a primi gravida. Now we see this kind of picture. It looks like a non-viable pregnancy. Now what? Will you do that cytogenetic studies? No. For the first pregnancy, anybody interested? No, none at all. Veena, you want to do it?
I won't do it. Theoretically, it is not recommended.
Okay.
Practically, if we explain the patient, if the patient demands for it, then only. Otherwise,
What is
not
the
recommended.
likely possibility, Dr. Archana, what is the reason for having such non-viable pregnancy? What is the likely possibility?
It could be because of the non-growing improper development or improper fertilization,
Okay.
or problem with the oocytes.
So probably, are you expecting a genetic abnormality more often in these pregnancies? So 80 to 90% these are going to be a genetic abnormalities, and the evidence is very clear that if you come across any genetic abnormality like trisomies, your chances of having good viable pregnancy next in future pregnancy is almost 98%, if absolutely parental karyotype is normal. So probably first pregnancy, we don't have evidence that we must do a karyotype. That's very clear. But once it comes to a second miscarriage with again similar picture, probably yes, it is definitely indicated. Kalyani, you want to say something?
Yes, I just wanted to say that in our counseling, we have to add on that this investigation is suggested.
Yeah.
And then
Correct.
leave it up to the couple, because in today's scenario, even this patient is 28 years old, but we are coming across the patients who are more than 30 years old. So it definitely becomes one of the
So I think very right point.
Sir,
You must give option.
I have an opinion regarding that. I partially agree with you. It says that aneuploidity is more in case of the loss which occurs very early. Say for example, before 7 weeks abortions, the aneuploidy chances are more. But at this evidence says that if the age is more, the euploid abortions are more, not aneuploid. So the evidence says that if it is more than the age is more than 35 years old, then the chances of euploid abortions are more, not aneuploid. So this is what I have come across.
Now, good practice guideline says that you offer a option of doing a POC karyotype, okay? Because if you haven't done this, and if at all if they go to the other doctor and if they do it and they find out some abnormal, they'll have a wrong impression about it.
Very true.
First of all, please put an option that we can find out a cause of miscarriage or non-viable pregnancy by doing this test. At the same time, the second point is very important, that even if it is abnormal, the chances of having a normal conception in a second time is more than 98%, but it will help us to find out whether we should go into detail of parental karyotype or no. So that's very important, and that's why the counseling point should be on this.
Yes, sir. That brings out a light of hope also, sir, to the couple.
Absolutely. Okay. So, this is just to summarize that suppose you come across such kind of case and patient has presented in a post-abortal phase with you. These are the few investigation which you can do it, which can even cause a second non-viable pregnancy. So one good transvaginal ultrasound to know about uterine abnormalities, homocysteine levels, glucose tolerance test to rule out diabetes, thyroid function test, FSH and LH to rule out polycystic ovarian syndrome, which even TVS will help, and if necessary, if it is repeated and if it is abnormal karyotype in the POC, then parenteral karyotype. Yeah.
So, yes, sir. So coming to case, thank you for this. I think we are very clear about the case management of case number 1. Now coming to our patient, second patient, she has got a spontaneous conception, 32 years old lady. She has a pregnancy of 8 weeks period of gestation with the same complaint of bleeding per vaginum, but here with a pain in abdomen, moderate pain in the abdomen. Now she was a booked case, she was given folic acid, all these pyridoxine, all these things are given. Now when she came to your clinic, she was having active bleeding. Now this TVS shows a single live intrauterine fetus of 7 weeks 3 days period of gestation with a fetal heart rate of 128 beats per minute, and there was no subchorionic collection. So she is presently bleeding, and you had an ultrasound done in your clinic. Now what is your line of management?
Okay, we'll start with Archana. You can take this.
Since this is a viable pregnancy and the OS is closed, this is the case of threatened abortion.
Perfect. Okay.
And the first line of management is since she is bleeding heavily, I would like to admit her and reassure her and check for the vitals and blood. I will check for the blood loss as well. Okay. And definitely I'll prefer to give her progesterone.
Okay. Archana, do you every time admit? It's a big controversial point. Does this...
Yeah, but if the patient comes to me with such, this much of bleeding, definitely I will admit.
Okay. Yes, your opinion?
Yeah, if it's an active bleeding, I will tell her it is better to get admitted. But if she is not ready, then...
Anybody who manages on OPD basis, you are okay?
Yes, managing on the OPD basis.
Managing in the OPD basis. So what made you think that, okay, I can manage on OPD basis? What is your line of treatment so that she doesn't need IPD?
Basically, as we discussed previously, giving her the progesterones along with the tranexamic acid and getting her some investigations done, making it sure on the sonography that there is no collection. So since there is no collection, there is no risk of advancing the bleeding or anything. And by checking her complete blood count and ruling out any infection.
Okay.
Then
what do you do in Meeraj at medical college? You admit the patient every time they come?
If it is active bleeding, we would like to endure,
Okay.
because she will be under observation, and suppose she is bleeding heavily, there will be immediate management. So
Okay.
active bleeding will like to endure the patient.
All right.
I would like to add that in investigation we should do the blood group of the patient also, because if it is blood group negative, then we should give the anti-RSD also.
Now coming back to Veena, what is your first choice out of these all progesterone? Because she is actively bleeding. So will you combine, will you give only one progesterone, will you give higher dose of one progesterone, will you give 2-3 progesterone together, will you combine oral plus injectable? What is your choice, and justify your choice?
I will give intramuscular progesterone injection.
Intramuscular, you want to give pain? Okay, done.
Yes.
All right. No, it's fine. It's your opinion.
And just wait and watch policy in the
Okay,
hospital.
you will give only one single intramuscular progesterone, or you will combine with oral?
No.
No oral, only intramuscular.
Only intramuscular
Vaibhav?
and probably.
Please differ if you want. What you do in your practice, do all
I
is
will
justified.
just give a pelvic rest. No other medicine is required. If pregnancy is genetically good.
So is it like Bhagwan Bharose?
No Bhagwan Bharose.
We can't do anything with Bhagwan Bharose.
सर रस्त्यावर खडी फोडणाऱ्या बायकांनाही दिवस राहतात, विश्रांती घेत, नीट होतं सगळं. दिस इज अ ऑल फार्मा गिमिक विच इज लिडिंग अस टू राईट सो मेनी प्रोजेस्ट्रॉन्स. असं म्हणतात की बोले पैसा चाले त्याची बंदावी पावले.
I think someone is also sponsoring
consultants
this.
are saying from the stage that no progesterone is required, but I will say 99% of the audience writes at a time vaginal, oral, injectable, and different types of progesterones.
All right. Mugdha, what about you? Combine, injectable, choice?
I would, if patient is hemodynamically stable, I would like to manage her on OPD basis.
Okay.
And I would like to give oral digoxin.
But ma'am, don't you think that injection देने से seriousness बढ़ जाता है? Patient सोचते हैं नहीं मुझे एक IV लगा,
I would prefer to
injection
give her
लगा.
oral digoxin.
What patient thinks doesn't matter for us. Right?
I would counsel the patient.
Yes.
I think they do understand.
Okay.
एक saline की बोतल लग जाए. मतलब Hindi movies always shows that saline की बोतल.
Okay, Kalyani, one question. Suppose you said that you will give progesterone. So what do you expect? Within how many hours the bleeding should stop after giving a loading dose of progesterone? Do you think, does it really have something like a duration?
It doesn't have
It
a
doesn't
correlation.
happen. Okay, all right. And then how you will, further course? She's bleeding, she's not stopping. What will you do? What is your course of line? You have to tell patient. Patient says that I want no bleeding. Then what?
The bleeding, basically the bleeding has to be defined in the terms of the color also, because fresh bleeding is going to be there, that indicates that it is continued. Then the little bit old color and the browning color, this is what we have to counsel them, that you are going to see different type of colors as the days pass by, and it is going to come out.
So you want to
better.
differentiate between fresh blood and old blood. That's
Yes,
what you mean
and
to say.
reappearance of
Shilpa?
Definitely, as she specified, whether it is a fresh bleeding or a
So
altered bleeding.
that's very important counseling point,
Yes,
right? So
definitely.
that's very important when you prescribe some medications and patient goes home. Okay, you'll have to explain that this active episode of bleeding, once it stops, if there is any collection inside, you may get that dark colored pervaginal spotting for next 2-3 days if there is any collection. Right now we don't see in this case, but probably that's an important point. Do you agree, all of you?
Yes.
Okay.
So I'd like to submit one very diplomatic answer given by Cochrane review. It says that progesterone is good for miscarriage. Yes, it has, the statement from the Cochrane is it is good for miscarriage.
Okay, so this 2017 meta-analysis, so we have some evidence from some randomized control trials, okay, that 2 days is enough. No, I think everybody agrees. All of you practice same? All of you practice same? Anybody is different opinion? Right, so I think if you look at the majority of the practice, I think it is same that a patient who has a threatened abortion episode, she is bleeding actively, and you have given progesterone, everybody gives progesterone, right? Now, very important point here is that for how long we need to give progesterone, okay? Even in ART, suppose we want to give progesterone as early pregnancy support, how long do we give? Dr. Archana, your IVF consultant, Ashwini, both of you tell me, Mugdha, you tell me, how long you give in ART, in down-regulated cycles? Go ahead, one by one. Archana, first you.
If the patient conceives, I'll continue the progesterone till 12 weeks.
12 weeks. Ashwini, do you?
Nitrogesterone till 9 weeks, micronized progesterone till 12 weeks.
Micronized. So it acts at the ovary because it stimulates ovary to produce progesterone. So if you are giving adequate progesterone, now it is very clear with evidence that you don't need to give SCG. Okay, because you are already giving progesterone. So there is no need. If you have enough amount of progesterone you are giving, then there is no role of SCG. So now, with all evidence in recent decade, there is no role of SCG. Even if it is now in down-regulated cycle, we keep giving SCG as early pregnancy support, there is no need because there is no corpus luteum where this SCG is going to act. So be clear about what we are giving and for what purpose we are giving.
I would like to add, if you read the physiology of pregnancy, we know that the corpus luteum remains functional till 6 weeks of pregnancy. And the beta SCG level rises after that only. If you see, the maximum peak of the beta SCG is at 8 to 10 weeks period of gestation. So there is a clear-cut conflict in the mode of action of the role of corpus luteum and the beta SCG, and probably because of that, what sir is saying, that the current evidence is not favoring the beta SCG.
Mugdha, suppose this patient is a known case of antiphospholipid syndrome, right? And she's 8 weeks something. We have already started her on low dose aspirin since the UPT is positive, cardiac activity documented. We have started low molecular weight heparin 60 milligram per day. So now what you will do? Patient has come to you with active bleeding. Will you stop? Will you continue? How long you will ask the patient not to take these medications because they are anticoagulants? What do you do in your practice? Forget about evidence. What do you do in your practice? Suppose you have started. What you would have done?
If the patient has come with active bleeding, then I would discontinue for a week.
For 1 week,
Yes.
yes. Vaibhav, what you would have done in antiphospholipid syndrome?
7 days after stop.
Okay, so 1 week, and then will you like to restart these medications?
Yes.
Okay, good. Now, after a week, she came back again with the bleeding. Now what? I'm sorry, I'm just jumping up from. You had to push. Okay, sorry. So what will happen? Suppose now you have stopped anticoagulants. After 5 days, you have asked, okay, restart. Now again 3 days later, she came with bleeding. Now what will do? Again stop? Again stop? Okay, confused. Okay, of course we'll stop because she's bleeding, right?
Yes.
So anticoagulant has to be stopped. Whatever it is, we want to give her because she's APLA syndrome, but at the same time she's bleeding. If she's bleeding, we have to stop. So whenever you come across bleeding, please stop for at least minimum 72 hours to maximum 5 days. And then you can restart. Okay, we can find out the cause.
Sir, next
we can go.
Yes.
Sorry.
Sorry.
You do it, do it. Go back to the case.
Sir,
Alright. So 34 years woman, second gravida, previous one living child with 9 weeks of single pregnancy with per vaginal spotting since 2 days. Past history, transvaginal scan done at 7 weeks showing perfectly okay pregnancy or 7 weeks 2 days according to the CRL. Fetal heart rate is 142 beats per minute. This was past sonography report. Now blood group was B positive, thyroid was 2.3 in that first visit, 11.2 hemoglobin, sero markers negative. On the day of bleeding, you have done the sonography, again transvaginal scan. So Ashwini, what you see, can you describe this picture? This one.
So the anechoic area which we see just near to the fetal pole, the crescent shaped one.
Yeah.
So that is likely to be a subchorionic hematoma.
Yeah. Isn't it very large hematoma there?
Yeah.
Yeah, it's more than the sac size actually.
So,
it's quite a huge collection there.
Yeah, almost it is indicative of separation of the membranes probably.
Membranes, yes, because chorion is on this side.
Yeah.
You can see very well clearly make it out. Chorion is on this side. It has not separated, especially the placental bed. It is exactly opposite direction.
I would like to ask, is there any clear-cut dimension that this much of hematoma, chorionic hematoma will lead to failure in pregnancy?
Is there any such kind of thing?
Any cutoff?
Do you think that
anyone.
Still this pregnancy can go ahead? All of you do agree?
Still this pregnancy can go ahead, but we have to keep a watch for the other problems that she might face. Once we control this situation.
Please specify which problems.
She is a likely candidate for preterm labor. She is a likely candidate for premature
long-term
rupture of
consequences.
membranes.
Okay. What will you do, Archana, in this scenario? Okay, she has just a spotting, but there is a huge collection. You don't know because it's already 2 days she is bleeding. So probably it's not a fresh blood. Okay, it's a dark colored spotting she is having because there is a huge collection there inside. Now it's 9 weeks. Will you give treatment?
Yes, first I'll counsel the patient regarding the subchorionic hematoma and what are the chances of continuation of the pregnancy. In spite of giving treatment, with this much large hematoma, there are chances of abortion. And I'll continue with the progesterone treatment.
Progesterone you will give. Anybody from this side like to do a serum progesterone levels to know what is happening in her circulation? Anybody is in favor? At the time of presentation, would you like to know whether she has a good progesterone or no?
Yes, basically the progesterone level should be at this point of time more than 30 to 40 units.
Okay.
So unless and until those levels are there seen, then we cannot assure, and we have to increase the dosage.
Okay, do you agree? Do you routinely do progesterones, Veena?
Progesterone and serum estradiol also should be.
Are you doing it, ma'am, in your
Estradiol,
clinic?
okay.
Are you doing it?
The estrogen? Estradiol, okay. All right. As long as I feel that in threatened abortions or such subcurrent hemorrhage, probably at 9 weeks, very minimal role of estrogen I feel. But progesterone, yes, probably what Kalyani said that yes, sometimes it might help you, but it is already advanced pregnancy. So probably we can think of little early pregnancy, maybe 6-7 weeks where progesterone levels might be very low and might present with threatened abortions. But by 9 weeks, less chances. Do you agree? All right. Very right point that one assay will not help you to give you some idea about what is happening. So please do not go blindly with serum progesterone levels.
To sum up this subchorionic hematoma, what evidence says is that if the collection is more than 2/3 of the sac size, or if it is more than 60 ml, then the chances of failure of pregnancy is very high. So 2/3 and a volume of more than 60 ml.
Now, Weber, is there any need of antibiotics? You see large hematoma there, which is a kind of a good culture for bacteria to grow. Will you give antibiotics or there is no need?
Unless there is...
Take the mic, please, if you don't mind.
Unless there is signs or symptoms suggest of infection or WBC count increase, then only I will.
But there is high chances that she may develop infection. What is your choice?
Still,
you are not worried about. No. It's all right. It will resolve on its own. Yeah. Mugdha, antibiotics?
See, many times subchorionic hematoma maybe because of pelvic infections also.
Okay.
So I wouldn't routinely give antibiotics, but I would like to observe.
Now, this was a study in 2001. I tried searching for good study in threatened abortion with collection, and I only found this study by Dr. Q, where they selected 23 women, again a very small size study, but they were having previous spontaneous abortion history, and now this time they detected that almost 65% had an abnormal vaginal flora, and out of these 23 pregnancies, almost 22 who received antibiotic therapy could carry their pregnancy till term with no identifiable neonatal anomalies. So this study only concluded that probably there is a role, but to be honest, very small size study. Selection of the patients are wrong. They are not threatened abortion. That was patients with a previous loss, not present threatened abortion. So I think probably still we are not sure about antibiotic therapy. Does it really work? So that's the evidence, and that's, I think everybody does that practice, that no antibiotics, no role. But progesterone probably, yes, there is some role because it's a large hematoma. Now, case number 4. You can read.
It's a she's a 29 years old, gravida 3 with a 2 history of abortions in the previous, at around 9 weeks period of gestations. And presently she is having a pregnancy of 7 weeks, 5 days. Now, you have got a TVS picture alongside, and does the presence of subchorionic bleed without external bleed sign is a sign of failing pregnancy? So this is the question to the panelists.
So Shilpa, you see this picture here where you can see some little collection in that area. Can you see that there? Okay, but there is no external bleeding. She has not presented to you. It's a routine scan you have done at 9 weeks. So what do you feel? What you will do in this scenario? Will you treat this patient or just leave it like that? It's okay.
No, again it is kind of a subchorionic hemorrhage that we can see. Yeah. So again progesterone supplementation, and as sir said, pelvic rest we will advise.
What is that history point where you feel that no, it is important that I should give progesterone?
2 previous abortions.
2 previous miscarriages, yes. And that too also at 9 weeks gestation.
9 weeks, exactly.
I think that's very important history. But somebody who never had a loss but present to you with this, now the opinion will differ? Yes, Mugdha? Still give. Okay, everybody wants to give progesterone. I think that's the best part of this topic, that when you don't have evidence, it is good thing that we can give anything and we can say, yeah, it works.
Does progesterone has got any side effect in any of your patients? With so much
progesterone can cause hypospadiasis in male fetus.
All right, incidence is very rare, less, but it can cause. All right, anyway, so that's fine. Let's find out answer. Now she has a history of 2 abortions, and that's very important. In this scenario, at least with that history, yes, we will continue progesterone for some more time. Probably it is right now 7 weeks pregnancy, so at least she has to cross that 9 weeks barrier minimum. So we'll give progesterone till 9 weeks and then we stop. But in case this is a very minimal bleed without history of any previous loss, probably there is no role. We can still wait and watch and continue because there is no external bleeding at this moment, some minimal bleeding. So this history is very, very important. Yeah.
Sorry.
Okay. 30 years woman, married since 2 years. Okay. Please pay attention. 30 years woman married since 2 years with amenorrhea of 8 weeks. presented in OPD with per-vaginal bleeding since 2 hours and severe vomiting since 3 days. Obstetric history, primi gravida, regular cycles in the past. Advised to undergo TVS, which showed this picture. What is it? Is it a clot? It is a big clot which is organized dissolving clot.
Vesicular molar pregnancy. Vesicular
You think molar pregnancy?
Molar pregnancy. Hereditary form.
It is molar pregnancy? Sure. Or clot?
I mean, it is not mentioned that the
No,
period
that
of
is what you have to
amenorrhea with the sonographic picture of the fetus, you know.
So can you
If it is
describe
more,
this pattern? Can you describe what you see? What do you see?
it is like grape-like appearance.
No, grape-like appearance, how can you see it?
Cystic spaces.
Snowstorm appearance. Snowstorm appearance.
Snowstorm appearance, okay. Alright, so what is snowstorm appearance? Again, very
Exactly. To help my panelist, this snowstorm appearance used to be in those old ultrasound pattern. Now with the modern ultrasound, it is the cystic spaces, hyperechoic and hypoechoic spaces. So we have a diagnosis here and agreed by the panelist also that is a case of molar pregnancy.
One question before to Shilpa. What do you see and how can you differentiate on this picture whether it is partial or complete hereditary form mole? Wait, please, panelist. Panelist answer.
See, basically there are normal tissue also on the other side. So it is going to be a partial
mole. Because you see some fetal pole there, you see some chorionic normal tissue there, which is actually giving you a very clear idea that it is not a complete mole. Yes.
Yeah, in fact, hyperemesis also, it is only in 25% of the molar pregnancy.
It's not diagnostic.
Not diagnostic. So we can't say that it is because of hyperemesis, it is a molar pregnancy. It is more of ultrasound diagnosis. So any bleeding in the first trimester, it can be a threatened abortion, it can be a molar pregnancy also. So the idea of the molar pregnancy should be...
Why about to continue, not to continue? Not to continue. Why not to continue? What is the problem?
Sir, he is saying not to continue the pregnancy, but to continue the panel discussion.
No, the reason is why I wanted this question is because partial or complete mole, it is always and always genetically abnormal pregnancy, and that needs to be terminated, right?
Yeah, many a times very unfortunate incidents occurs in ERT, especially ERT cases. After a lot of trials and tribulations, they do get pregnant, but lands up with ectopic or molar pregnancy. So this aspect of bleeding per vaginum in the first trimester of pregnancy should always have at the back of the mind about the ectopic pregnancy and the molar pregnancy.
Does every partial complete mole after you terminate, do you need to monitor with beta HCG every pregnancy?
Yes.
Yes? All of you do agree? Anybody differ from panelists? Everybody. What is the risk of persistent gestational trophoblastic disease? What is the risk? Do you think that common factor of 10% or time's up? I know. Last one. Okay. Is it too high? The risk is
1%, I think.
1% risk. Yes. Dr. Girija Wag, madam. Every case of partial hereditary form mole after termination needs to be followed up with beta HCG? Yes, okay. The risk of, we have to follow up with the beta HCG, that is very important till the beta HCG goes below 1, that is 0 or below 1.
Below 5. Below 5 is the normal.
Yes. Now, quickly go to the next case, you can read.
Yeah, we have got a 29 years old, gravida 2, para 1, living 1. She had got a normal pregnancy 2 years back. Now presently she is UPT positive 10 days back. Now she has got no signs symptoms of any intrauterine or extrauterine gestational sac, but with a ET of 17 mm. How would you like to investigate?
So Ashwini.
She will need evaluation of serum beta HCG level because the endometrial thickness is 17 millimeter and there is no evidence of any intrauterine or extrauterine sac.
Okay, beta HCG.
And
do we have
yes,
HCG?
2392.
Yeah, the HCG levels are written there, 2392.
So if at the level of 2392, if nothing is seen, ideally anything between 1500 to 3000, at least some evidence of gestational sac should have been there. But if it is not there, then that should raise a suspicion of extrauterine pregnancy. So repeat beta HCG after 48 hours. If anything less than 66% of the initial value, if we see, then repeat the ultrasound.
Okay,
like,
great.
Repeat the ultrasound after 48 hours.
So quickly coming back, what she said is absolutely a right line of management. And after 7 days, when we repeated a sonography, when there was rising beta HCG, we saw this at the outside the uterus. So you can see this is the uterine musculature on this side, but kind of a gestational sac there. And yes, as you said, high possibility of ectopic pregnancy, and that was a picture. So I'll skip this, and this is what we call as a innovations, and that's what we always feel, that our conferences, our life, our practice all depends on innovation. So we must have innovations like this. So let's see this, what innovations
You never do any work. You spend your entire time making ridiculous inventions. Well, I've had enough, boy. Bend over.
So always we like to have lot of evidence. I think this was a wonderful topic to discuss. I really liked it, and I was first to take it. Yes, I'll take it because there is hardly any evidence, and there are so much to discuss and so much variety of practices everybody does. Various dosages, various different routes, combining so many progesterones together, lot of things. So teamwork divides the task and multiplies the success. We have heard it today, and on behalf of my moderator, Colonel Saab, thank you so much, my panelists, for excellent discussion and giving your honest opinions. And thank you for not asking questions back to us, because we didn't have the answers. So thank you, Parag. Thank you, Manjiri, for giving us chance to moderate this session. Thank you so much. Thanks a lot.
On behalf of we all panelists, we'll like to congratulate Dr. Parag Biniwale to be installed as the president. And thank you for inviting us as the panelists.
Thank you.
Thank you, moderators, and thank you all the panelists. And quickly, may I request our moderators to felicitate the panelists?
Oh, moderators to felicitate. Wow. Chalo, sir.
May I please request Dr. Pankaj Sarode sir to felicitate the moderators? Thank you so much. Yeah. May I please request Dr. Manjiri Valkasankar ma'am to take over the next session?
It's time for felicitation. Dr. Girija Wagh madam had to go for an emergency during the inauguration. So may I request our President POGS, Dr. Parag Biniwale sir, to felicitate Vice President-elect who has won with the maximum number of votes, Dr. Girija Wagh. Thank you, sir. Thank you, madam. May I request the next MOC, Dr. Veena, to take over.
Good afternoon, friends. Our next session is first trimester bleeding, and it gives me great pleasure to welcome our first chairperson, Dr. Savita Mehendale. She's a great academician and teacher working at Bharati Vidyapith as Emeritus Professor. Our second chairperson is Dr. Harshad Parasnes, who is a renowned gynec oncologist in Pune and faculty nationally as well as internationally. He is the head of gynec oncology unit and associate professor in Bharati Medical College, Pune. He has also been president of Pune Obstetric and Gynec Society in 2021. Our third chairperson is Dr. Vaishali Biniwale, who is an eminent obstetrician and gynecologist in Pune, practicing since 1995. She has written a book on pregnancy in Marathi, Balantapan, published by Rajhans. She has also contributed many health-related articles to various magazines and newspapers and delivered educational talks. She also conducts health camps for underprivileged women in Velhe Taluka.
Yeah, thank you, Veena. I think this is a very important session, first trimester screening, and
I will request Aparna Kulkarni. You know her very well, Aparna Kulkarni. I request you to throw light on ultrasound used for such cases. She is a consultant, fetal medicine, and working in a Dinanath Mangeshkar hospital at present. She was working in Bharati hospital also previously. But regularly you were coming, previously, regularly you were coming.
Congratulations to Parag and entire team for today's occasion, and the best wishes for the next academic year. It's an honor to be here to present this talk today. Okay, so let's go through first trimester screening for the next 15 minutes. The first trimester scan, we use it for aneuploidy screening and beyond. The common markers which we use are nuchal translucency, nasal bone, ductus venosus, tricuspid regurgitation, and fetal heart rate. We also use this opportunity to screen for structural defects, and another important aspect for screening is screening for early onset preeclampsia and IUGR that presents before 34 weeks of pregnancy. So NT is the most robust marker. Nearly 80% of Down's babies will have increased NT. It is measured between 11 weeks to 13 weeks, 6 days with a CRL of 45 to 84 millimeters. But it has to be measured accurately. One needs training to be able to measure the NT accurately, and we have to follow strict criteria. Of course, we have to have patience, willingness, dedication, and time when we are doing an NT scan. So let's have a look at this lovely baby. Can I have a mark? Is this a marker? Is this a marker? I need a marker. Oh, okay. Yeah, okay, I'll just play that again. Okay, so a good magnified image, strict mid-sagittal, that's diencephalon. No maxillary prominence between the nose and the upper jaw, and that's the nuchal translucency. So it is expressed in multiples of median. The actual reading of the NT has got no meaning. We do not compare a NT reading with a cutoff. We always correlate with the CRL and maternal age, and therefore accurate CRL measurement is a must, and correct maternal age is a must, especially if it's a donor embryo. We have to use the biological mother's age when we assess the risk calculation. So when I mean that NT has to be correlated with CRL and gestational age, this is what we can see. So suppose if the NT is say 2.2 millimeters, if the baby is younger, say at around say just around 11 weeks with a 45 millimeter CRL, the 2.2 millimeter NT can be more than 95th, 99th percentile. But at the same time, if you have an older baby and a younger mother, a 2.2 millimeter NT can be within normal range. Therefore, it has always to be correlated with CRL and gestational age. So an NT which is less than 95th percentile for maternal age and CRL, we call it as a normal NT. There is a terminology used as a borderline NT when it falls between 95th to 99th percentile, while any NT that is more than 99th percentile is called as increased NT. Some studies do use more than 95th percentile as a point to call it increased NT. NT that is more than 3 millimeters is always more than 99th percentile irrespective of the CRL, and therefore the options for these couple would be different. And this is what I mean to say. So NT more than 3 millimeters is always 99th or more than 99th percentile. Almost 4% of general population will present with a baby with NT more than 95th, while more than 99th percentile NT is seen around 1% of general population. In our data in Dinanath over the last 10 years, almost 15,000 NT scans were done, and this was our prevalence of babies with NT presenting with more than 95th percentile, around 4.4%. Now let's have a look at this baby, and all of you would agree that the NT looks bigger. Okay. So two mothers, one is a 38-year-old with primary infertility for 15 years, conceives spontaneously, and the NT scan shows NT of 4.9 millimeters. Another one is a 26-year-old young second gravida. NT shows NT of 5.4 millimeters. So what do we do now? So can we reassure parents that the baby is normal? And how much can we reassure a patient where the baby presents with increased NT? We all know that increased NT is associated with chromosomal defect, structural defect, cardiac defect, sudden fetal demise, and some rare genetic syndromes. But we also know that if the NT is normal, majority of the babies will be normal. If the NT is borderline, yet majority of the babies are going to be normal. While if the NT is more than 99th percentile, yes, the association with chromosomal defect or poor pregnancy outcome is high, but we still can have normal outcome. So increased NT, if it is chromosomal abnormality, yes, we can confirm or rule it out by doing CVS or amniocentesis. And for increased NT, nowadays we are recommending microarray because we can pick up deletion and duplications in microarray, which is not picked up by conventional karyotype. The structural and cardiac defects can be identified by a dedicated first or second trimester anomaly scan, and cardiac defects, yes, by first and second trimester fetal echo. So more than 80% of significant structural and cardiac defects can be picked up before 20 weeks of gestation. Coming to the fetal death, can be predicted? I doubt. But yes, these patients, they would need serial scans, even if all the prior investigations come back as normal. Genetic syndromes, again, there could be some subtle signs which we need to look for whenever we are scanning the baby. So management would be a stepwise management, and counseling of couple at every time when we see the baby is crucial. And we have to involve geneticist, of course obstetrician, and a fetal medicine specialist when we manage a baby with increased NT. So the first step would be look for additional markers. So this is a normal baby with additional markers will be nasal bone, normal nasal bone, absent nasal bone, normal ductus venosus, this is DV reversal, normal tricuspid normal tricuspid flow, this is tricuspid regurgitation. Nasal bone, yes, another good marker, but in first trimester we look for only presence or absence. We do not measure the nasal bone in the first trimester. It is around 1 to 4% of normal population will have absent nasal bone. It is more common if it is a younger baby, more common if the NT is increased, but almost half of trisomy, common trisomy affected babies will have absent nasal bone. If a baby with increased NT has normal DV and no tricuspid regurgitation, the management of that baby remains the same. The risk of cardiac defect in this baby, however, would be reduced as compared to a baby with increased NT and abnormal DV and tricuspid regurgitation. The risk of cardiac defect would be increased, and this would help us in counseling the couple. Coming to fetal heart rate, this is a normal fetal heart rate which we see. In trisomy 21, the heart rate could be mildly raised. The trisomy 13 affected babies will present with significant tachycardia, while the 18 affected babies will have mild bradycardia. Now, screening for structural defects, let's have a look at normal baby. So, just looking at the baby, I'm quite happy to know, bear in my mind that this baby is going to be absolutely normal. So what we can see is entire baby, that's the bladder, a good profile picture, good mid-sagittal picture. Normal NT, good mid-sagittal image, and we screen for any retro macrognathia, so this baby hasn't got retro macrognathia. So from the sagittal section we come to baby's head, and that's the normal well-ossified calvarium, midline falx, and a nice normal choroid plexus. From the head, if we go down, we'll be able to see two orbits with eye lenses, the pre-maxillary triangle. If it is intact, it would kind of rule out cleft alveolus or cleft lip. From the head go down, that was the heart, and that's baby's stomach. And of course the limbs, so we need to document all the 3 segments of upper as well as the lower limb. Okay. So when we know how a normal baby looks, then there are some abnormalities which can be easily identified in the first trimester, such as holoprosencephaly, we cannot miss it. Omphalosil, we cannot miss it, megacystis, hydrops, and of course AVSD. If we have a look at baby's heart, the basic cardiac assessment is possible in the first trimester. So this is a 4-chamber view, a normal 4-chamber view in a normal baby. Cardiac assessment can be achieved by abdominal as well as transvaginal scan. And the color flow, of course, helps us. We can see very nice two inflows across the atrioventricular valves. And this is nice confluence of the ductal and aortic arch. So this baby has got normal heart. Now coming to look for obvious cardiac, when we know that how a normal heart looks in the first trimester, let's see what this baby's got. So what we can see is a regurgitation across both the AV valves. This is tricuspid and mitral, and baby also has got VSD. So this baby had polyvalvular dysplasia. We can diagnose AVSD as well as obstructive severe lesions in the first trimester. Now, with increased NT with structural defects in the first trimester, yes, we know that the prognosis is guarded or poor, so it helps us in appropriate counseling the couple. Yes, there can be an option of termination of pregnancy, but the most important thing is post-termination full workup on the baby is essential because it will tell us the cause, the recurrence risk, and it will help us in management of future pregnancy. If the NT is borderline, the risk can be low depending upon what additional screening methods which we use, or the risk can come back as intermediate. So again, counsel the patient. Yes, there would be an option of NIPS or an option of confirmatory test depending upon what the patient chooses. So this is a basic flow chart which we normally use. So if we do a combined test with borderline NT and if it comes low risk, the next step would be do early anomaly scan 16 to 17 weeks if it is normal, then do serial follow-up scans till the baby is delivered. If early anomaly scan is abnormal, we offer diagnostic test, again with microarray. If it is high risk, diagnostic test. I've put a question mark for NIPT for a borderline NT because I personally prefer to offer them diagnostic test rather than NIPT. If microarray is normal, we go back to serial follow-up. If it is abnormal, we know that the couple would eventually opt for termination. And if all these investigations and all the serial scans till delivery are normal, then perhaps then we might be able to reassure them, but those babies would still need postnatal follow-up. Coming to NIPS, the patient needs to understand that it is a screening test. It has got cost implication, and if it is high risk, then diagnostic test is necessary. For babies with increased NT, that is more than 99 percentile, the normal outcome is still possible. And this is what I mean when I say normal outcome is still possible. So the steps would be similar, but in this subgroup, I wouldn't offer a screening, but I would offer a direct diagnostic test. So let's see what happened to our patient, the 38-year-old with an NT of 4.9 millimeters. So she had normal karyotype. We didn't have an option of microarray at that time. This was a 4-year-old patient. She had throughout normal scans, and she's got a healthy child who's 18 months now. And then she's pregnant again when she was 40. She opted voluntarily for amniocentesis and had a good outcome. And this mother with an NT of 5.4 millimeters, that is a baby, absolutely fine. Coming to last two aspects of screening, yes, we use the first trimester scan as a screening for spina bifida or open neural tube defect by assessing the intracranial translucency. This is the future fourth ventricle. And it can be seen in the same image that we use to measure NT. So this is the diencephalon, that is measure NT. Above the NT, the lucent space is the cisterna magna, and this lucent space between the cisterna magna and the brainstem is the intracranial translucency. So it increases with gestational age in a normal baby. And if the baby has got open neural tube defect, we get obliteration of IT. So this baby, we can see that the diencephalon has shifted down and we cannot see the IT. And thus open spina bifida in the first trimester. This is a coronal section, that is the sagittal section. Other signs which we look for in the first trimester is a thickening of the brainstem. We can measure the brainstem and occipital bone distance and calculate the ratio. And in the axial section, we have a look at the aqueduct of Sylvius. So this kind of rectangular space is the aqueduct, and if there is open neural tube defect, we can see the entire midbrain is shifted posteriorly. We cannot see aqueduct clearly, and the distance between the aqueduct and the occipital bone is reduced. So these are very good markers for a baby who has got open neural tube defect. And lastly, preeclampsia screening and early IUGR. Yes, we use uterine artery Doppler in the first trimester. The notch is not important. We give importance to the pulsatility index. If it is more than 95th percentile, we call it as an abnormal. Why use it in the first trimester? Because there is intervention available if the patient is screen positive, and the intervention which we all know is aspirin 150 milligram single dose at bedtime to be started before 16 weeks of gestation, because it is known to reduce the risk of preeclampsia, early onset preeclampsia by almost 50%. And the other good thing about uterine artery Doppler in the first trimester is it has got a very good negative predictive value, meaning if it is normal on both these sides in the first trimester, then I'm very happy for that baby. Yes, we can use it as a part of combined screening test if we have a facility of PLGF. Take history, take mean arterial pressure of the mother, do PLGF and uterine arteries Doppler. Because it increases the detection rate by 90%. However, PLGF, there is a question of availability and the cost issue. So I personally feel a first trimester uterine artery Doppler and the PAPE, which we do in combined screening test, they both do equally good as a part of screening for early onset preeclampsia and IUGR. So summing up, it is a crucial period to screen high risk cases. Ultrasound scan does play a pivotal role, and early diagnosis, appropriate counseling, and intervention, it will certainly help us in achieving a very good outcome for the couple. Thank you.
Thank you. Can we take some questions or in the end?
In the end?
Okay.
Okay, thank you.
Thank you very much. Thank you.
May I take this opportunity? I mean, Dr. Kinre sir has asked me to just pass on this message, because there is a IFUMB meeting next Sunday at Symbiosis Hospital. So Kinre sir has asked me to kind of pass on this message to you. Thank you.
Thank you.
Okay.
Aparna.
Thank you, Dr. Aparna. I think we'll take questions at the end, so she will have to stay put till for the next two lectures too. Our next speaker is on the topic biochemical markers, and it is Dr. Pooja Lodha. We all know Pooja Lodha. She is a fetal medicine consultant, and I think she needs no much of introduction, but still Welcome, Pooja.
Thank you, sir.
She is the director of Kangaroo Care Cradle, Fetal Medicine Center. And I think she's attached to a lot of institutes. I think she's also attached to Bharati Medical College. And yeah, the stage is all yours on biochemical markers.
Thank you so much, sir, for the kind introduction. Respected chairpersons, respected Dr. Parag, sir, and the whole team 2022-23. Thank you for this prestigious opportunity. Being the junior most, one of the junior most, and still being given this opportunity is really a huge privilege. Thank you so much, sir. Today I would like to speak on biochemical markers, but I request to keep it interactive because Aparna ma'am has laid such a beautiful foundation for the first trimester screening, and not much to talk about double marker as such in 15 minutes, but let's go through various case scenarios that we get from patients every day. So today I would cover screening and diagnostic testing. It seems ghisa pita, but as long as we don't understand the basics of screening and diagnostic testing, we will not be able to offer the correct test to our patients. We'll see how normal double marker is interpreted and how to counsel our patients, and we'll go through some abnormal double marker reports. So 12 weeks is a window of opportunity, but it all started with Professor Nicolaides going through the nuchal translucency in 1991, and since then it's grown, and a lot of things are covered at 12 weeks. Something that has been recently added over the last decade very regularly, even in the antenatal care in India, is the maternal biochemistry or the biochemical markers at 12 weeks, which is then combined with the ultrasound. Even before I start the topic, I would just like to mention even in low resource settings, such as even in Bharati Vidyapeeth, we've been able to implement a combined screening of double marker and a 12-week scan. It is possible in most of the resources. But in case it is not, please choose ultrasound over biochemical markers. Do not skip the 12-week scan and go in and do a double marker. The best thing is to do both and combine and assign a risk. But if not possible, suppose in really far-fetched rural areas, choose the ultrasound over the biochemical markers. Whom to screen? So whom do we screen? More than 35, more than 40? Great. Why do we screen all? Because although the risk increases with age, the absolute number of women that deliver under the age of 35 is way more than the elderly women delivering. So we see that the proportion of Down syndrome babies which are born in less than 35 years of age is way more than the elderly group. And therefore, we cannot pick and choose that this 20-year-old lady does not need to have a combined screening or an aneuploidy screening. It is a universal screening, and fortunately, most of us are now following it. So what do? We apply a screening test to the whole population. After the screening test is applied, we find two groups of people, patients. One is a low risk, which most of them are, and another is a high risk, which few of them are. And once this whole concept of high risk and low risk comes in, and then this is how an obstetrician has to appear in front of the couple, that it's very difficult to convey these numbers. At the same time, you are the decision maker there. So what do? Since this was a screening test, you cannot base your pregnancy decision on the basis of screening test, and you need to do a further diagnostic test. So finally, we did screening for all and diagnostic test only for those who came out to be high risk through the test. If the diagnostic test is normal, you prove normalcy. If it is abnormal, which means the fetus is affected. This is the screening for Down syndrome in the first trimester. Now, why just Down syndrome and why just so much of fuss about Down syndrome? Because it's the commonest reason for a mentally abnormal baby being born alive, and which is not correctable. So cretinism or congenital hypothyroidism is the commonest correctable mental retardation, but this is not correctable, and therefore, and they live as probably as much as you and me. So that's the worst part. The morbidity associated is very high, and therefore we screen for Down syndrome. There are two kinds of tests, screening and diagnostic. Screening tests are maternal biochemistry, which we'll cover today, which is double marker in the first trimester, triple marker is obsolete, and quadruple marker in the second trimester. Ultrasound markers, Aparna madam has already covered beautifully, and diagnostic test, depending upon the gestational age, 11 to 14 weeks is chorionic villus sampling, and after 16 weeks is amniocentesis. What is double marker? It is a test done for
assessing risks for trisomy 21, 13, and 18. What is the sensitivity? If you add age and double marker only, you pick up 65% of Down syndrome. But you add nuchal translucency, you pick up 90% of Down syndrome. So this is a very simple way of screening for chromosomal abnormalities. What is it? It's a simple blood test, and which tests for two hormones. We all know it is free beta HCG and PAPE. When is it done? After 10 weeks, but practically we do it with the NT scan. So 10 to 13 plus 6 weeks is the technical time when a double marker can be done. Who should be offered? Yes, it's all. Ideally, we will come to the MOMS concept, but we all know there is a MOMS that we need to read on the report, right, on the double marker report. Ideally, beta HCG and PAPE both should be one mom each. What happens in Down syndrome? The beta HCG usually rises to more than double, and the PAPE is less than half. So this is a typical trend in Down syndrome, not with the exact numbers, but this is the trend. What happens in trisomy 13 and 18 is that beta HCG and PAPE are extremely low. And when you all see risks of high risk for Down syndrome, high risk for Edwards syndrome, this is the reason why those patients come out to be high risk on the basis of biochemical markers. Now this is the complicated report that we all see every day after the lady comes back with the screening, the NT scan and the double marker. Now the labs, all the genetic labs have simplified by adding colors to the report, and you don't need to go in and read every number. What they have done is this. They were given green for a green signal that she is low risk overall. Intermediate is yellow or orange, and red means she is high risk. So here we see 3 green dots, which means she is grossly low risk. Okay? How do you counsel on the basis of this report? You get this report mostly just mentioning that you are low risk for chromosomal abnormalities or Down syndrome suffices, because when we scan the lady, we do tell her about what we are doing on ultrasound. And when this result comes, there are some couples who will ask you, what do these numbers mean? So you have to tell her that suppose this is a 30-year-old lady. Before, when she entered pregnancy, she had the risk of having a Down syndrome 1 in 603. So she was sitting in a room of 603 people, and she was one of them who could have a baby with Down syndrome. Since we did a beautiful ultrasound at 12 weeks, we combined it with a double marker, and everything is fine. We've been able to put her into a large ground of 6,300 people, and now she is one of them. So does that make her feel better? Yes, it does. So this is what risk reduction means, and this is a normal screening report. Now, what do we actually mean by MOMS? I will not go into the technicalities, but MOMS, or multiples of medians, which you see across the beta HCG and PAPE, is actually what the value should be for that age versus what it actually is. So suppose the PAPE value at 12 weeks is supposed to be 2800, but the patient's value is 1400, then the MOMS are 0.5. This is very simplistic. There are a lot of factors that decide the MOMS, and this is the whole list. I've put up this list because this is exactly the list that the labs want you to fill when the lady gives the double marker. So do not neglect any of these, because each one is contributing to the calculation of multiples of medians. You put in IVF and you forget to put the donor age, it causes a problem. You don't put in IVF, it causes a problem. You don't put in twins, or you don't put in the type of twins, it changes the interpretation. So since we are doing all this, let's all do it the right way. Now coming to the interactive session. This is a 29-year-old, a second gravida, 12 weeks and 3 days. She's got a normal NT scan. Do you all agree this is a normal NT scan? Yeah. And then double marker values. This is what it is. So do you think it's fine? Yes, President Sir, there are no mom values. We can just forget about the absolute values on double marker, and all we need to do is look at the moms, because the labs have already converted the absolute values into moms. So we don't need to put our head into whether 3000 is normal or 500 is abnormal. Okay? So the moms are 1.1 and 1. Are these normal? Perfect. So this is a very low risk screening. Now let's come to the timeline. This is a 29-year-old. She's 13 weeks and 6 days. The CRL is 84. She's had an NT. उस दिन पूरा दिन बेबी ने पोज नहीं किया, रात हो गई, सो डबल मार्कर नहीं दे पाई. नेक्स्ट दिन संडे था, फिर कुछ 14 जनवरी आया, फिर 15th जनवरी को उसने डबल मार्कर दिया. Is this going fine, or she should not have given the double marker, or she should still give it, or what's going on? Why she should not have given the double marker? Okay, who agree that the double marker and NT scan should be done on the same day?
Okay, we'll come to you all in a while. Anybody else has a reason why she should not have given the double marker? She is already 13 weeks and 6 days on the day of scan. If we believe that the baby is growing by 2 millimeters per day, she has become 14 weeks and 3 days or 4 days by the time she is giving her double marker, which she has crossed the boundary for giving the double marker, okay? So, we need not necessarily give the double marker on the day of NT scan. I'll come to why. But she should not have given it because she crossed 84 millimeters and all these values are very sensitive to the timeline. She did it and finally it was intermediate risk and the whole facade of whole trigger factor for the rest of the test started. So, okay. So, is this quote correct? There's never a wrong time to do the right thing? Not really. If you're doing the right thing, doesn't mean you can do it anytime. 12th of January, she's had a scan, the CRL is 38, the NT is 1.7, nasal bone is fine. And this is her report. She's come intermediate risk. Now what else? 1 in 446 is the risk here. What next? Can we just leave her alone? Anybody wants to do an NIPT? Anybody wants to call her back for an amniocentesis? Okay. Can we do an NT scan at a CRL of 38? 45 minimum, madam just told us, 11 to 13 weeks and 6 days. These are very time bound. So here it's nobody's mistake. If we accept a patient at 38 millimeters CRL to do an NT scan, it's our mistake. So the lady should be sent back. Maybe she is a delayed conception because actually she was 11 weeks. But the CRL is only 38 millimeters. So more than the weeks, 45 millimeters to 84 millimeters. This is what we need to remember. Okay, so this screening is invalid. Now the whole thing where we are all facing problems is the intermediate risk. Na yahan ke, na wahan ke. So how does it look? 1 in 405. Anything with a risk of more than 1 in 100, anything between 1 in 100 and 1 in 1000 is termed as intermediate risk. And why this was created? Not to create more confusion, but it was found that even these women who are getting a risk of 1 in 400 and 500 are actually coming up with babies who have Down syndrome. So we are missing this category if we find 1 in 405 and if we label it as low risk. And that's why a new category came in known as intermediate risk. Does not mean that all intermediate risks are abnormal. You have to go in and check what is it that is making her intermediate risk. Okay? How do you give risks? Never on ultrasound alone, never on double marker alone. You have to combine the NT scan with the double marker and give the risks. And if she is intermediate, find out why. Look at this report and why do you think she is intermediate risk? Yes, her PAPE is so low and her HCG is high. We just saw the trend. Is her NT normal? Very much, okay? So her nuchal translucency is normal, which means her scan is normal, which means there are more chances that the baby is actually going to be normal, but because of the double marker trends, she is coming as intermediate risk. And therefore this flowchart, which Aparna madam mentioned, I'm just adding biochemistry to it. Once you do a combined screening, you get 3 kinds of risks: high risk, intermediate risk, and low risk. If she is high risk, she goes in with CVS and amniocentesis, and I personally also completely agree with Aparna ma'am. Even in a borderline high nuchal translucency, prefer to go in for an invasive testing rather than going in and do an NIPT, because NIPT is going to tell us only about Down syndrome. There are going to be so many other things that we will miss upon getting a low risk NIPT result and be falsely reassuring. Okay, so low risk, just routine antenatal care. But if she's intermediate risk, let's find out why is she intermediate risk. Let's do early marker scan. If it's all fine, we can offer her an NIPT. If it's low risk, she goes under routine care. Let's do an ultrasound. If there are markers on the ultrasound, please offer invasive testing and not NIPT. Of course, if the ultrasound is normal and still the couple wants 100% assurance with the risk of 1 in 405, please go ahead and do an amniocentesis, because that is what the couple demands. But usually this is a flowchart that can be followed. If NIPT is low risk, well and good. If it is high risk, you still have to test with an invasive testing to confirm that the fetus is affected. The next case, now these are very quick ones. 30-year-old, primary, 12 weeks, 2 days. She is an IVF conception. Excellent NT scan. Any problems on the scan? It's normal. What is the problem on the slide? Why is her risk 1 in 257? She's got a very high beta HCG. And what do we do next? NIPT? Everybody loves NIPT. What else? I added on IVF conception. There would be a reason to give you a hint for that. We just heard a panel, जिसमें Veena ma'am, we wanted to give HCG every week to support the pregnancy, and that's what has happened to this lady here. Okay, so she comes into you, you give her an HCG, you send her out, give a double marker, and that's what you find on the HCG. So whenever you find only high HCG as one of the things on the whole screening, please ask for an injection of external HCG within the last 3 to 4 days or at least a week. Okay. Next one is a 39-year-old. 39-year-old, 12 weeks, 3 days. NT scan is normal. Everything is fine. Her age risk is 1 in 120. She is high risk? President sir is already. She is high risk for the age. Last 1 minute. She is high risk for the age. The risk has not yet been assigned. I have not even given you the risk. This is the risk with which she entered the pregnancy. It is not high or low. It depends on her age. The risk is actually very low because everything's come out to be fine here. So the age risk can never be high or low. The risk that is assigned after the screening is what needs to be decided as high or low. 41-year-old, IVF conceived. Is everything fine? Scan, double marker, all good? Perfect. 1 in 80 is still the risk. Abhi wo age risk to high risk nahi hai, 1 in 80 because she is 41 years old. But her risk is still 1 in 140. What do we do next? NIPT? Leena ma'am, how many 41-year-olds are you going to use her own oocytes? Sometimes they insist, but let's ask. So in case she has, yes, if she's insisted, NIPT is the best choice. So if her own oocytes have been used, NIPT is the best choice here. But more often than not, 40 plus, if we use a donor, please use the donor's age on the screening and not the mother's age. Now, just a last slide. This all appears green and low risk. Doesn't mean you leave the report here. Can anybody find out what needs to be paid attention to? The PAPE is low, and that's really an ominous sign, and I think Datta sir is going to cover a few things on low PAPE, but there are adverse outcomes that are related with a low PAPE, and we need to take care of that as well. Just one slide on the indications of NIPT, since har cheez ka answer NIPT ho raha hai, I just want to put in this one slide. Do it when there is advanced maternal age and normal ultrasound, when there is high risk for aneuploidy on combined screening with a normal ultrasound, intermediate risk with a normal ultrasound, or there is history of prior pregnancy with Down syndrome. So what is that one common thing in all these indications? The ultrasound has to be normal when you are offering an NIPT. Okay? So thank you so much. Beauty lies in originality, but the change is the only constant, and technology is a boon when used judiciously in aptly indicated cases with proper interpretation without compromising what is inevitable. Thank you so much for the opportunity.
Thank you, Pooja. It was a really nice, descriptive as well as interactive, clinical-based discussion. Thank you so much. Just one thing I'd like to say here is many times infertility patients, IVF patients are referred to obstetricians, and then in donor age is not written, it is not available. So it is better for IVF specialists to mention specifically about the donor age. That will make things easier.
That's true. Then we have to presume it's 30, which is right, not right. Yeah.
I request all the chairpersons to felicitate Dr. Pooja.
Pooja, that makes all of us very old. No.
I'm just trying to feel young, sir. You're not old.
Yeah.
So our next speaker is Dr. Chaitanya Datar. We all know him as a well-known geneticist in Pune who helps us in all difficult situations. He's going to speak on genetic counseling, when and how. Dr. Datar, please.
Thank you so much. Good evening to respected chairpersons and everyone in the audience. At the outset, let me thank POGS, Dr. Parag, Dr. Manjari for this opportunity, and also congratulate and my best wishes for the new term. So I'm speaking today on genetic counseling, how and when. So the process of genetic counseling essentially is to investigate individuals and families who are at a risk of having genetic disorders to help them understand and adapt to the various medical, psychosocial and familial implications of the disease. So here we are going to interpret the medical and family history and also going to educate them about inheritance patterns, testing, management, and how you're giving them informed choices as to what they should take based on the results available. So we have already discussed about screening. So essentially, if it's a low risk result, one thing that we must always tell them, this is a screening test. It will pick up about 85 to 90% Down syndrome cases, and it is not going to pick up all the genetic disorders. It's only mainly for Down syndrome. So that's one very important thing that we need to counsel these patients. Dr. Pooja has highlighted on the importance of moms. So any baseline moms, either they're going to increase or decrease. So essentially here what we are seeing, the first and major indication earlier used to be the risk of screening tests, but nowadays obstetricians, fetal medicine experts do the counseling by, so essentially, but what we need to look at over here is the MOM values. So in this particular case, you're seeing that the final risk is increased for all these three conditions. And look at the PAPE value is very, very low. It's 0.14. Even the NT is significantly elevated. So it's a third degree consanguinity with a high NT with scalp edema. So what we must understand, other than Down syndrome, there could be other conditions as well which can give rise to a high NT. Though 70% cases are going to be because of chromosomal aneuploidies, we must be aware of structural abnormalities, and more importantly, about 5 to 10% cases, it could be single gene problems like Noonan syndrome also. So it's a very common indication where there's a high NT. So in such cases, we must consider invasive testing when there is a high risk on double marker, any adverse marker trends that you are seeing, or soft markers or anomalies on the scan. And what should be the timing? So essentially it can be a CVS procedure in case there is a soft marker or a suspected anomaly, but if it is just a high risk and the scan is relatively normal, we can wait for amnio, because for chromosomes, amniocentesis is a much better sample. So this particular fetus turned out to be a trisomy 21. But in this particular case, what we find is that there was a minor deletion on chromosome number X. This was one of the older karyotypes, when we used to do karyotypes. Now all this is picked up on the microarray. So whether do a karyotype or a microarray, so essentially if you have a soft marker, an anomaly, previous bad obstetric history, or a very low PAPE which is less than 0.2, ideally go for a FISH and microarray. While if it's a normal scan, not so adverse marker trends, not a BOH, and if the patient has affordability issues, you could opt for a karyotype. Again, over here what we see is the 34-year-old lady with no consanguinity, it's a second pregnancy, NT is good, but the PAPE is very, very low, 0.18. Now this patient has an increased risk for trisomy 18 and 13 because of the low MOM values. They opted for an NIPS, and which showed a low risk for the common trisomies. Now, they were not very comfortable with the results, so they came for a second opinion. We opted for an invasive, and what we found is that there was a chromosome 17 microdeletion which was identified. They opted for an autopsy as well. So physically the fetus was looking very, very normal, but the fetus had a condition called Kulin-Dev-Rice syndrome. So it's a 17q microdeletion, and see the phenotype. It's more of developmental delay, intellectual disability. So something what is called invisible phenotype, which you do not see on the scans as such. So scans are normal, everything. So essentially any adverse marker trends, ideally we should opt for an invasive testing, even in this particular case. See the UE3 values. These two markers, PAPE and UE3 being very low, could be indicative of genetic syndromes as well. So chromosomal as well as single gene disorders. So this showed a high risk for Down syndrome, 1 in 117. They went for an amniocentesis, karyotype was normal. They continued the pregnancy. But ultimately the baby was delivered preterm and was diagnosed as a congenital adrenal hyperplasia. So we must be aware that whenever these markers are low, sometimes we have to counsel that there could be conditions other than Down syndrome that we may be looking at. Then we are looking at various soft markers. I'll just discuss one of these examples, an unossified nasal bone. So what we know is in about 2% of normal pregnancies, the nasal bone may remain unossified. About 50 to 60% may be associated with Down syndrome, but 10% could have single gene problems over here. So essentially what we would do is if the nasal bone is absent or is not seen well in the first trimester, we are going to rescan at around 16 weeks. Now this particular patient, it's a second pregnancy, nasal bone was hypoplastic. The trisomy 21 risk was 1 in 899. And what we found here, there was a duplication in one of the chromosome 9p23 region, and this would have led to a phenotype which could have caused intellectual disability, autism, and a developmental delay. So essentially, but this is a new variant which had occurred, and therefore the risk of recurrence is low. But see this particular case, it's a non-consanguineous, the nasal bone was absent on DNT scan, it was hypoplastic at 16 weeks. The pregnancy, they opted to discontinue the pregnancy because there was mild knuckle edema which was seen. And after autopsy, you can see the absence of the nasal bone, and this patient turned out to have a OTUD5 gene mutation. Now this has very high risk of recurrence. This is X-linked disorder, so almost 50% males are likely to be affected. So whenever we are reviewing these markers, we have to review them very carefully for the next pregnancy. Now essentially we have discussed NIPT in great detail, so Dr. Pooja has already highlighted this particular part. What is important that this NIPT is essentially for Down syndrome. It gives an accuracy of almost 99%. It's not a wholesome test which is going to give us information about various other disorders. So it's good as an individual choice. Age-related risks, a very good test here. Screen positive results, but those who are not wanting to take the risk of invasive, they can go for this. But it's not a test of choice whenever there are soft markers or anomalies. Very, very adverse marker trends of especially PAPE and UE3, multifetal gestation, but nowadays, except now in twins, it can be done. Fetal reduction vanishing twins, you can give some time and you can have the sample collected. And very, very importantly, it is not a screening test for single gene conditions, because we have seen prescription NIPT for thalassemia. As of now, it is not available. But yes, in due course, it may come in. Now, when the pregnancies are to be considered for discontinuation, like the products of conception testings as such, then which test should we prefer ideally in these circumstances? So one thing we must understand, fish gives us information only about 5 chromosomes. Karyotype in most of these cases becomes difficult because it requires culture. So most of the time what is going to happen is the bacteria are going to grow and we are not going to get a good tissue. So essentially microarray is the test of choice when we are doing the products of conception testing. The reason being 2 things. One, it is going to detect the microdeletions which are going to be missed on the karyotype and fish. And secondly, it gives about it doesn't require culture, so the success rate is almost nearly close to 100%. And it gives about 15-20% more information than a karyotype or a fish. So for example, this particular patient, 37-year-old, at 13 weeks she had lobar holoprosencephaly. We are knowing that it's mostly associated with trisomy 13, but here you can see that there was a very small deletion on chromosome 2p21 which had one of the genes which caused a holoprosencephaly. So these cannot be picked up on a karyotype. So therefore the role of microarray. Then sometimes what happens is some pregnancies, they are abnormal and overall we have to continue them for some reason. So essentially now this particular patient had one previous IUD. She came with a second pregnancy at 24 weeks with subdural hygroma, pleural effusion, subcutaneous edema, so on and so forth. A very poor prognosis was explained, but it's important that we tell them that they need to consider further investigations on the sample. The reason being we have to guide them for the next pregnancy. So if it was done in the earlier pregnancy, it would have helped prevent this recurrence. Now this particular patient had a MuSK gene mutation which has a very high risk of recurrence, almost 25% in the subsequent pregnancy. Then occasionally we do get cases wherein now this particular case at 34 weeks, the USG was suggesting oligoamnios, there was ventriculomegaly, there were calcifications, hepatosplenonephromegaly. The baby was delivered by C-section and passed away in the few days' time. No investigations, considering it was a torch infection, no investigations were done. And the next pregnancy too, she landed up with the same issue. Now we know that torch is not going to recur. So essentially, when this particular fetus was discontinued at around 19 weeks, we considered autopsy, we did the chromosomes, everything was normal. But it turned out to be something called as pseudo-torch syndrome, or it's called Aicardi-Goutieres syndrome, which has a very high risk of recurrence again in the next pregnancy. So essentially, calcifications may be associated with many, many single gene conditions as well. So all this has to be explained during counseling, and it's important to tell them that this is essentially to prevent recurrence in their future pregnancy. Now sometimes patients are going to come with some medical history. Now this lady who has come with a pregnancy, she is diabetic since 13 years on oral hypoglycemics. She was diagnosed as a type 2 diabetes, the MODY type, and she also has renal cysts. Now if there is a combination of these, we do know that there is a condition which is called as renal cysts and diabetes syndrome. Now when this lady was investigated, she showed a deletion which incorporated this HRF1B gene, and there was a 17q microdeletion there. Now she is at a 50% risk of transmitting this to the baby. So we investigated her during the pregnancy, and we could offer a prenatal diagnosis to prevent recurrence. So maternal medical history also sometimes is very, very crucial. So sometimes we do get polycystic kidney disease, which has a very high risk of transmission. So we must be aware of these conditions as well. Risk due to family history. Here there is one child who passed away because of spinal muscular atrophy. His maternal grandfather was diagnosed at the age of 55 with spinal muscular atrophy. Now things don't end here. Essentially, some other members in the family, you can see the significant consanguinity in the family, and these two members wanted to marry. And both of them are carriers for the SMA gene mutation. So essentially they would be at a 25% risk because it's an autosomal recessive condition. So looking at the pedigree properly and thoroughly evaluating that pedigree helps in picking up such syndromes. Another case like this, wherein this lady comes at 12 weeks, the indication was she came with a high NT, which was about 3.3 mm at about 12 weeks. So essentially the dual markers were apparently low risk, but when asked about it, she had a brother who was intellectually disabled. So I just happened to ask for a photograph. Now you would all agree that there is significant dysmorphism in this child. So suspicion of a genetic condition was made, and we considered a trio testing for the three individuals, that is the fetus and the husband and wife. The wife turned out to be a carrier for this particular, the ATRX gene, and the fetus was found to be affected. So if it would have delivered, it would have led to a recurrence of that similar condition, which is an X-linked mental retardation with hypotonic facies syndrome. This child looks relatively quite well, and essentially there was no consanguinity, and the parents wanted to know about the risk of recurrence. There is no major dysmorphism as such, and MRI was also suggestive of some hypoxic ischemic encephalopathy. But strangely, this child did show one of the genetic mutations, and it led to something called seizures and microcephaly syndrome. It had a 25% risk of recurrence. So sometimes if the parents are wanting to evaluate, we can give them the choice and the options to consider investigations, because you land up sometimes with issues like this. If the babies as such, our previous children are not available, still we can consider testing in couples. So parents do come early, and they would want to consider evaluation, and we can test the couples for carrier status. In this case, we had some history available, and the genetic testing showed that it was a propionic acidemia. So after proper correlation, we could confirm that this was the mutation which caused the 2 neonatal deaths, and we could offer a good prenatal diagnosis for this family. Now, most of the times there is a question regarding autism as to how to investigate children with autism. So we usually would divide it into syndromic and non-syndromic categories, but the detection rate of autism is not that high. About 20 to 30% may have, especially the syndromic category, you'll reach a definitive diagnosis. And once you have a diagnosis, like in this particular case, this girl had a syndromic autism with autistic features as well as neuromuscular features, and it was a condition called megaconial muscular dystrophy, for which we could offer a prenatal diagnosis. A very important question, when to evaluate and why to evaluate. If possible, evaluate preconceptionally, but at least if the patient has come to you with the first antenatal visit, even if they come at that time, we do have some time in hand, say about 6 to 8 weeks in hand, to consider investigations and offer them invasive testing on time. Thalassemia counseling is very, very common, and we can offer a good panel. It's a very small panel by which we can offer a prenatal for the couples, and it is not detected by NIPS. The other thing is a teratology counseling, wherein many patients would come for intake of various drugs or exposure to radiation, wherein we have to evaluate a lot of things, but evidence is lacking as such. Then a pre-test counseling. So whenever these patients are coming they want an amniocentesis for this particular variant, but it's actually not the causative variant. So upon evaluation, what we find, I'll just finish. So it's not a causative variant at all. So we have to be very sure that the causative variant is actually the one which has led to the disorder. The other thing is now this patient came to me with this particular karyotype report of a translocation between chromosome 7 and 13, and this was a lux. It was not because of the translocation 7-13, it was because of mucolipidosis that this particular child had this neurodisability. So we cannot offer a prenatal based on this particular issue. Then importance of post-test counseling. Essentially the two children, there was two children were lost here. They came with a pregnancy and there was a homozygous mutation, which was, it's just the last slide. A homozygous mutation was identified for this SLC22A5 gene. Now this leads to a condition called primary systemic carnitine deficiency. So this is a treatable condition. Now the parents did not want discontinuation of pregnancy, so we gave them the option to consider antenatal carnitine, and now this child is around 1 year, he's doing absolutely fine. So the take-home message would be an early referral is what is required. So various indications is what we have discussed. In the era of genomics, a proper pre and post-test counseling is essential to really understand whether the variant is really causative of the disorder or not. And ideally, no family should be left without an attempt to genetic diagnosis in the era of genomics. Thank you so much.
Thank you, Dr. Datar. I think an excellent presentation, and if there are any questions now, I think after we do the felicitation, if the President permits.
I request all the chairpersons to felicitate Dr. Chaitanya Datar. I request Dr. Parag Biniwale to come up on the stage and felicitate all the chairpersons. Dr. Savita Mehendale. Dr. Harshar Parasnis. Dr. Vaishali Beniwale.
And now we start with the next session, which is again a very important session. Very rarely we come across discussing topics about perinatal mental health. And today we have eminent speakers to elaborate on that topic. Before we start a session, may I request our next chairpersons to come on dais. Dr. Anand Bhalerao sir and Dr. G.S. Shekhawat sir. So my request chairpersons to please proceed with the session.
Session of a day one of our POGS CME, and at the onset only I would like to congratulate Parag and his team and wish you all the best and very successful year ahead, and we are expecting very high programs from your side. As I told you that day that I would be very happy if you take more of a practical obstetrics than of some other topics. Of course other topics are also important, but then should concentrate more on obstetrics. Right. So let's start with the first speaker.
Jyoti Unni, please come. Importance of mental health in obstetrics. Jyoti Unni is the Director of Department of Obstetrics and Gynae, Jahangir Hospital, Pune. She is a very senior obstetrician and gynecologist. And if Jyoti remembers, our trip to Israel was one of the best trips which Dr. Nargolkar had organized. And we had an excellent time there in the Israel for 10 days, which was called as the POGS study program and all these things. So, Dr. Jyoti.
Okay. They seem to have lost my presentation. So, yeah, okay. Yes, thank you. First of all, congratulations to Parag and the whole team. And also thank you very much for asking me to talk on this subject, which is very important and which I have learnt a lot about while trying to prepare this talk. And as our chief guest, Padma Vibhushan, Mr. Kelkar said this morning, we seem to neglect it quite a lot. And antenatal problems of mental health are something which we know very little about. So it is not only in our country, but it's neglected globally also, because there has been a focus on physical health in the antenatal period. And there is a reluctance amongst most of us to discuss mental health, and we lack the training to inquire from women what their problem is. Now, unfortunately, psychiatric illness is overtaking hemorrhage, hypertensive diseases, venous thromboembolism as a cause of maternal mortality. So it's really a time to wake up. The Embrace 2015, which is the UK maternal mortality survey, has got mental health as a leading cause of maternal death. And we don't have to look that far. As you all know, Kerala, with Dr. Paili at the lead, has been doing maternal mortality audits for close on 10 years. And the Why Mothers Die, which has been published this year, shows that in 2019, even in Kerala, suicide was the highest, the leading cause of maternal mortality. So we need to, it's a call to action before this happens in all our states. WHO defines maternal mental health as a state of well-being in which a mother realizes her own abilities, can cope with the normal stresses of life, can work productively and fruitfully, and is able to make a contribution to her community. So, as with physical health, mental health is not merely the absence of mental illness, but reflects a capacity to adapt and cope. And the WHO has said that MDG 4 and 5, which you can now translate to the Sustainable Development Goals, cannot be achieved without good maternal mental health. The prevalence is reported as about 10 to 20% of pregnant women. This, I'm not talking about postpartum depression or psychosis, just in the antenatal period. And commonly in the antenatal period, it's depression, anxiety, which affects women. And this has been traditionally thought to be something of the Western world. And it was thought that in low and middle income countries, it's not really seen because of the traditional cultural practices and the fact that the family is there to protect, it doesn't happen. But now data is coming from these countries as well, and it is seen that there are certain risk factors. The teenage mothers or the very young women from the religious minority, women who have undergone a lot of partner abuse or conflicts with their in-laws or parents. If there are adverse reproductive outcomes, like for example, several miscarriages or an intrauterine death or a stillbirth, or in fact even artificial reproductive technologies. And of course, what we know already is women with past mental health problems. Now, we are quite well aware that postpartum depression has a negative impact on mother and baby. But what is not so well known is that antenatal depression and anxiety can also lead to adverse obstetric outcomes. So there could be poor nutrition, inadequate weight gain, irregular antenatal care, placental insufficiency, preterm labor, and low birth weight. And more than that, children of mothers who have depression or anxiety are more susceptible to ADHD and emotional problems. So it will affect the next generation as well. So is it time for us to integrate mental health into maternal health care? Certainly it appears that it is. The perinatal period is the most vulnerable time in a woman's lifespan as far as her mental health is concerned. And there are challenges to the introduction of routine maternal mental health screening in India, but they are not insurmountable. So ours is a large and diverse country, and a major problem which we all know has been there even for maternal mortality is that healthcare is a state subject. So there are wide variations in the provision of care. Centrally, the national programs are really good, but how they are implemented in different states is so different, and that is how care is also different and outcomes are different. So the single plan may not work countrywide, so we need to develop our own plans wherever we are working. There is a lack of awareness not only amongst us obstetricians, but many other healthcare professionals. And so we all need to be sensitized. The other big problem is that there is no suitable screening tool which is validated and that can work in all settings, whether public care, private care, mothers in urban and rural areas, and mothers with varying literacy levels. And though some of the screening tools have been translated, we might not be able to actually use them directly translated because our cultural practices are different. But there are some promising developments. Everything is not just dull and grey. There is an increase in the coverage of the district mental health program. There is an integration of maternal mental health into the RCH program in Kerala, which is really very great. And the Mental Health Care Act of 2017 is very good in that it mandates mother-infant joint care when a mother is admitted for mental illness. Earlier, if a mother was admitted for mental illness, it meant that her child would be taken away from her. And then those children would grow up troubled and with mental health problems. So just a little bit about the district mental health program. It started as the National Mental Health Program in 1982. And then it was found that it's not really being implemented because it's a central project. So under this scheme came the District Mental Health Program in 96, and it was started in 27 districts, extended to 100, and now in 123 districts. And NIMHANS, which is the key institute in Bangalore, is providing training to undergraduates as well as public health workers so that at the primary healthcare level, they can recognize these patients. This is a fantastic initiative by the Kerala government, which is called Amma Mansu, which is Mother's Mind. This started because there was an RCT which was done on community-based depression, and they found that it was effective in reducing the severity of depression. So this was taken up by the government, and a statewide maternal mental health program was done, where mothers are assessed during their routine antenatal and postnatal visits by trained junior public health nurses. Referral pathways were established. Doctors who are trained under the DMHP program were there to assess them further. And there is a mother and child tracking system which is supposed to be working nationwide, but probably again works very well in certain areas. So seamless care is provided for such mothers because online they can track these women. And now the National Health Mission is considering replicating the integrated maternal mental health care model into other states in India, and we do hope that happens very quickly. As we heard very well in the panel this morning, preconception is an excellent opportunity to look at these women and assess their mental health also. Traditionally, we are looking at nutrition, weight management, optimizing medication, immunization, folic acid, but this should include mental health screening. And if there are women with mental health disorders, we must stress that they should not be taken off medication. What often happens is that either when they get married, they don't want the in-laws family to know that they have an illness, so they stop taking their medication, and that happens even with things like diabetes and hypertension, let alone mental health. Or somebody will tell them that this is not safe in pregnancy, so they go off the medication. So we have to stress that they must stay on the medication and arrange a review by the psychiatrist or psychologist so that if possible they can be shifted onto medication which is safe in pregnancy. Now, how to begin the conversation is important. The first encounter should count by establishing the rapport and ask simple questions. It is common to develop anxieties. Do you have any? Pregnancy and childbirth are a difficult time. Do you feel you have a low mood? You can ask other questions like, do you have concerns or anxieties? How is your sleep or appetite? Now, depression is seen in almost 12% of antenatal mothers and anxiety is in 13%. So besides the normal screening tools, these couple of very simple questions. For depression, in the past month, are you feeling low, depressed, little interest in doing things? And for anxiety, in the last 2 weeks, have you felt nervous? Have you not been able to stop worrying? There are easy things which we can ask. There are several screening tools. I don't have the time to go into all of them, but the Edinburgh Postnatal Depression Scale is what is commonly used. And 3, 4, and 5 are what are used for anxiety and depression. So I'm just showing you what the questions look like. I've blamed myself when things went wrong. I've been anxious or worried for no good. I have felt scared or panicky for no good reason. And they're scored as 0 to 3 with yes most of the time, some of the time, not very often, no or never. So it's important to first do an antenatal screening early. And a score of 13 or more needs detailed assessment. Anxiety disorder is common, so we need to inquire at every visit. And you recognize by taking a history, looking at their speech, mood, seeing whether they need help and they're compliant with their medications. So we can give them simple advice when they're not when they're in the early stages, like sleep hygiene, managing hyperemesis, importance of gentle exercise with social interaction and self-reflection. Paternal mental health is again very important because the whole family is important, and fathers may have other things like they are easily frustrated, they use work to escape the home, they have problems with sleep and self-control, they may go into alcohol or substance abuse, and they may deny their problems. So although screening and detection is important, they are only useful if interventions can be provided, so we need to train doctors. So in conclusion, an obstetrician can play a key role at this time by opening the conversation. It empowers the woman to talk, and it increases our awareness and reduces the stigma in recognizing and accepting mental health concerns so that we facilitate timely help-seeking behavior. Thank you very much, and I recommend you to go for this course if you are interested in further. Thanks.
Thank you, Jyoti. Thanks for your excellent review about the mental health in obstetrics. You are stressed quite well about the importance, especially of the family history taking and her status in the family, because that itself really might make her to have some emotional issues later on. Thank you very much, Jyoti.
May I request Dr. Jyoti Madam to join on stage, and may I request chairpersons to felicitate Madam.
Now we invite second speaker. Topic is psychotropic medication, teratogenicity and beyond. Dr. Sonia Parial. She is a leading consultant psychiatrist and director at Dhanvantri Hospital, Raipur, Chhattisgarh. Sonia Parial, ma'am.
At the outset, I would like to thank you all for giving me the opportunity to speak on this very important topic, teratogenicity and beyond in perinatal mental illness. Now, if you look at the word teratogenicity, basically it's a Greek word which means malformation. So it's any chemical, substance or exposure given to the pregnant mother that may cause birth defects to the developing fetus. Teratogenesis basically is formation of an abnormal embryo. And teratogenicity is the ability to cause defects in a developing fetus. Thalidomide was the first molecule which was found to be teratogenic, and it alerted the scientific fraternity to using drugs which can have teratogenic effects. And in fact, psychotropic drugs, most of them fall into FDA category C, and some of them do have teratogenic potential, and hence we need to be aware of it. Now, what are the factors that determine the effects of teratogeny? One is the dose which reaches the fetus. Secondly, the time of pregnancy during which drug exposure occurs, and the duration of exposure. Now, the effect of a teratogen on the fetus can be spontaneous abortion, malformations, which can be major or minor. It can cause intrauterine growth retardation, can also lead to mental retardation, and at times it can have carcinogenic effects and also cause mutagenesis. Now, how does a molecule be functioning as a teratogen? There are a lot of mechanisms which are being implicated. It can be due to affecting folate antagonism. It can be due to the vascular disruption. It can be due to specific receptor or enzyme-mediated teratogenesis. It can be due to neural crest cell disruptions. It can be due to endocrine disruptions. It can also be due to oxidative stress. So a lot of mechanisms have been implicated. But in case of perinatal mental health issues, we have to be very aware that our client who's mentally ill, in them, exposure is going to occur both due to the treatment and also to the illness. It becomes quite challenging because we know that if we don't treat the illness, we are going to have significant impact both on the mother and the fetus due to the illness. And at the same time, we also know that some of our molecules can have teratogenic potential. So let's first have a look. What are the effects of perinatal mental illness on the mother? A mother who's mentally ill can be abusing substances, and these themselves can be contributing to teratogenicity. We also know that some of the complications and misattribution of physical symptoms of life-threatening complications like pulmonary embolism can be implicated to mental illness. Many a times our clients are victims of interpersonal violence, and if the illness is not treated, it can lead to suicide in the mother, and at times the mother can also have infanticidal thoughts, and it can lead to infanticide. That is quite worrying. So that's why we need to be aware that if you're not going to treat the illness, these are all the issues that are involved. Similarly, untreated mental illness can also have an effect on the fetus. There can be a premature delivery. The mother who's mentally ill can give birth to a baby with IUGR. The infant and child adolescent outcomes are also worrying for us because recent research has shown that mothers of perinatal mental illness can have emotional difficulties and social development in the infant, and the infants can also have externalizing difficulties like ADHD, oppositional defiant disorder, and conduct disorder. These infants may also have attachment disorders because the mothers who are ill may not bond well with their infants, leading to even cognitive delays in the infant. So these are very worrying aspects that we all need to be aware that if we don't treat, so many implications are involved. There's also, it has been found very clearly, like I'd already mentioned, that maternal mental disorders have a clear incidence in effect on child development. The symptoms can vary. You can have a wide range of symptoms and illnesses during pregnancy, which vary in type, timing, and severity. But it is well found that any kind of maternal psychological distress is often accompanied by higher rates of smoking, alcohol, poor diet, and lifestyle. And it's also accompanied by metabolic and functional changes that may influence the fetal development. Distress is also associated with elevated maternal stress hormones, like a hypercortisolemic state. And the enzymes like ACTH and adrenaline also can be raised. And this can definitely have an impact on the fetus. So these are all the areas that we need to be aware of as treating obstetricians and psychiatrists when we are dealing with women with mental illness. Of late, recent research in Australia, it has shown that most women are using molecules which have teratogenic potential, and psychotropic drugs are quite high in that. In fact, all the 3 trimesters, they have found that a good number of women are using these molecules. And we know that all our psychotropic drugs are lipophilic, and they pass through the placenta and are present in the amniotic fluid. And the degree varies between drugs, individual drugs, though we don't know individual drug variation to that extent. But yes, there are variations in the amount of exposure that can occur, and which has to be an area of research. It has been found that nearly 21 to 33% of established pregnancies have an exposure to psychotropic medications, which can have a teratogenic potential. Like I had mentioned, the timing of exposure is very important, because if it's the exposure to a teratogenic molecule is early in pregnancy, it can lead to major structural defects. If it is later in pregnancy, it can have minor structural defects. As you know, that valproate has been linked to developmental delay and autistic spectrum disorder when there's late pregnancy exposure. And if it is earlier, then it can cause neural tube side effects. Similarly, there can be preterm delivery and abnormal fetal growth. And at the same time, at delivery, you can have neonatal toxicity and neonatal withdrawal syndromes. And in the postnatal period, you can have cognitive and behavioral effects. But what we all need to be aware is that the illness itself can also cause these same very effects, because what has been found is that there are so many confounding factors. A mother who's mentally ill, she is the one who can be using substances like alcohol, which can have its own teratogenic potential. So before attributing a teratogenic potential to a drug, we need to be aware that the illness itself can be causing these very same side effects. So there lies the challenge of treating mental illnesses. So if you go back to neuroanatomy, the basics, we very well know that the time after conception to implantation is 8 to 10 days, which is called the all or none period, which implies the exposure to any harmful agent of the embryo would either yield to spontaneous abortion or intact survival. In the embryonic period, that is 54 to 60 days, organogenesis takes place. And this is the most sensitive period of the embryo to teratogenic insults, resulting in structural malformations. So the first 3 months are very crucial. As we know that psychotropic drugs like, say, lithium or other valproate, if the exposure has already occurred in the first 2 months in unplanned pregnancies, it is quite sensible to know that the exposure has occurred, go in for a quick screening to find out if there is an abnormality, and do not stop treating the illness if she is exposed to a severe illness. So we need to be aware of these basics of neuroanatomy. Similarly, the fetal period just starts after organogenesis and continues to term. Teratogenic exposure during this period usually leads to disruption in function or size of the organs. Now, valproic acid, as I had mentioned in the first trimester, can cause neural tube side effects. Paroxetine had been implicated. There were studies which previously said that there is 2.5 times the risk of heart defects in paroxetine exposure in the first trimester. But luckily, larger studies have now started questioning these findings. When better statistics were used and the confounding factors were eliminated, it was found that paroxetine is much safer and it may not be causing these heart defects. And if a mother has responded to these molecules, you may be able to use them. Similarly, for lithium, Epstein's anomaly, cardiac malformations were implicated, but now larger studies have shown the risk is much lesser than it was previously thought. Similarly, carbamazepine is also can cause teratogenosis. So it is best to avoid molecules like valproic acid, carbamazepine in the first trimester. Similarly, lithium, though the risk is lesser, if you can avoid it in the first trimester, try to avoid these molecules in the first trimester, considering their risk for structural teratogenesis. Similarly, perinatal syndromes of drug intoxication or withdrawal can occur, especially in the third trimester. So, if you have been using benzodiazepines, many of our patients have sleep disorders or anxiety disorders, and they are exposed to benzodiazepines. So we should be aware that it can cause sedation, respiratory depression, or withdrawal. Similarly, SSRIs, if there is exposure, especially in the third trimester, you might see withdrawal symptoms, though they are quite mild. 30% of infants can have withdrawal symptoms, but we are happy to tell that they are much milder and they are treatable. Though, if there is a mother who has been exposed to SSRIs, it is always better to have a hospital delivery and observe at least for the first 72 hours. Another very difficult side effect that's persistent pulmonary hypertension. Molecules, SSRIs, especially which like sertraline or other SSRIs which have been exposed in third trimester, can lead to PPH. But now newer studies have found that the risk is much lesser and it may be more lower with SNRIs. Now, FDA had, divided our molecules into categories A, B, C, D, X. But this category system is quite hierarchical and can have its own limitations. Now, if you see, most psychotropic drugs come under class C. That is, some risks, benefits may outweigh the risk. But now FDA in 2015 has suggested a newer way of labeling, which is called the new pregnancy lactation labeling. This is a good system in the sense that it requires a narrative explanation of the risks associated of the illness and also the supporting data. So you have a risk summary, you have a clinical consideration, and you have the current data about the molecule. So this kind of labeling is a much better way because it helps the client make better decisions once they come to know what is the risk of not treating the illness and what are the risks involved due to the molecule. And there, the knowledge will be updated by the pharmacist. Though this is an ongoing process, not fully complete, but it is a better way. Like I had mentioned, that patients who have already been exposed to teratogenic molecules, say like lithium or paroxetine, it is advisable that they be given an anomaly scan opportunity, a fetal echocardiography at 18 to 20 weeks, so that we can detect these abnormalities if they are there early. So you need to suggest screening to your clients so that they can avoid the birth of a child with a serious abnormality and help them make decisions that suit their socioeconomic, family, and emotional situation. But it is necessary to understand the advantages and limitations involved in these procedures and also other options that are available. And you should give the couple the choice to take their own decision and make an informed choice. Now, most of the times as psychiatrists, we are quite worried that if an exposure has occurred, but we also know that the illness needs to be treated. You need to follow certain general principles when you're treating. That is, educate the women about a planned pregnancy, educate about contraceptive measures, educate about a healthy lifestyle, and try to avoid teratogenic molecules right from the beginning, especially like valproate or carbamazepine. If an illness is newly diagnosed, try to avoid all drugs in the first trimester unless benefits outweigh risk, and try to use an established drug at the lowest effective dose. Similarly, if a woman is taking psychotropic drugs, is planning pregnancy, consideration should be given to discontinuing treatment if there is a high risk of relapse. If there is mild risk, you can discontinue. But if there's a severe mental illness and there's a high risk of relapse, do not discontinue, rather switch to a safer molecule. If a woman taking psychotropic discovers that she's pregnant, abrupt discontinuation should be avoided. Consider remaining with the current medication rather than switching to a new drug. But if a drug like valproate there is an exposure to valproate, it is advisable to stop it. Always go in for preconception counseling. It is good because you can explain that there are baseline risks of congenital malformations in absence of a medication. A normal outcome to pregnancy can never be guaranteed. The spontaneous abortion rate in confirmed early pregnancy is 10 to 20%, and the risk of spontaneous malformation is around 2 to 3%. So you need to go for a detailed family history. High-risk pregnancies should be identified. Try to give periconceptional folic acid supplementation in advance. Control maternal diseases like diabetes and counsel the patients about the teratogenic effects of the possible anticonvulsants or other psychotropic drugs that women might be taking, and impart the rightful education and awareness to prevent congenital disabilities. Hence, to conclude, I would like to say, mental illness or medications used to treat them both pose risks to the mother and the child. We need to provide a balanced view of risk and benefit to our clients. The relative importance of various risks and benefits will be different for each patient. Treatment patient decisions may be very different for each individual, for which a trust and a good working relationship between the patient and clinician is critical for this decision making to treat the mental illness or not to treat it. Thank you so much.
Only thing we are missing here is that which is the safer drug for all the specific diseases. Like if there's schizophrenia or depression or there's anxiety or seizures, that perhaps is not mentioned here. And previous madam has, I think it is my personal feeling, if we have to include in our all antenatal cards one line for the mental health. Now it is like in abruptio we always underestimate the blood loss. Similarly, I think we are underestimating underestimating the mental disease. So this column should be there so that our resident interns, they do not miss out this particular thing. Now, next speaker is
Jyoti Shetty. Yeah. She is a professor and HOD in the Department of Psychiatry, Bharati Vidyapit Medical College and Bharati Hospital Research Center, Pune. Dr. Jyoti Shetty.
Change the slides. Yeah, we can. No, not that. It was on.
Thank you very much at the outset for inviting me to speak at this important conference. At the outset, I would congratulate Dr. Parag Biniwale for becoming the president of POGS. And hello to Dr. Menley also and all my colleagues out here. I think Dr. Lodha is not there, but then I think we have had an interaction where we refer for fetal medicine to Dr. Lodha, who comes to Bharati also. I think the question raised was that, more questions would arise as to what are the drugs that are safe in pregnancy. Considering the first two speakers have actually covered quite a lot of what I was supposed to cover, I think I will be, sort of skipping over a lot of slides. And maybe the interactive part, which is, basically I think the concerns of obstetricians is what is safe in pregnancy, what is safe in the lactation period. That is something that we can focus more on. So coming to what the topic given to me was postpartum depression. So this is an illustrative case that we had seen, that I had seen in a maternity home. So she's a 34-year-old lady, 13 years she was married. She had had several IVF cycles. In fact, she was saying that she had almost 20 cycles in the past, I think, 10 years. She conceived twice. In 2013, she had conceived again through IVF. She had a miscarriage a few months into the pregnancy. On consultation, this was about a few months ago, she was 7 months pregnant. She had symptoms suggestive of depression. So this started after her mother-in-law died due to COVID, when the patient was about 5 months pregnant. So when I saw her, she was already 2 months more depressed. She was crying. She was extremely anxious. She was referred because she was not sleeping at all. She used to stay awake. She used to keep troubling her husband. The husband had become stressed because she used to keep getting anxious, calling him from work. He was a businessman. They used to earlier work together, and then it was almost like not only was he also grieving for his mother, the patient was grieving, and they were also not being able to go back to their normal routine. And this was a very precious pregnancy. This was a pregnancy which had come after 20 cycles of IVF. So they were very, very anxious. She also had a lot of guilt over the pregnancy. It was almost like, she felt like everything happened because she became pregnant. So there was a lot of guilt. There was almost a hostility to the coming child. Though, of course, she did say that it was with mixed feelings because it was something that was very precious. They had waited for so long. But she was wondering whether, after so long, there seemed to have been so many troubles. And this is something that we see in our society, a good event coupled with a bad event, which was coincidentally, unfortunately, that stigma gets carried over to the good event also, in this case, new birth. So there was guilt, there was mixed feelings. She also had history suggestive of very brief depressive spell. She said for a few days she used to feel sad, but it used to be okay, and she used to feel better.
of course, she also had premenstrual dysphoria. So she had in the late luteal phase, she had 2 to 3 days where she was very irritable. She used to be very, very, what she said was chidchidi. She used to snap at her husband. She used to feel very low, very sensitive to any sort of criticism. And of course, this used to subside after the onset of menses. So she had these brief spells which went on. And apart from that, she was also a very perfectionistic person. She was very anxious. She was very perfectionistic. So when I saw her, she had severe anxiety on presentation with low mood, sleep loss. She didn't have any significant family history. She was also on thyroxine for the past several years. She was on 50 micrograms. She was well settled on it. The husband was a very supportive person. So we had, when we say postpartum depression, what we see in most cases, it's a continuum. It's not that, it's only in a first case scenario. It's not only that the patient for the first time presents with depression. There may have been other symptoms in the past which may contribute. Probably the personality, probably family history factors which contribute for the patient to present with depression. So in this case, I think diagnostically, according to ICD-10, should probably fit a diagnosis of recurrent depression. She was started on sertraline at that time. She was better. She continued for a few weeks because the period was very important for her because it was during the time of her God Bharai. So it was during the, the baby shower rituals. So she had to be well for that period. She continued and then she stopped. She felt very concerned about taking medications in pregnancy because she had read a lot. So she stopped because of that. She again had a relapse of similar anxiety symptoms just before her due date. So in late pregnancy, she had a relapse of these symptoms after a few weeks. And this continued even after delivery. So she continued to have a lot of anxiety. In fact, at that point, the husband was tired. He was like, now what does she want? Because it was a very healthy baby girl who was born. Everything had gone smoothly. She didn't have any problems. It was, the third day or something, and she continued to cry. She didn't sleep at all. She kept everyone awake. So obviously a call was given in distress. And the husband was like, I can understand so far, but now I don't. So when Dr. Unni focused on, paternal mental health, I think it is important because this actually case signifies to a large extent the whole symposium. Not only is it perinatal, you have had symptoms in the past, a person who's susceptible, a person who has symptoms in the pregnancy, there is postpartum symptoms also. Apart from that, there are also, the latter half of the symposium will be on perinatal loss and grief. And here we are seeing something like perinatal loss. So not only was it about the loss experienced because of the failed IVF, it was also the loss following the miscarriage, which was, via IVF. So, which is why I wanted to elucidate this case because it sort of holds most of the symposium together. To continue, when we are talking about perinatal psychiatry, I don't want to sit and go back to what Dr. Unni actually elucidated. It obviously involves preconception counseling, perinatal care, postnatal care, psychological care in traumatic births, stillbirths, miscarriage, psychosocial support for partners and family. As I said, this husband really needed support himself, which was what was advised. Of course, they didn't follow up. Improving mother-infant interaction and bonding. This is something that has come up, which is new and which I will elaborate a little bit later. And of course, liaison with multiple disciplines, whether it is obstetricians, whether it is the neonatologists, and of course, fetal medicine also. So, going back to the statistics, I won't again repeat too much. 1 in 5 experience some sort of perinatal mental illness. Only 50% are diagnosed, which is unfortunate because this is a very treatable illness. 10 to 25% of them have perinatal depression, 25 to 45% perinatal anxiety, 50 to 85% have baby blues. Now, when we are talking about depression, postpartum depression, we divide them into baby blues and postpartum depression. And of course, postpartum psychosis. Baby blues is something that comes within a few days of delivery. It's a very mild form of depression. It's just feeling sad, feeling a little unhappy, feeling a little tearful. it subsides within a couple of weeks. But when these symptoms persist, it persists more than 2 weeks, when the person continues to feel low most of the time, can't sleep, gets up in the morning, feels as if, life is not worth living, has suicidal ideas, may also have ideas of harming the child, and has a lot of anxiety, and also has problems with appetite, libido, anything, all socio-occupational functioning is disturbed, that would be major depression in the postpartum period, postpartum depression. When we are talking about postpartum psychosis, of course, when a person has disorganized behavior, has a lot of, probably psychosis in terms of delusions, hallucinations. It could also be a person who's coming with postpartum first episode of depression, which could be an indicator of a bipolar illness. Bipolar depression is notorious for relapse. It's notorious for being resistant to treatment with only antidepressants. So it is important to diagnose postpartum depression and also clarify whether this is the first episode of bipolar disorder. So when we are talking about baby blues, this is something that subsides over time, and a majority of women have that. 2 to 3% will have a bipolar disorder, as I said, cycling depression with mania. Postpartum psychosis, as in a psychotic disorder, is much less. Of course, what we have seen is that COVID times has increased, some increase in depression and anxiety because of lack of access and the anxiety related to the pandemic. So depression is more than low mood. I don't need to go again into it. I think what we had a couple of months ago was this distressing news of CM of Karnataka, ex-CM, Yadurappa's granddaughter dying by suicide, and which was supposed to be because of postpartum depression. So despite routine contact, why I wanted to just mention this name is, irrespective of which socioeconomic class you are and the avenues of access to healthcare, despite routine contact in the healthcare system, which happens in maternal healthcare, where a person usually follows up very religiously with the obstetrician, there is still a failure in detection and treatment of mental health conditions. And this is something that is unfortunate, and a lot more could be done. So this was one of the systematic reviews and meta-analysis, which was conducted by a community medicine department. And what they found was postpartum depression in India was 22%, and the risk factors as stated here: financial difficulties, birth of a female child, marital conflict, lack of support from the family, high parity, multiple pregnancies, complications during pregnancy, low maternal education. It was also seen that it was more in the urban areas than rural. Now this could be a little bit of a problem, because it could be the way the meta-analysis and the studies were done. It could be that in urban areas it's picked up more, postpartum depression, so perinatal mental health probably has much more symptoms being picked up, so hence it's reported more. So probably the skew because of that, and south more than north. And what we have seen is there has been much more training, probably because of NIMHANS having done with the South Zone, as Dr. Unni had put up. There have been much more training, much more state initiatives also. In fact, Dr. Sonia has a state initiative which is in Chhattisgarh. She's Raipur based. So she has been training the Mitanin. She's a private psychiatrist, but she's been liaising with the government health system and training the Mitanins in picking up and screening for maternal mental illness.
Madam, last 1 minute.
Yeah, okay. Yeah, I'll just rapidly go through 2-3 slides, and I think I'll just wind up. This is a study that we did using the EPDS. What we also found was that, in our study, out of 100 patients, 14% were depressed. Barring that, of course, most of the risk factors were almost the same. So perinatal depression is prevalent. There is an absence of active identification strategies, and they neither receive nor seek help. And of course, with regards to medication, I would like to say is that when you do RCTs for psychotropics, pregnancy and lactation is a exclusion criteria. So you are not ever going to take patients who are pregnant or lactating into trials. So which is what all the data that comes is from real time, probably phase 4 and 5 stages. So these are the recommendations that ICOG does, actually, American, the thing of obstetricians. They advise using standardized tools like the EPDS, PHQ. I won't go into the details. So coming to what is there, as I said, when we have anxiety in pregnancy and depression in pregnancy, it obviously forecasts a lot more problems for the mother and the child in future, not only with relapse of pregnancy-related mental illness, but even growth, as Dr. Sonia was elaborating. I think another factor which is very important is that when we are talking about Indian statistics of suicide, it is the most in the reproductive age group, which is why it is important to pick up depression, because these people are not identified, they are not addressed. So the risk of suicide, self to harm and self to the baby is much higher, which is what Dr. Jyoti Unni also talked about, the EPDS, you know, that item number 10 is actually about picking up suicidal ideation. And then obviously, you know, assessments are done in detail if the score is between 10 to 13. So these are the risk factors. As I said, I won't go into it. Assessment, again, most of us are familiar with it in terms of looking into the family history. Why I illustrated that case was because most of the factors have been assessed in that case. Barring that, I just wanted to go back to, you know, something about Marseille. I think, can we go to the previous? No. Can we go to the previous slides, please? There are just 2 lines I wanted to talk about. No, before. No, before this. No, you're going ahead. Yeah, no, go ahead, behind. Behind. This. Okay, so why I wanted to bring up Marseille was, this is an international society which actually has psychiatrists, psychologists, nurses, obstetricians, everyone on board. So anyone can obviously be part of the society, and their position statement states that these are these 2 questions, which they call the Woolley questions. It's actually what Dr. Unni also stated. Having been depressed for the past month and having no pleasure in activities for the past month. These are 2 important questions which any of us can ask. It is something that you can do even while you're doing your, you know, while chatting or examining, which is something that can identify whether the person has symptoms suggestive of depression. So impact, I think we won't go into it, that it impacts the mother and the child. Untreated depression is obviously a risk for both the child and the mother. This is just something about self-management, which is related to nutrition, exercise, sleep, rest, time for self. Most of us promote all these positive coping strategies, and partner support is very, very important. Management is in pregnancy, obviously, Dr. Sonia talked about. In lactating mothers, SSRIs are something that can be given, and SNRIs too. Tricyclics are very safe in lactating mothers. We won't go into that. Barring paroxetine, though there is now evidence that it's not so unsafe, antipsychotics are in the category C except clozapine. So when a patient with, you know, your question about schizophrenia, when a patient who has schizophrenia becomes pregnant and has been on clozapine, we would advise to continue. The risk of relapse of schizophrenia is probably seen as much more harmful for herself and the baby than continuing on clozapine. So that is about antipsychotics. Apart from that, when you have to start antipsychotics in pregnancy, olanzapine, quetiapine are some things, especially olanzapine, the 2nd generation antipsychotics, are deemed to be safe. Of course, we have to, you know, probably look at the fetal birth, the birth weight, the fetal weight, the mother, because, you know, olanzapine, I mean, mostly 2nd generation antipsychotics cause a lot of metabolic problems in terms of weight and lipid profile. Barring that, benzodiazepines obviously are category D. We try to avoid them as far as possible as mood stabilizers. Lamotrigine category C could be started. Barring that, obviously, you know, these are the benzodiazepines below, which are category S, which are always avoided. Apart from that, in lactation, we look at the relative infant dose, which has to be less than 10%. You encourage, obviously, breastfeeding, you don't stop it. We also don't say that we have to discard the milk after a few hours of taking the tablet. It's not required. Co-sleeping is obviously avoided. Mother-infant, especially, you have to monitor if the child is low birth weight. So you don't give clozapine, you can monitor lithium. Sertraline is better than fluoxetine. Fluoxetine is a longer acting SSRI and it gives a higher RID. SSRIs and SNRIs otherwise are relatively okay in lactation. Barring that, I think valproate they say is okay in lactation, but then once you have stopped in pregnancy, we don't usually restart. It's always avoidable, like the NICE guideline says, to avoid valproate completely in the reproductive age group. And of course, lorazepam amongst the benzodiazepines is considered safe, although we try to avoid.
Madam, your time is up.
Yeah. So I'm not going to go into this. Just a little bit on, I think I'll wind up by talking about ECT in suicide. In suicidal depressions is something that's effective. Barring that, I think what I would like to talk about is this drug, which is a newer drug, which is an intravenous drug which is given over 60 hours, but of course it's not FDA approved but not come to India yet. It's allopregnanolone, which is found to be effective in PPD. This madam has already mentioned, so I won't go into the COPE and the knee studies. And I thank Dr. Sonia, and I thank you all again for giving me a patient listening.
Thank you, madam. Very well covered. But this is a very complex problem. Recently, we have seen 2 patients, they are coming with overdose of quetiapine as well as olanzapine. Because drug is available with them and there's some marital disharmony in the house. They take the overdose, then you have to inform the police, make the medical legal. So it is always essential for obstetrician to try to screen out these cases in the first trimester itself. Thank you very much. Now, last speaker.
May I request chairperson to felicitate madam.
So, last session of the day, Dr. Aslila Bagadia, she is okay, already there. Handling perinatal grief and losses.
To talk about this very sensitive topic at REPLETE 2022. Today, I'm going to cover what are the tasks of grief, not just for the patient, but as obstetricians, what are the things that we have to make sure that we navigate, help them navigate. Now, when a patient comes and encounters grief or encounters a loss, what they really have to go through is to cross a stage of accepting the reality of the loss, experiencing the pain of the loss, adjusting to a new environment without the lost baby, and to reinvest in the new reality. And this is not something that is going to be happening immediately. It's going to take some time. What are the tasks for the obstetrician who encounters such a patient at the moment of the loss, or just when they're about to experience the loss? The task for the obstetrician is to, first of all, handle a possible emergency situation, or encourage the family and the patient to make a decision, which will be very difficult, and to again encourage a process of shared decision making. The biggest task, of course, is breaking bad news and then navigating grief. If you think about it, the scenarios in which you might encounter grief or loss for the patient may be divided in 3 ways. One is someone who comes to you suddenly with an emergency, with not having had any previous risks. So they're not prepared, you're not prepared, and it can be completely an abrupt situation. Or you may know a patient whom you monitored for a while, it's a high-risk pregnancy, you've known the risks, you're somewhat prepared, they are somewhat prepared, but there has been hope that they may be able to overcome this. And the hope is shattered now and they're coming in that situation. Or there was probably a hope, or you're not sure what was going, and then you're encountering an unviable pregnancy where some difficult decisions have to be made. So all these situations are possibly the kind of situations you're going to encounter patients where they may experience grief or loss. So as I go through the next few steps, think about scenarios that you might have experienced and how you might have handled it. You may have come across what we call as spikes. It's a acronym that we use to help clinicians figure out how to best break bad news or talk to patients when you're helping them navigate grief. So think of the acronym as spikes. S stands for setting up the scene. So think about who is going to deliver the news. It's really important to spend a couple of minutes deciding who is going to tell the patient, the family members, who is the one who has had a rapport. It's really, really important to think about it because it's very uncomfortable for them suddenly to be told something by a radiologist who they not know at all. And also think about who is receiving the news. Are you telling something to the mother who then has to tell the daughter? Or are you going to have to tell something to the husband? Should you have both of them in the room? Would it be better if you had one person, primed them, and then invited the other? So it's really important to spend a couple of minutes, discuss with your team to set up the scene. How are we going to do this? Should we have a quiet room? Where are we going to do this? Because that few minutes taken will really go a long way. The next letter stands for perception. Now, you know that you have seen many patients with different levels of understanding, medical knowledge, even their understanding of health and risk and, outcomes. So understanding the patient's perception, what is their perception of the situation, how much are they likely to blame you, how much are they likely to blame themselves. Also, not just the patient, but the husband and the family. How much are the husband and family likely to blame this patient? You should not have eaten this, you should not have ran, you should not have done this. So assessing the perception is really important. That will also help you to decide of setting the scene and who are you going to include in the initial conversation. Always obtain the patient's invitation. So it should not be just that you're giving them information to kind of invite and say, I'd like to talk to you. I have some difficult news. We need to discuss this. So you invite and set the scene a little bit, but deliver the news without beating around the bush. That's really important. But deliver the news as succinctly, as simply and empathetically as possible. Then wait. Wait for them to ask more questions. Then deliver more information when they're ready. You can sort of gauge them, wait and see how they're responding. Maybe they need to talk to each other. Maybe they may be scared. So deliver a little bit of the news, the most important news, and then wait. Once they are able to process that, check if they're okay for you to go on and go to the next step, which might be thinking of next steps of what to do next, or the risks if they do something, or giving them pros and cons. So ask at every stage before moving on. You have to kind of gauge the patient's level before you move to the next step. The next letter is K, giving them knowledge and information. So the knowledge and information is to start with a warning shot, like I said earlier, but be honest and precise. Be aware of your own inhibitions. It's really important to know that, some kind of news are difficult for you to share. So prepare for it. Talk to your seniors if you're a junior doctor, or talk to your colleagues and say, this patient I was so close to, I think I'm going to break down if I'm going to talk to her alone. Maybe take someone along. So be aware of what is going to be difficult for you to share. Most importantly, especially for patients who might have, had a botched up care in some other hospital, they come to you and you're trying to fix them, but you can't. Avoid blaming colleagues or blaming the patient. You should have come earlier. Those kind of things can at that moment not be helpful. Later on, when you're sitting down and figuring out what could have happened, that's a different thing. But at the time of delivering bad news or talking about grief or helping them through the loss, it's really important to avoid blaming the colleagues or the patient. And of course, this, I think, all the obstetric colleagues that I know have this in loads, addressing them with empathy. Empathy is really important when you are navigating loss and grief for the patient. Because as much as this is a patient's loss. I know that, the colleagues that I have worked with, this is their loss as well. So this is your loss as well. So you recognize and acknowledge the emotions that they're feeling, validate the emotions they must be feeling, and give them time to express it. If they're angry, you don't have to sort of agree that they have a right to be angry, but you can acknowledge that, yes, you can see that this is something that can make them angry. You can use sentences like, I can see this has been very unexpected news. I'm sorry to have to tell you this. I was also hoping for a better result. So you're kind of sharing that this is difficult, like you can see it, but you're also not sort of saying, I can understand that it is sad for you, because you may never be able to fully understand their experience. What you can see is what you're noticing. Most importantly, give them time. Another thing is, when you have kind of delivered the news, you've talked about it, you're kind of waiting for them to fall apart, they've cried. Once you wait, you can ask the patient, like I said earlier, are they ready to hear the next steps? If they're not ready yet, you can say, okay, why don't we do this today evening? Maybe when your parents are also here. We do need to talk about what's going to happen next. And ask your patient which family members are they okay to include. And you'll be surprised who they want in the room, and do take their consent into consideration. And then also that will be something for them to focus on. Okay, what do we need to do next? So strategy and summary comes in the end. Remember, the flow has to be SPIKES and not, in any other order, because this will really help them and help you navigate this initial process of when they hear the news, or when they're being told about something that they've lost, or they might be coming and sharing it with you, but you need to now explore, what are we going to do next? Just a few things about perinatal loss. What are the factors that actually may impact on, how the patient reacts or the family reacts? And we know, of course, that the later the stage of the pregnancy, or, the older the age of the infant, the harder it is for the mother and the family. So it's really important to remember that may be harder rather than the first trimester, but not to dismiss that the first trimester loss will not be important. Also, sometimes for parents, it's really important to have a mental image or internalization of infant. If they don't have enough expression of grief or time to mourn, family members sometimes expect them to quickly move on. No, don't show them the baby. They won't be able to move on. They should plan another pregnancy. Otherwise, they won't be able to move on. So if they don't have enough expression of grief or time to mourn, then they will find it very difficult. Now, chronic grief is something important to remember, especially if you're seeing women who may have experienced loss before and may either be jumping into a next pregnancy or planning pregnancy. It's important to think of these things in mind, because it will impact them during the subsequent pregnancy. If they're left with a feeling of guilt or shame, have a very low self-esteem, are yearning for the baby, which doesn't diminish, that yearning just doesn't go down even after they've had other children, and they have unresolved feelings towards the spouse or other family members. And remember, death of a child is extremely hard to recover. Be gentle. The basic points I want to leave you with is that you can't manage their emotions. They have to tolerate them, and they have to manage them on their own. They have to ride the wave of distress with your presence. You can validate their emotions. You can acknowledge that they can feel shock, denial, anger, and they will have to reach a stage of acceptance. And always start from the beginning when you're seeing the family. Validate the emotions. You don't have to validate the behavior. Again, like I said earlier, avoid words like, I understand how you feel. You need to be strong. It'll be all right. Don't use jargon and statistics during this time. See how well he or she is handling it. Very important to have self-care. Always have a colleague for support somewhere. Manage your emotions and debrief with someone after every session if you can. It's also useful to have some group discussions. If you've gone through a spate of losses, then take some time out to look after yourself. I'll leave you with this last slide, that bereaved parents never forget the understanding, respect, and genuine warmth they receive from caregivers, which can become as lasting and as important as any other memories of their lost pregnancy or their baby's brief life. So it's important that what you're doing is being their companion and not really trying to fix anything for them. So they want you to just be their companion when you're sharing the news with them and this moment of acute grief for them. At that note, I will stop the slides now. I hope we can have a discussion. Thank you very much for your attention.
Thanks a lot, all the speakers. I think they have done very well on the mental health of mother and various problems related to it. One point which I really liked, which Dr. suggested or Chairperson has suggested, is that of adding the mental health column not just of a patient, but even of the family member, any family member, including the past history, of course. That might really help to some extent in solving this particular problem. And thanks a lot, Parag, and all POGS committee members on the behalf of both of us for giving us this opportunity. Thank you very much.
Hello. So the reason why we thought of having this particular program was I did attend one of the courses which was conducted by AICC RCOG South Zone, and ICOG had endorsed it. So as the secretary of ICOG that time, I did attend it's a 2-day course, but then I thought, we should at least have a glimpse of it. It is a topic which has not ever been discussed in our meetings. So, and I must thank Dr. Jyoti Shetty, who happens to be my friend for last 40 years. She currently heads the department of OBG at Bharati. So she was very prompt in responding. And when we were identifying obstetrician, who would talk about, the obstetrician's role, I could not have asked for a better speaker than Dr. Jyoti Unni. So thank you, both of you. And Chaitanya, please present a memento to our chairperson.
Please do join us for tea in Majestic 2.